Very good morning. Sudhir, are we live?
Yes, madam.
Okay. A very good morning to all the delegates to another exciting day of Appec. Today is the day 6, and today we have a very important session on critical care, which many young anesthesiologists are joining day by day. And there are so many advances which are happening on a daily basis in critical care. I'm sure you will enjoy the day with us. Without wasting further time, let us begin with our first session, which is on mechanical ventilation. To chair the session, we have Dr. Rananji Chatterjee, sir, with us. Sir is head of the critical care and accident and emergency at Swami Dayanand Hospitals. He has his area of interest are CRRT, ARDS, and helmet NIV. He has lots of achievements to him. He is a fellow of Royal College of Physicians. He is a fellow of Indian Academy of Clinicians. He has been awarded with Rashtriya Gaurav Award, COVID Warrior Award, Chikitsa Ratan Award. He has an Academic Excellence Award from IMA, ISA. He has the Presidential Citation for ISCCM, and he has various chapters in national and international journals and books. We welcome you, sir, and we would like you to introduce our first speaker for the day.
Thank you, Dr. Anupama. First of all, I congratulate the whole team to host such an excellent program, and especially online, so that many people can join here, can learn from here. I've seen the topics that you have selected; they're excellent, and we are also learning from it, because it's a learning experience for all of us. Even the faculty, they are also joining in this learning phase, and the whole team of Ram Manohar Lohia Hospital, including obviously Dr. Nija, yourself, and others, definitely deserves a due credit and acknowledgement for this fantastic program. So I will, first of all, without wasting time, I will introduce Dr. Akhil Taneja. I don't have his CV with me, but I know that he is the director of critical care in Max Patparganj Hospital, and he is running a very big, successful ICU. He is also a secretary of ISCCM Delhi branch, and numerous papers and research works in his credit. And Akhil will be starting on a topic that is the basic modes of mechanical ventilation. Over to you, Dr. Akhil.
Thank you, sir. Thank you. Thank you for the introduction. So, good morning, everyone. I'll just share my slides. Okay. I hope it's visible to all.
Yes, it is visible.
Okay. So very good morning to all the delegates, and thank you very much to the organizing team for including me here. Now, it's always good to connect with young clinicians. It will be an interactive session today, and you feel free to ask any questions or give your opinion for that. So the topic to start with is basic modes of ventilation and non-invasive ventilation. Now, to be fair, these are two different kind of topics to me. I'll just try to cover them both. So first we go with basic modes of ventilation, and what are basic modes of ventilation now? VCV and PCV. So these two modes, and we can finish this talk then and there only, and we can have a full stop over that. So moving with that, what is the outline for today's talk is spontaneous versus positive pressure ventilation. What do you need to know about the basics of breath delivery in both of these? What is the role of equation of motion? What are the basic modes of ventilation? And finally, we go to non-invasive ventilation. So this is a brief introduction. Andrew Vesalius, he was an anatomist in 16th century. Now that was the first official a description of mechanical ventilation, that a opening should be made in trachea and a tube should be put into it and the lung may rise again. Now, that was the first official introduction to mechanical ventilation. Nearly 400 years later, in polio epidemic, when we had a surge in respiratory failure, the positive pressure lung inflation devices were used, and that was the beginning of modern positive pressure ventilation. So, what is spontaneous ventilation? We have inspiratory phase and an expiratory phase. Now, inspiration is an active process, and expiration, it is a passive process. So, as the diaphragm and the intercostal muscles, they contract, they perform all the work. The chest cavity is expanded and inspiration occurs. As the muscles they relax, the expiration occurs. So, inspiration is a active process, expiration is a passive process. And what are few pressures at the level of mouth opening? You can call it pressure at the airway opening, that is zero pressure or the atmospheric pressure. Then we have intrapleural and alveolar pressures. Now, intrapleural pressure is a negative pressure between the pleural space. It could be -5 to -10, depending on which phase of respiration you are in. And alveolar pressure is called as intrapulmonary pressure. That is a negative pressure varying from -1 in inspiration to positive in expiration. So when we have a airflow, there should be a pressure gradient. So now try and understand what is happening here. This is the alveolar pressure. As it goes negative, inspiration occur, breath is delivered. And as soon as the alveolar pressure becomes positive, +1, and the airway opening pressure is 0, the air flows out and expiration occurs. So this is how the movement of flow occurs during. Yeah. My pointer is visible? Okay. So moving forward, what is positive pressure ventilation as compared to spontaneous ventilation? This is forcing the air or oxygen into the lungs. So at all the times, all the pressures in the airway are positive. So when we had a negative pressure in spontaneous breathing, in positive pressure ventilation, we have a positive pressure throughout the respiratory cycle, that is during both inspiration and expiration. Now, when we are forcing the air into the oxygen, what is the source for this energy? It could be ventilator or patient. What are a few control variables that we need to know? The pressure, volume, and flow, the phases of breath delivery. Now, what begins the breath, how it is delivered, and what terminates the breath. This is what we call as phases of breath. And finally, we need to know the characteristics of breath. Is it a mandatory breath, a assisted breath, or a spontaneous breath? We will look into the details of these. So this is a diagrammatic representation of what is happening in the positive pressure ventilation. What I would like you to note is, look at the alveolar pressure and look at the pleural pressure. Although pleural pressure and alveolar pressure both are positive during inspiration, intrapleural pressure is negative in exhalation, while alveolar pressure is still positive. So, by convention, pressure at the level of alveoli is always positive in positive pressure ventilation. But then, how much pressure? How much pressure to inflate the lung? And what is the source of the energy for this pressure? That we need to look in. So, for that, we need to understand the few lung characteristics. So, to inflate the lung, we need to oppose two kinds of forces. One is elastic force, which is the inverse of compliance. So what is elastance? Elastance is the property of a object to come back to its original shape. So when we are trying to inflate the lung will try to come back to its original shape. So if elastance is high, the compliance is low. That means it will come back heavily to its size. It will be a low compliance lung. So we need more pressure. If the elastance is low, we can inflate it with lower pressure. So other is the frictional forces. So as the air flows in the uh, endotracheal tube, there is some resistance to gas flow through the airway. So we need to overcome the resistance as well as elastic forces to inflate the lung. So that is the pressure. required to inflate it. So pressure required to overcome the resistance, and the elastance is the inflation pressure at the upper airway. So this is the pressure that we need. But then what is the source of this pressure? So we can look at this equation, the P mus plus P vent equal to PR plus PE, where P mus is the muscle pressure and P vent is the ventilator pressure. Then PR is resistance pressure and elastic recoil pressure is PE. Now try and understand what is happening here. The muscle and ventilator together are generating a pressure which must overcome the elastic forces and the resistive forces. So muscles, diaphragm and intercostal muscle, that is the patient, vent is the machine. So patient and ventilator together are generating this force to overcome the resistive and elastic properties. So what the energy production, both by muscle, when are we using our muscles? That is in the spontaneous breath. And when the patient is paralyzed, it is only the ventilator which is working. Total amount of pressure depends on the physical characteristics of respiratory system, that is the elastance and airway resistance. If respiratory muscles are inactive, that is a paralyzed patient, all the work will be done by ventilator. Now, a different number of combinations of muscle power and ventilator power can be used to achieve total force required during assisted ventilation. That is the crux of how the mechanical breath works or mechanical breath is delivered. So, who will choose where the pressure is generated? It is we, the clinician. We can paralyze the patient and P mus is zero. We do not paralyze and P muscle is active. On the ventilator, we will choose what pressures to be delivered, what volumes to be delivered. We'll come to that. So this is all about basics of breath delivery. So how mechanical breath is delivered? What are the variables for this? One is control variable and then there are phase variable. So you can look at these things not as troublesome, complicated jargon, but actually it's a dish. You can say we have an onion, we have a tomato, we have some vegetables. So these are onion, tomato, and vegetables. Now we need to prepare a dish with these kind of ingredients. So we need to understand the ingredients so that our dish is better. So coming to control variables and phase variables. What are control variables? The primary variable the ventilator adjusts to achieve inspiration is called as control variable. A ventilator can control four variables at one time: pressure, volume, flow, and time. Now it is four variables, but not together. Ventilator can control only one variable at one time, and pressure and volume are the most commonly used control variable. Now, using this language, ventilator can control one variable is slightly misleading. Actually, it is we who are controlling the ventilator. So we can control one variable at one time, not the other one. And actually, we have to worry about the other one. How come? We'll look into it. So we now remember this equation, the muscle power, the ventilator power, overcoming elastic and resistive forces. Now converting this in equation to elastance and volume plus resistance and flow. This is what we call as equation of motion for mechanical ventilation. So the beauty of this equation is that we can control only one part of equation, either the pressure side or either the volume side. And then we have to worry about the other side. So what is happening here is if we set pressure, we demand ventilator to deliver a pressure of say 25 centimeter water, then that is something is a control variable. This is the pressure controlled mode. Control variable is pressure. Now at that pressure, whatever volume ventilator can deliver will deliver based on the elastance and resistance of the airway or patient's mechanical dynamics. So we can control the pressure, but then we have to worry about the volumes as per the elastance and the flow. We can set the volume, that will be a volume control mode. We can set a 450 ml of tidal volume to be delivered, but then we will have to worry about the pressures, the other side of equation. So the rule is we can control one side of equation and then we have to worry about the other side. In a low compliant lung, delivering a 450 ml of tidal volume will have higher pressure. In a highly compliant lung, delivering a 450 ml of tidal volume will have a lower pressure. So that is where the art of mechanical ventilation comes into play. So pressure controlled ventilation, the clinician sets a pressure for delivery to patient, also called as pressure targeted ventilation or pressure ventilation, volume controlled ventilation when the clinician sets a volume for delivery to patient, also called as volume targeted ventilation or volume ventilation. Now look at these two curves. Try and understand what is happening here. This is a comparison of VCV and PCV. So these are three curves on each side, which you routinely see on your ventilator screen. On the top is a pressure time curve. In between is a flow time curve. And in the lower panel is a volume time curve. What is happening in PCV? Try and see this. There is a constant pressure delivery. Every time a breath is delivered, the pressure is constant. But at that same pressure, if you see the volume curve, the volume is varying. In the first mark, it is approximately near 500 ml, then overshooting it, then going below. So depending on the lung characteristics of compliance and resistance, at same pressure, variable volumes are being delivered. This is what we call as pressure controlled ventilation. And if you look at the middle curve, it is the flow time curve. Now, when you are looking at the ventilator screen only curve that is going below the baseline is a flow time curve. So flow is positive, then negative, positive, and then negative. Positive flow is inspiration, negative flow is expiration. So descending ramp flow pattern is the hallmark of pressure controlled ventilation. As you see this curve, you identify, okay, this is a pressure controlled ventilation going on. Now compare that with the volume controlled ventilation. The constant flow in the middle panel, the green one, stable inspiratory flow. This constant flow is the hallmark of volume controlled ventilation. But then also you see that constant volume delivery is occurring with each breath, but the pressure time curve in the upper panel in VCV is varying with each breath. So in volume time, we are controlling the volume irrespective of the pressure. In pressure control, we are controlling the pressure irrespective of the volume. So coming to our next part, the breath delivery, the actual breath delivery. What are the phases of breath delivery? One is the trigger. Something that initiates a breath is what we call as trigger. Then there is actual delivery of breath. What controls this delivery of inspired breath and how does it limit it? And then finally, something must change it from inspiration to expiration. That is the end of your breath. So what is this cycle? Cycling variable terminates inspiration and switches to expiration. Then the expiration occurs, which is the expiratory phase. So these are four phases of a respiratory cycle or ventilatory cycle. So we need to understand what is a trigger, what is the delivery of inspired breath, what limits it, and finally, what cycles it. So a phase variable begins, sustains, ends, and determines the characteristic of each breath. So trigger variable begins the inspiration, limit variable, also called as target variable. It does not end the breath, but it determines what to be delivered. This is a slight confusing terminology. The target variable or limit variable, actually, most of the people confuse it with the control variable, the pressure control and the volume control. But we'll look at an example and see how it limits the breath, but does not end the breath. So cycle variable ultimately ends inspiratory phase into exhalation. So what signals the breath is the triggering, and what signals the end of inspiration is cycling. So we can have time triggered breath, pressure triggered breath, and flow triggered breath. Finally, cycling can be done if the preset time has been occurred, preset volume has been reached, or preset flow target has been reached. So coming to trigger variable, it can be a ventilator triggered breath or a patient triggered breath. Now, ventilator triggered breath means it is a time triggered breath. The patient is fully paralyzed. We have set a specific rate on ventilator. We have set a specific inspiratory to expiratory time on ventilator. Just assume it is a 10 per minute of ventilation that we have set. We have set a I ratio of 1:2. So 10 ventilation per minute will be a 6 seconds for one breath. Dividing that into a 1:2 ratio, it will be a 2 seconds of inspiration and 4 seconds of expiration. So every time a breath is delivered, it will be a 2 second of inspiratory phase and then 4 seconds of expiratory phase, followed by again a inspiratory phase. So ventilator will trigger all breath based on the time elapsed that as a clinician, we have set on the ventilator. But then again, there will be a patient triggered breath. When the patient is not paralyzed, the patient can also trigger the breath. The pressure triggering, when the ventilator breath is initiated, if it senses a negative airway pressure deflection generated by a patient, the patient starts to breathe, there is a negative airway pressure as in spontaneous breath which is generated. Ventilator senses this trigger and gives a breath. Flow triggering, the patient generates a flow and the ventilator senses that the patient is generating a flow and the breath is delivered. So now if you go to your ventilator screen in your ICUs or OTs, we have pressure triggering something like -1, -2, -3, and then flow triggering something like +1, +2, +3. So how do we set it? We try and make the ventilator sensitive to patient's effort. We do not want the patient to fight with the ventilator. So when we are trying to keep the patient calm, we are keeping a pressure trigger as low as possible. That is -1 to -2. When we are trying to wean the patient, when we are actually wanting the patient to breathe himself and contribute, will make it a little bit less sensitive, going towards -3, -4. Similarly, with flow trigger, if you want to keep it more sensitive, we keep it at +1 to +2. If you want to keep it less sensitive while weaning or we are trying to make the patient work, this is what we keep at +3 to +4. So these are examples of time triggered and patient triggered. So every 3 seconds, we can see there is a initiation of breath. This is a machine breath. There is no triggering by the patient. And as you can see in the lower panel, there are patient's inspiratory effort shown by a negative deflection. As and when there is a negative deflection, the patient attempts the breath is delivered. Now, this is what we call as patient triggered breath, but then the duration between each breath is variable. So time triggered and patient triggered, two triggering mechanism. This is how the flow trigger works. There is a bias flow. Whenever there is no airflow, whenever there is end of expiration, there is no airflow in the circuit, ventilator delivers a bias flow of 2 to 3, 4 liter per minute in the circuit. As the patient starts to breathe in, the flow returning to the ventilator circuit decreases. It is sensed by the ventilator and the breath is delivered. So that was all about the trigger variables, the patient triggered breath and the machine triggered breath. Now we look at the limit variable. So maximum value that a variable can achieve is what we call as limit variable. Now we have set up a volume control or a pressure control mode. How do we set up limit? Limit we set primarily by setting the alarm settings. So if you go to the ventilator screen, you have alarm settings, and that is where we actually set the limit variable. So before going further with this, just imagine a patient on volume control mode. We'll look at this figure. So on one panel, you can see the peak airway pressure is 28 and the tidal volume set on ventilator is 450. Volume set is volume control. Now, what is happening here? Volume of 450 ml is being delivered and some pressure is reached. But look at the other screen in which there are some red marks. So peak airway pressure is 22. Pressure generation is limited and volume delivery is not good. On the extreme right lower corner of both the pics, we have a tidal volume delivery. It is 445 ml on one pic and in other pic it is 250 ml approximately with decrease in minute ventilation to 4.8. Now try and understand what is happening here. In one picture, we have a peak airway pressure of 29 and a pressure limit set to 35. In the other, we have the pressure limit set to 25. So this is where this breath is volume control, but the pressure limited. As we have set as a clinician, we do not want the pressure to go beyond a certain limit. Now, this is not the limit 22, but this is just to make you understand that what is happening. So if we set the pressure limit and the actual airway pressures are going higher than that, that breath will be stopped right there only and volume delivery will go down as you can see in your previous pic. So this is how a limit variable works. So reaching the set limit variable does not end inspiration, but it terminates the inspiratory flow. So that is a limit variable. And there can be pressure limit variable, volume limit variable. You can set up a peak airway pressure limit. You can set up a minute ventilation delivery limit in your alarms. And finally, you can set up peak flow rate to be achieved. And finally, we come to cycling variables. Now, variables that a ventilator uses to end inspiration is what we call as cycling variable. Ventilator measures the cycle variable during inspiration, uses this information to govern when the ventilator will end gas flow. Only one of four variables can be used at any given time. So we'll use volume, time, flow, or pressure to terminate breath, but only one at a time. So if you can see, it is only about volume, time, flow, and pressure. So we use volume, time, flow for initiation. We use volume, flow, and pressure for limiting, and we can use any one of these fours for as a cycling variable. So we can have pressure cycling when an inspiratory flow ends because a preset pressure is attained, a volume cycle because a preset volume is attained as defined by us, flow cycling when a predefined flow is achieved, and time cycling after a predefined time has elapsed since in the beginning of inspiration. So we have learned about the control variables, the limit variables, and finally the cycling variables. Now, when we combine these three, what we are trying to make is a recipe that defines the breath sequence and breath type. So just remember, there are only two breath types. One is a mandatory breath and one is a spontaneous breath. So what is a mandatory breath? Breaths are either triggered, cycled, or both by machine. So either the triggering or the cycling is to be done by machine. This is what we call as a mandatory breath. If both of these are done by patient, the triggering and the cycling, this is what we call as spontaneous breaths. So there are only two kinds of breath in mechanical ventilation, a mandatory breath and a spontaneous breath. And finally, we have three breath sequence, the continuous mandatory ventilation, the intermittent mandatory ventilation, and finally the continuous spontaneous ventilation. So in continuous mandatory ventilation and intermittent mandatory ventilation, the breaths are mandatory. That is, either they are triggered or cycled or both by machine. That means the machine is contributing somewhere, either in initiation, either in cycling, or both. When the machine is not contributing, the breaths are triggered and cycled by patient. This is what we call as continuous spontaneous ventilation. So we have two types of breath, mandatory and spontaneous. And we have three types of breath sequence, and this is what we call as basic mode of ventilation. The continuous mandatory ventilation, when all breaths are machine delivered. Intermittent mandatory ventilation, when a set number of mandatory breaths each minute are provided, but the patient is allowed to breathe spontaneously in between. And then there is continuous spontaneous ventilation, when all breaths are spontaneous and therefore patient triggered and patient cycled. So coming to continuous mandatory ventilation, what is happening? All breaths are mandatory, can be volume or pressure targeted. Now we look into our control variables, the limit variables, and the cycle variable. So it will be a volume or pressure targeted. That is what we will decide. Can be time triggered or patient triggered. So if the patient is paralyzed, it can be time triggered. If the patient is not paralyzed, it will be patient triggered. So time triggered is what we call as the controlled ventilation, and patient triggered is what we call as the assist controlled ventilation. So volume control, pressure control, both are CMV. Assist, when the patient is allowed to trigger the ventilation, which we call as assist volume control or pressure volume control. Now try and look at these curves. What is this mode? This is a volume control mode. How to identify volume control mode? We look at the flow time curve. This is a square wave pattern, a constant flow. This is a volume controlled ventilation. Now this is what is the preset peak flow in volume controlled ventilation. So this is limiting it. So what is the triggering? This is time triggered. There is no patient effort, not in the pressure time curve, not in the flow time curve. So if there is no patient triggering, this is a machine triggered or time triggered breath. It is limited by flow. And what is the cycling variable? When the fixed volume is delivered, the cycling occurs towards the expiration. So this is a time triggered, flow limited, volume cycled breath. This is a volume controlled ventilation. Look at what is happening in the pressure controlled ventilation. Again, time triggering, there is no patient effort. What is limiting this breath? The set pressure. So pressure limited. And what is cycling? A time cycled breath, as after a fixed time, there is cycling from inspiration to expiration. So these are pressure controlled and volume controlled mode, the basic modes of ventilation under CMV. Now, what is assist control ventilation? When we allow the patient to trigger the breaths and also to breathe in between, we call it assist controlled ventilation. So as you can see, there is some negative deflection in the pressure time curve. So this is what is the trigger is whenever patient is generating a negative pressure, as per our set value on trigger settings in the ventilator is delivering a mandatory breath. So this is what we call as assist controlled ventilation. Now look at this curve. There is this negative deflection in the pressure time curve and the breath is being generated. So this is what we call as volume targeted ventilation. Now this is not time triggered. This is patient triggered. All volume controlled ventilation are constant flow. So this is flow limited and volume cycled ventilation. Now this is the comparative graph of controlled and assist control. So only difference being the triggering. So time triggered and patient triggered when this is assist mode. Coming to our next intermittent mandatory ventilation, there is a periodic volume or pressure targeted breath that occurs at set interval that was occurring as in the CMV. Then patient can breathe spontaneously between the mandatory breaths. Patient assumes a part of work of breathing and allows for active participation by patient in breath delivery, but there can be a lack of coordination between mandatory and spontaneous breath. So see, if when the mandatory breath, which is based on time, is being delivered, there may be a situation when patient is trying to exhale or he wants more of the inspiration and the ventilator is trying to go in the expiratory phase. So that is the drawback of intermittent mandatory ventilation. So to remove that drawback, we convert that to a synchronized intermittent mandatory ventilation. It operates in same way as IMV, except that all the mandatory breaths are patient or time triggered rather than solely time triggered. So if the patient is trying to trigger it and there is a time for mandatory breath to be given, it will synchronize that breath with the patient trigger. And if the patient is trying to breathe in between, it will let it breathe. So this eliminates the problem of breath stacking. But then again, this mode is associated with greater work of breathing than assist control ventilation and therefore is less frequently used. So SIMV, the mode, the intermittent mandatory ventilation, can be SIMV VC or SIMV pressure control. That is something that you will decide. But what is happening here is there will be a mandatory breath which will be delivered as per volume control or pressure control. And these breaths will be synchronized with patient effort. And also, if patient is trying to take additional breaths, they are allowed to do so. So look at this chart. What is happening? On the first curve, we can see a negative deflection in the pressure time curve. That negative deflection is the trigger. And when the trigger occurs, the breath is delivered. And in between, patient is trying to breathe spontaneously. These spontaneous breaths are allowed. When the time for next mandatory breath comes, that mandatory breath is synchronized again with the patient's effort. So all the mandatory breaths, they are synchronized with the patient's effort. And in between, if the patient is trying to breathe, that liberty is always there that the patient can breathe spontaneously. So on the left panel is the SIMV curve that we just saw, and in the right panel is SIMV plus pressure support. So what we have done here is when the patient is breathing spontaneously, we have provided some pressure support to patient so that a volume is generated as the respiratory muscles may be weak. So this pressure support is shown in the curve right in the middle. So all pressure supports are spontaneous ventilation. We'll come to that, and they are flow cycled. What is flow cycling? We'll look into it. And lastly,
actually, you have to hurry up a bit because the time.
So lastly, we have continuous spontaneous ventilation. Patient can breathe spontaneously through a ventilator circuit without receiving any mandatory breath. It is almost equivalent to TPs. We can do that in the with two things. One is the continuous positive airway pressure, and finally we have pressure support ventilation that we just saw with the SMV. So pressure support ventilation is spontaneous mode. Pressure support ventilation is a assisted ventilation. It is flow cycled. So what is flow cycling? We'll look. So as the maximum flow is reached and it is coming down, so we can define at 25%, 50%, 30% value of peak flow. So when peak flow is decreasing, whether it has come down to 25% of peak or 50% of peak, that is something we can set at that time the flow cycling will occur towards the expiratory phase. So this kind of breath we can say are patient triggered and flow cycled. So this is what is pressure support ventilation, the patient triggered, pressure limited, flow cycled breath, and we can always set the flow value at which the expiration occurs. So this is the flow is coming down almost 10% of the peak value, then the cycling occurring 25% and 50% of peak flow when the cycling is occurring. So take home for invasive mode of ventilations, a lot of fancy names, but simple bottom line. There are only two breaths. One is spontaneous, one is mandatory. Mandatory can be control or assist control. Whether you want your patient to breathe, you decide that on CMV, IMV, or SMV. Assist VC and assist PC are most commonly used, and choose whatever you are comfortable with. Now, that was all about the basic modes of ventilation. I'll quickly go through with the non-invasive ventilation. It refers to the administration of ventilatory support without using an invasive artificial airway. It offers same physiological benefits of invasive ventilation like respiratory muscle unloading, gas exchange improvement, augmentation of alveolar ventilation. What are the advantages? It eliminates the risk associated with upper airway trauma, reduce patient discomfort, minimizes the risk of VAP, minimize need of sedation, preserves airway clearance and swallowing. Normal eating, drinking, and communications are permitted. So, what are the strong indications or the scenarios where it is commonly used is a acute exacerbation of COPD, then weaning these kind of patients of acute exacerbation of COPD, cardiogenic pulmonary edema, and immunocompromised patient. Now, these are the commonest indication with strongest evidence for use of non-invasive ventilation in clinical practice. Now, a patient who is hemodynamically unstable, unable to maintain the airway, and in cardiorespiratory arrest, unable to generate the breaths. These are absolute contraindications. Then there are some relative contraindications like cardiac instability, arrhythmias, GI bleed, MI, intractable emesis, abdominal surgery. These are relative contraindications. What are the interfaces? We have a lot of interfaces you must have seen: nasal mask, orofacial mask, total oral mask, mouthpieces, nasal pillow. These are the interfaces, how they look like: the oronasal, nasal, the nasal pillow, total face mask, mouthpiece, and finally the helmet. Nasal interface is most commonly used for home-based BiPAP therapy and better tolerated. Patient can eat and drink, but the disadvantage is nasal ulcers. Air can leak from mouth. This is the oronasal mask that is most commonly used in the our hospital setup. Then we have full face mask. Now, what are the problems with NIV? Claustrophobia, skin irritation, air leaks, stomach bloating as there is aerophagia, dry mouth or throat, nasal congestion. These are the common problems, and 18% of NIV trials fail because of the mask discomfort. Now, this is the some jargon of terminologies that we use: the BiPAP, the bilevel positive airway pressure; IPAP is the inspiratory pressure; EPAP is the expiratory pressure that we said. Trigger is the point where the BiPAP unit transitions from a low EPAP pressure to a higher IPAP pressure. Cycle is going from inspiration to expiration again, that is from IPAP to EPAP. Rate is the number of breath. And finally, we need to look at the rise time. The rise time is the time during which the inspiratory flow is delivered. And then sensitivity, as we have seen the sensitivity in the invasive ventilation, we refers to triggering and cycling in the same way. So just look at this curve, what is happening. There is a pressure going up, coming down. So highest pressure is what we call as IPAP, lowest pressure is what we call as EPAP, and then there is a baseline pressure. So baseline pressure is zero in the airway. Expiratory positive airway pressure is the pressure at the end of inspiration. So some positive airway pressure is maintained at the end of inspiration. It goes up as the inspiratory pressure is going up, and a final IPAP is delivered. So what is the function of EPAP and what is the function of IPAP? EPAP keeps the alveoli open. So if you want to increase the oxygenation, your patient is hypoxemic, you increase the EPAP. What is the function of IPAP? As the pressure is generated, it adds to volume delivery. So if the patient is not generating tidal volume, you have patients with exacerbations of COPD who are in type 2 respiratory failure, you increase your IPAP. So how do you set the ventilator? You have bilevel ventilators and you have ICU ventilators. So what is the benefit of the ICU ventilator is you can monitor the graphics and you can titrate the FiO2. So in hospital or ICU settings, preferable to use them. So setting and adjustment, choose the correct interface, explain therapy to the patient, also discuss the possibility of intubation, set the NIV portable pressure ventilator in a spontaneous or spontaneous timed mode, administer oxygen at 2 liters per minute if using the bilevel machine, hold the mask with hand over his face, do not fix it, start with very low settings. You start with a low IPAP of 8 and 4 centimeter of EPAP. So minimum difference between the IPAP and EPAP that you set is 4. So you start with 8 by 4, 10 by 6. So there has to be a minimum of 4 difference between the IPAP and EPAP. Increase the EPAP by 1 to 2 centimeter increments till all inspiratory efforts are able to trigger. And if the patient is making inspiratory effort and the ventilator does not respond to that inspiratory effort, increase the EPAP further till this happens. So that is how you increase the EPAP till the triggering starts to happen. Most of the patients require a EPAP of 4 to 6 centimeter water. Patients who are obese or have OSA can require higher EPAP. When all patients' efforts are triggering the ventilator, leave EPAP at that level. Now start increasing the IPAP in the increments of 1 to 2 centimeter up to a maximum pressure, which the patient can tolerate with adequate tidal volume and minimal leak. So now secure the interface. And after doing this, you stay with the patient. You don't leave the patient for next 30 minutes. You stay with the patient. You observe the patient. You look the signs of whether the NIV is tolerated or not, or if this is a case of NIV failure and we need urgent intubation. So NIV is a very beautiful thing. It can avoid intubation, but it can also delay intubation. So whenever you are giving a trial of non-invasive ventilation, you need to be at the bedside observing the patient for next 30 to 60 minutes. Thank you. Thank you very much.
Thank you, Akhil. We are sorry that I know that you have to hurry because we are running out short of time. Just 1 or 2 points regarding this. If nobody has any questions regarding the NIV, nobody actually, anybody, whether it is me or it is you or it is my relatives, nobody will want a patient directly to be put on ventilator. So everybody wants to make the NIV successful. So in order to make the NIV successful, you have to put it correctly as we have shown it. And 18 to 40% of the NIV fails due to the interface that you are using. The interface that you discussed is the face mask. It comes only in 3 sizes, and 3 sizes cannot suffice the millions and billions of faces of the world. The shapes are completely different. So the shapes cannot be compared with the sizes. So that is the reason of failure. You have claustrophobia, you have lot of other happy hospital acquired pressure injuries. That is one of the big problems of face mask. And you cannot give a PEEP of more than 10 through a face mask. So use a helmet. The only thing that I want to say about helmet, only 1 minute I'll take. When you are using a helmet, use a ventilator. Use the pressure support PEEP mode. Where you end PEEP at 10 in a face mask, you start with 10 in a helmet. Keep a pressure support of 50. Decrease your size of your ventilatory circuit to 65 to 80 centimeter. Inflate the cushion that is there in the helmet to 125 centimeter of water. And along with that, keep a fast rise time. If you have a rise time in the helmet, you keep a fast rise time. Give a more flow. You have to increase the certain ventilators. You have the choice to increase the flow, bias flow. Also, if you can give more flow, then only you can be successful with a helmet. And I think you have to monitor your patients very good with NIV. See the scoring. I think you learn due to shortage of time, you can tell it. The Hackard score, we are using it. Heart rate, acidosis, consciousness, oxygenation, and respiratory rate. If this score is going more than 7, 6 or 7, this patient is not a patient of NIV. I have to quickly put the patient on mechanical ventilation. Remember, the more late I do, more I increase the mortality. Thank you so much, Dr. Akhil, for such a fantastic presentation on the ventilation, the basics modes. You have explained really well. I also learned from it. So without wasting time, I'll call the next speaker, Dr. Puneet. Dr. Puneet Khanna is my very dear friend, and he's the professor in All India Institute of Medical Sciences, the Department of Anesthesia and Critical Care. There's a lot of publications in his name. I also read his book on ultrasound, and his famous quote, "Guidelines are not guidelines." I think Puneet will be remembering that. I always quote him on that. So Puneet, thank you. It's really a treat and a privilege to basically introduce you. And
Thank
I'll
you.
request you to stick to your time and discuss the advanced mode of mechanical
Sir,
ventilation.
actually, I
Thank you
didn't,
so much.
I didn't know whether I would be free or not. So I had a pre-recorded thing. It's 30-minute odd. I think they will
Yes,
play.
please, put it.
Okay. Hi to everyone. We will be dealing with the advanced modes of mechanical ventilation after the basic modes of ventilation. Myself, Professor Puneet Khanna. I work in the Department of Anesthesiology, Pain Medicine and Critical Care in AIIMS, New Delhi. So we all know about the conventional modes. The clinician talks to the ventilator talks to the patient. Fine. So what the basic modes as discussed have been like pressure support, pressure control ventilation, volume control ventilation. So either you set a volume or a pressure or a flow, and the patient has to adapt. All these modes assume that the patient need and condition are constant. On the contrary, it's not so. The patient conditions keeps on changing. So why were the new modes introduced? New modes were introduced because 50% of the time used to be spent on trying to liberate or wean the patient from the ventilator, which used to require frequent change in ventilatory settings. To think of comfort, synchrony, so that weaning readiness can be given a priority and patient can be weaned comfortably. And probably to decrease the length of the ICU stay. So what does closed loop refers to? Closed loop ventilation, the clinician talks to the ventilator talks to the patient gives a feedback signal to the ventilator, and then clinician can change the settings. The basic modes: pressure support, SIMV, ACMV, a set volume, a pressure and a flow, and the patient has to adapt. It gets a feedback and clinician sets the ventilator setting and adapts to the patient. Mainly, these are based upon minute ventilation and based upon the lung mechanics. Before moving on to the advanced modes, let us see what do we actually mean by a breath delivery. A breath delivery or a ventilator breath or a control variable either can have both the phases which are controlled, or have one phase which is controlled, or a support ventilation where both the two phases are under patient control. Now, what we think is to have a target scheme. What is this targeting scheme? It is based upon the ventilator response to the patient's lung mechanics and efforts. So, a control variable, the independent variable used to establish the gas flow to the patient, is called as the control variable. In any ventilator, only one parameter can be controlled, either pressure or volume. It is not possible to control both of them. So it is not possible to control both of them in a single breath. Based upon the variable control, it may be volume control or pressure control. In volume control, we set the flow or the volume, which will remain constant, whereas in pressure, which will vary depending upon the patient's lung mechanics. In pressure control, the driving pressure is set by the operator. The volume delivered may vary upon the lung mechanics and the patient's effort. So that's the targeting scheme based upon the ventilatory response to the lung mechanics or the patient's efforts. That's how we choose an advanced mode. So coming on to the advanced weaning and advanced weaning modes of mechanical ventilation. Let us explore the most common advanced weaning modes of mechanical ventilation and how healthcare professionals can safely transition the patients off the mechanical ventilation. So we will be discussing both advanced modes of mechanical ventilation and advanced modes or weaning modes of mechanical ventilation. So let us discuss about the evolution of new technology. Why was the needs of the new modes, introduction to the basic principles of the new modes, what are the advantages and the limitations of the new modes, and then we will summarize. So evolution of a mechanical ventilator. Let's start with volume control. It delivers a set volume of gas into the lungs with each breath, best suited for patients with chronic respiratory failure. Pressure control delivers a set airway at a set airway pressure with each breath suited for the patients with acute respiratory failure. Pressure support provides support for each breath, allowing the patient to breathe more comfortably on their own. Pressure support delivers small tidal volumes at higher frequency, improving gas exchange in patient with acute respiratory distress. The problem, the ideal mode. Everybody is in search of an ideal thing. Disparity between what we expect and what we have. There are a number of studies on the ventilatory modes which exceeds, in fact, the number of patients which have been treated. So the ideal mode is which will synchronize with the patient's spontaneous respiratory efforts, which will maintain adequate, consistent tidal volume, minute ventilation at low airway pressures, and respond to the respiratory changes in the pulmonary mechanics of the patient, and provide us with the lowest work of breathing. So why the new mode? Better patient ventilator synchrony, less sedation. Let the ventilator think and apply, less monitoring and adjustments. There are claimed benefits of reduced ventilatory associated lung injury. They propose to facilitate weaning, and maybe it's a scientific jargon to keep on looking for the new things. We don't know whether they really help or not. The first advancement was the microprocessor technology. In simple words, it had the better control of the flow and the exhalation walls, increased monitoring capabilities, increased patient and ventilatory interactions, and dual mode could be introduced. What were the benefits of microprocessor? Allows for the precise control and monitoring of the ventilation process and reduces the risk of complication. How does a microprocessor work? Sensors detect the changes in respiratory status, and microprocessors adjust the ventilation strategies accordingly. Advanced monitoring, microprocessor controls the real-time monitoring of the patient status, enabling the intervention and improved outcomes. So what mode to use? Smart Care, Intelligent View, ASV, PAV, NAVA, PRVC, VAPS, Auto Mode, BiPAP, APRV, and BiVent. This is the dramatic increase in the use of different modes of mechanical ventilation by the various mechanical ventilatory companies which have been introduced in the recent years. We'll just touch upon a little of everyone. New modes of ventilation and dual control modes. Type dual control within a breath. The manufacturers are mentioned over there. The name given is volume assured pressure support or pressure augmentation. Dual control breath to breath, basically volume support. Pressure limited time cycled variable pressure support. Dual control breath to breath, pressure control, pressure regulated volume control, adaptive pressure ventilation. Pressure limited time cycle ventilation, auto flow or variable pressure control. Dual control breath to breath, adaptive support ventilation. The various companies have adapted to various things like Hamilton, Draeger, Siemens, and Bard, so many of them. So these are the various trade names that they have given it to the various modes. So let us touch upon the few important ones. Volume assured pressure support. Volume assured pressure support, the name itself signifies it's a dual control within a breath. Limit, target, pressure and volume. So it adjusts the pressure level to achieve a set tidal volume. It adjusts the pressure to achieve a set tidal volume. Volume assured pressure support adjusts the pressure. Fine. It combines volume ventilation and pressure support. It uses tidal volume, peak flow, and pressure support settings. It targets the pressure support with at least set peak flow first and continues until the flow decreases to the set peak flow. If tidal volume is not delivered, then the peak flow is maintained. If tidal volume is delivered, the breath ends. So what are the benefits? Benefits are lower peak airway pressures, reduced patient's work of breathing, improved gas distribution, less need of sedation, and improved patient comfort. Application: the patients who require substantial level of ventilatory support and high ventilatory drive during weaning phase of patients with unstable ventilatory drive. This is very important one, PRVC. Again, a dual control breath to breath, pressure regulated volume control. Here, a set tidal volume at a regulated airway pressure. There are many synonyms for it used by various companies: PRVCs, adaptive pressure ventilation by Hamilton, or autoflow by Avita Draeger. Here, a set tidal volume is delivered at a regulated airway pressure. So let's see how does PRVC works. It combines both volume ventilation and pressure control. Fine. The ventilator will not be allowed to deliver a pressure to rise higher than 5 centimeter of water below the set pressure limit. Let's explain the breaths. First breath plus 5 to 10 centimeter of water above the PEEP. Then relationship is measured for the next 3 breaths. Pressure is increased to 75% of the needed tidal volume and then changes per breath till the time the inspiration ends. Set tidal volume is targeted. Ventilator estimates the volume pressure relationship in each breath. It adjusts the level of pressure control breath by breath. So advantages: it maintains a minimum PIP, guaranteed tidal volume with minute ventilation. Patient has very little work of breathing requirement, allows the patient to control respiratory rate, decelerating flow waveform for improved gas distribution. Disadvantages: varying mean airway pressures may cause worsen or may increase the auto PEEP. When patient demand is increased, the pressure level may diminish, may be tolerated poorly in an awake or a non-sedated patient. Then came the concept of open lung. HFOV, we won't discuss it over here. Open lung concept basically is an approach to ventilation that aims to keep the lung open and protect them from injury. HFOV is basically high oscillatory frequency ventilation, small volumes of air at a very high frequency, improving the oxygenation. It is of much use in pediatric patients now rather than the adults. The trials have proven of no benefits in the adults as such. APRV is the name of the day, or is the flavor of the day. Airway pressure release ventilation, a mode of ventilation that alternates between 2 airway pressures, and it improves the gas exchange by reducing the risk of lung injury. It is designed to recruit and maintain adequate expansion of the lung and decrease the atelectotrauma and improve the oxygenation. APRV. So the APRV is basically a mode of ventilation along with a spontaneous ventilation. It promotes the lung to reach the peak expiratory flow from returning to zero baseline. And a continuous positive airway pressure, in short, promotes CO2 elimination. Release time is short to prevent. It's a form of bi-level, but utilizes a very short expiratory time for pressure release. It always implies a severe inverse ratio. All spontaneous breathing is done at an upper pressure level. This is how a typical APRV screen looks like. P high is basically upper CPAP level. P low is low pressure setting. T high is the inspiratory time phase for the high CPAP. T low is the release time for CO2 elimination. Initial settings are algorithmic based. Adjustments are as per as PaO2 and PaCO2. Benefits: preservation of spontaneous breathing, comfortable breathing occurring even at high CPAP, decreased work of breathing, decreased barotrauma, decreased circulatory compromise, less sedation, less analgesia. APRV has some disadvantages as well. It does not completely support CO2 elimination. volume change with alteration in the lung compliance and resistance. If spontaneous efforts are not matched during transition from pre-high to pre-low, it may lead to increased workload. And limited staff experience with this mode may take implementation a little difficult. Closed loop system. This is the latest kid in the block. Automatic readjustment of tidal volume and respiratory rate depending upon the last breath. Predicted body weight and initial diagnosis has to be selected. Ventilator analyzes the tidal volume, the respiratory rate, the EtCO2, the compliance and the resistance, and delivers appropriate flow, tidal volume and respiratory rate at a least pressure. Closed loop control involves a positive feedback or a negative feedback for the information on the respiratory mechanics of the patient. Its measurements are made continuously, which can be modified or adapted physiologically. So the closed loop system, as we were discussing, how it actually works, the ventilator uses the advanced sensor to continually monitor the patient respiratory status and adjust the settings accordingly, improving the patient outcomes. The closed loop system provides more precise control of ventilation, improving patient comfort and reducing the risk of complications. Examples of closed loop system is ASV, PAV, NAVA. These are company proprietaries, adaptive support ventilation, proportionate assisted ventilation, and neurally adjusted ventilatory assistance. As far as I know, ASV is with Hamilton, PAV is with Draeger, or NAVA is with Mackay. So predicted body weight and the initial diagnosis has to be selected. Ventilatory analysis, tidal volume, respiratory rate, EtCO2, compliance and resistance are noted down, and the ventilator delivers the appropriate flow, tidal volume and respiratory rate at a least pressure. It is based on measurements made almost continuously, which can be modified or adapted in a more physiological and in an individualized ventilatory support manner, basically precision medicine or individualized medicine. So let's discuss these. Proportionate assist ventilation, pressure and volume, limits pressure and target is the volume. Available on Draeger, uses the patient's own respiratory effort to support ventilation. So the goal is to maintain a constant fraction of work breath done by the ventilator, automatically adjust the flow, volume and the pressure needed to reach for each breath. PAV requires only PEEP, FiO2, percentage of volume assisted and percentage of flow assisted. It reduces the work of breathing. It regulates the pressure output of the ventilator constantly according to the patient demands for flow and volume. Time and power asynchrony are nearly optimal. So this is how the PAV benefits: comfort, improves synchrony, patient control, lower peak airway pressure, less sedation, increases sleep efficiency, and it can be used in the non-invasive COPD patient. Limitations: patient has to trigger variable tidal volume or peak inspiratory pressure. Correct determination and airway work breathing is difficult, cannot compensate for the leaks, and trigger effort may increase the auto PEEP. Nava, it's mainly the Mackay. It's an esophageal catheter placed at the crura of the diaphragm and measures the electrical activity of the diaphragm. Basically, neurally adjusted ventilatory assist. Nava, central nervous system, phrenic nerve, diaphragm excitation, diaphragm contraction, chest wall and lung expansion, airway pressure, flow and volume. Current technology, ventilator unit, fine. So Nava, basically a esophageal electrode, diaphragmatic electromyographic signals, ventilatory trigger, and breath is supported by the ventilator. So these are the various pressure versus time, flow versus time, VS by time, and EDI. When the EDI decreases to 40 to 70% of the peak electrical activity, expression is triggered. So NAVA benefits: improves the patient ventilator interaction, meets the patient breath to breath demand, enhances the respiratory monitoring, Monitoring from the EDI signal evaluates the severity of the illness, helps in titrating the sedation levels, and it's basically based upon the diaphragmatic function. Limitations: relatively invasive, few clinical data, sedatives have to be used. Sedatives used and analgesic used affect the EDI and the learning curve and the interpretation. Adaptive support ventilation, basically used by Hamilton. It is versatile, easy to use, safe. Adjust the ventilation according to the need of the patient's changing needs. It's a simplified ventilator setting, one mode for all patients, spontaneously breathing or passively ventilated. Only three main parameters are there: percentage of minute volume, PEEP, and FiO2. ASV basically is a dual mode that uses pressure ventilation, both pressure control and pressure support, to maintain a minimal set expiratory volume or target volume using the least required settings for a minimal work of breathing. Automatically adapts the patient demand support depending upon the patient's elastic and the resistive loads. ASV combines basically pressure support ventilation if respiratory rate is higher than the target, pressure control ventilation if there is no spontaneous breathing, SIMV when the patient respiratory rate is lower than the target. Fine. It can combine PSV, PCV, and SIMV. Sounds fascinating. So this is how an ASV monitoring screen looks like. Ideal body weight, dead space, high alarms, monitoring, curves, target tidal volume, safety frames. This is how it looks like. But what are the main parameters? There are only three main parameters. Modes we have already seen what it can use. It can use pressure control, mechanical, SIMV, PSV. Fine. So that it can combine PSV if the respiratory rate is higher than the target, pressure control ventilation if there is no spontaneous breathing, SIMV when the patient respiratory rate is lower than the target. So initial settings: percentage of the minimum volume, passively ventilated patients, percentage of minute volume, target minute ventilation, increase or decrease to reach the target PaCO2, and initial setting is either 100% or 110. Spontaneously breathing patient, percentage minimum volume to minimum ventilation, increase or decrease according to the level of the pressure support. PEEP and FiO2. PEEP setting is as usual. FiO2 is adjusted according to the PaO2 and the target range. Other parameters are like trigger, inspiratory trigger, patient ventilator synchrony, ASV limit to 30 centimeter of water. These are the various other short time constant, normal time constant, and long time constant, which occurs in restrictive disease, normal lung, or an obstructive disease. The respiratory system time constant reflects the speed by which the system changes the volume in response to the change in the applied pressure. That is the RC time constant, resistance into compliance. Fine. Target the respiratory rate is calculated by the Otis formula. This is how it goes. Then there is an algorithm which assesses the patient condition, calculates the respiratory rate, automatically adapts, and then a closed loop ventilation starts. It also helps in weaning and it also tells us in readiness to weaning. That is why it is called intelligent ASV, adaptive support ventilation. IntelliVent ASV, the oxygenation controller requires certain signals, and then the plethysmographic waveform for the visual perception. Ventilation controller also requires the certain sensor signals that is given in the form of mainstream capnometry, a flow sensor. Then there is a ventilation controller which is set by the clinician. Quick wean and SBT. Here is an overview where you screen in the first phase, observe in the second phase, and give the trial in the third phase. We will come to the advantages and the disadvantages. Advantages are guaranteed tidal volume, minimal work of breathing, adapts to the patient, weaning is done automatically and continuously, decelerating flow, breath by breath analysis. Disadvantages and risks are inability to recognize the changes in the alveolar ventilation, varying means of airway pressure in patients with COPD, or a sudden increase in the respiratory rate and demand may result in decrease in the ventilatory support. Contraindications are Patients in ventilation with leaks, NIV, bronchopleural fistula, relatives are irregular respiratory drive. So ASV evidence as compared to SIMV pressure control, decreased ventilatory settings manipulation, decreased high inspiratory pressure, improved work of breathing, improved synchrony, decreased sedation use helpful in weaning. Fine. This is also a closed loop at a glance, various type pressures, PAV, NAVA, ASV. Fine, automatic weaning is present in KBS and ASV. Knowledge-based system is KBS. Fine, these are the various systems which we can look. Now, how to decide an advanced mode? So, to decide an advanced mode with the availability of various modes, you should determine the factors. The first factor to consider is the availability of the mode in your ventilator, whether that mode is present in your ventilator or not. Obviously, we will not be able to ventilate with a mode which is your ventilator does not have. The most important factor is the operator experience with that mode. An expert operator can get a better result with a conventional ventilation than a person who hasn't used that mode. So you should know everything about that mode which you choose to ventilate. The relative importance of the goal changes over a period of time. When the goal is identified, we should check the given mode, whether that mode has served us the function or has the capability to achieve that goal. Before checking the goal, we should also check whether the assumption of the feedback or the loop is also true. Optimizing the alveolar ventilation. The first step in choosing the mode is to identify the goal. What goal we are identifying, the goal of ventilation. Second step is to identify the mode and the capability to achieve that goal. The third step is to consider the mechanism by which that mode will achieve the goal. Finally, you should also consider the pros and cons. Alveolar ventilation. Optimizing alveolar ventilation can be done in various ways. It can be achieved by manual adjustment. It can be achieved by automatic adjustment of pressure as in adaptive schemes. The other way of achieving ventilation automatically is changing the mode as in dual modes or adaptive modes like an auto mode or a minimal mandatory mode. Or the intelligent schemes achieve the ventilation by using complex algorithm adjusted to the tidal volume. In conventional mode, this can be achieved directly by setting the tidal volume and respiratory rate. So what we see is there are various ways of achieving optimized alveolar ventilation. Manual adjustment, adjustment of pressure, adjustment of the optimal volume targets, adjustment of mode to achieve the tidal volume. So manual are like conventional volume strategies, adaptive PRVC, volume support, auto flow. Automatic adjustment may occur in adaptive or dual mode. Optimal intelligent ASV and intelligent SV, automatic adjustment to the target. And then maximize the oxygenization. How can you maximize the oxygen? Manual adjustment of the PEEP and FiO2, all modes except intelligent modes. Even recruitment modes like APRV, automatic adjustment of PEEP and FiO2, intelligent mode like ASV, or the ARDS net trials which says how to increase the PEEP and the FiO2. Maximizing the oxygenation, providing the comfort, trigger cycle asynchrony, mechanical flow, pressure trigger cycle, electrical trigger cycle, mechanical flow pressure trigger and cycle are all continuous spontaneous mode. Optimize the trigger sensitivity manually. Electrical trigger cycle NAVA, providing comfort, flow synchrony, unrestricted flow in mandatory breaths, set the target, pressure target breaths, switch from volume control to pressure control, adjustment of flow based upon frequency, that is adaptive eye flow, providing comfort, matching output to the demand, adjust the pressure support to the breathing pattern, PAV or NAVA, adjust pressure support to the respiratory rate like adaptive mandatory rate ventilation, adjust PS to the patient drive. Weaning, promote the liberation, manual weaning, set target, pressure support ventilation, ventilator initiated weaning, ventilated recommended liberation, ventilator initiated weaning, ASV, intelligent ASV, ventilator recommended liberation, smart care, pressure support. So to summarize everything, it can be manual, servo or automatic. Set target control, volume control, pressure support, dual mode, VAPs and PRVCs. Servo control, ATC amplifies the resistance support. NAVA, PAV, PPS amplifies the mechanical effort. Automatic adaptive, PRVC, MRV, optimal ASV, intelligent modes like smart care, pressure support, IntelliVent and ASV. So all these targeting schemes are based on expert rules and based on assumptions. If assumption is violated, the modes will be less beneficial or harmful. Feedback mechanics, PRVC, mechanical and effort, PAV and NAVA, mechanics, flow volume curves, ASV and AVM, ETCO2, minute ventilation, smart care, oxygenation, intelligent ventilation. The take home message is know your mode, understand the targeting scheme, the technical capability, know the assumptions of the mode, and then understand the goals of the settings. Advanced mode of ventilation gives us the precise control of the ventilation process, might improve the patient outcomes, reducing the risk of complications. New modes, microprocessor controls and closed loops. Open lung concept provides a promising avenue to protecting the lungs. The final take home is think and analyze. You are an intensivist. Volume control, pressure control, SIMV, PS, conventional modes are still the cornerstone. Newer modes are helping tools. There is no standard good ventilatory care and there is no shortcut to it. And I will say not all that glitters is gold. No matter how smart the ventilators becomes, the intensivist should always be the master and utilize what is best after thinking and analyzing. Thank you.
Thank you, Dr. Puneet, for such an excellent overview of the newer modes of ventilation. It's not so easy to explain. I think you have done an excellent job. Only one, the last line speaks all about what you have said, that old is gold, and obviously the intensivist has to remember. I remember one of the lines of Albert Einstein where he's saying that I fear that the human interaction will be surpassed by the technology. The world will become a place of idiots. So I remember those lines. So these newer modes sometimes give me that feeling. Smart care, Neo Ganesh system, I think due to short of time, I think it's a very interesting mode where I keep the patient in between a comfortable zone of a respiratory rate between 15 to 30, a tidal volume of around 6 ml per kg body weight, and a ETCO2 of 35 to 45. The pressure support is automatically changed by the ventilator, and ultimately it will signal you now extubate. So as if all of your work has been taken out by this ventilator. If you ask me, by the bedside, sometimes our brain becomes dull, but still they definitely have some advantages in some of the difficult situations that we face in difficult cases. Thank you so much, Puneet. I don't think there is any question here. The chat box is empty, so I thank both Dr. Puneet and Dr. Akhil for such an excellent lecture on the ventilation, and I hand it over to Dr. Anupama to continue for the further proceedings. Thank you so much.
Thank you, Dr. Ranajit. Nice catching up.
Thank you.
Thank you, Dr. Ranjit, sir. Thank you, Dr. Puneet, for a very good lecture, and sir, for your precious time in the morning and your expert comments. I'm sure that the delegates must have gained a lot to learn from the experts in the critical care. Thank you so much, sir.
Thank you.
Thank you, Dr. Puneet. With this, we come to an end to the mechanical ventilation session. I'm sure you must have all learned very well from the session. Now we have our very popular sessions on the case discussions. Today we have a long case to discuss, and for moderating the case, we have Dr. Anju Balotra ma'am with us. Ma'am is Director Professor at Maulana Azad Medical College, New Delhi. Ma'am has various achievements to her. She is a gold medalist and first ranker in MD Anesthesiology AIMS. She's an AHA certified ACLS trainer. She has several publications in international and national journals. She is on the review board of several important journals, and she is a member specialist board for anesthesiology at the MBE. Her areas of interest are the pediatric anesthesia and ARV management. We welcome you, ma'am. We are honored to have you, our extinguished moderator for this session. And to
Very
present
much.
the-
Can you hear me? I'm
Yes,
audible.
ma'am.
Yeah,
Yes,
thank
ma'am.
you.
You are clearly
Okay.
audible. Thank you, ma'am. And to present the case, we have Dr. Anshuman Gildial. He is a third-year postgraduate, and he would be presenting the case. And to summarize it and to moderate it with him, we have Dr. Pallavi. She is a senior resident in the Department of Anesthesia. I welcome you both. I hand it over to Dr. Anju Malhotra, ma'am, to moderate the session. Welcome, ma'am.
Thank you. Good morning, everybody. Today, the patient who has been given to us is a patient of COPD who's coming for laparoscopic cholecystectomy. So, without wasting time, I'll first of all, of course, I'd like to thank the Appec for inviting me time after time for this wonderful series of lectures. And now, Anshuman, can you please start with the history? Share your screen.
Yes, ma'am. Good morning, everyone. Today I will be presenting a case of COPD for laparoscopic cholecystectomy. My patient Afroz is a 50-year-old male who is a plumber by occupation. He studied till 5th standard and is a resident of Tilaknagar, Delhi. His chief complaints were pain abdomen for the last 3 months and nausea and vomiting for the last 3 days. The patient was apparently all right 3 months back when he felt pain in the right upper abdomen, which was insidious in onset, aggravated after fatty or spicy meal, not associated with any physical activity, any particular posture, fever, or voiding of urine and feces. There was no diurnal variation. Pain was relieved on taking medication. A patient has been having vomiting for the past 3 days, 5 episodes, which was sudden in onset, associated with severe pain, episodic, precipitated with every meal. It was non-projectile in nature and scanty in quantity. It was greenish in color and occasionally contained food particles. There was no blood or coffee-colored content. It was aggravated with fatty and spicy meals. There is no history of abdominal distension, fever, loss of appetite, or weight loss. There is no evening rise of temperature, yellowish discoloration of eyes, skin, or urine. There is no alteration of bowel and bladder habits, no passage of black or clay-colored stools, or bleeding from any side. The patient had visited a local physician who did an ultrasound and was told that he has gallstones in the gallbladder. In the past medical history, he has intermittent cough with expectoration for the last 5 years, which was gradual in onset, not aggravated by dust, fumes, cold air. No history of increase in severity at night, associated with the white, non-foul smelling, blood tinged sputum production. It is not associated with postural variation and is more in the mornings. And is not more in the mornings. It is approximately 2 teaspoons 3 to 4 times per day. It is also associated with shortness of breath for the last 3 years, which is insidious in onset, gradually progressive. Initially, he used to get breathless only when hurrying on a level ground, which has progressed to shortness of breath on walking at his own pace on the level ground, and he walks at a slower pace than people of his own age. It is aggravated by cough, exertion, and strenuous exercise. It is not associated with noisy respiration, chest pain, swelling of face or lower limbs. There is no history of discomfort in breathing while lying down flat or having to get up in the middle of night to catch breath. Not aggravated by dust, fumes, cold air, or any specific posture. He got treatment from a private clinic and was put on an inhaler. He feels better after taking the inhaler and rest. Patient had complaints of shortness of breath and increased coughing 5 months back. He was admitted to a local hospital and managed with oxygen therapy, nebulization, and intravenous medication during the period of admission. There is no history of ICU admission or ventilatory support. He was discharged from the hospital after 48 hours and put on a second inhaler. Patient is now compliant with the treatment and has had no exaggerations. There is no history of further hospitalization or immunization. There is no history of recent episode of running nose, chest infection, tuberculosis, repeated allergies, or any patches on skin. There is no history of repeated breathlessness since childhood, or jaundice, diabetes, hypertension, heart disease, or intermittent claudication, pedal edema, or palpitations. There is no previous anesthesia or surgical intervention. In the personal history, he is a smoker for more than 35 years. He smokes around 20 cigarettes per day, which becomes one pack or 35 pack years. He is not an alcoholic. He is non-vegetarian by diet. There is normal sleep-wake pattern and regular normal bowel and bladder habits. He is currently on 2 meter-dose inhalers, was earlier on one, and another was added 5 months back. There is no history of any oral medications currently, and he was non-compliant before the hospitalization and is currently compliant to medication and on regular follow-up. There is no history of similar complaints in the family members. There is no history of coronary artery disease, hypertension, diabetes mellitus, or any chronic illnesses in the family individuals. He belongs to a lower middle class family according to modified Kuppuswamy scale. He is a plumber by occupation and sole earner living in a rented house in Tilaknagar, Delhi with his wife and girl.
Okay, so Anshuman, can you quickly summarize your history? What are the salient features in your history?
Ma'am, my patient is a known case of cholelithiasis with the shortness of breath, dyspnea associated with cough, and he walks on dyspnea is of a grade. He walks slower than his peers, and there is history.
What happened first? What was the initial complaint?
His initial complaint was of pain, ma'am. His chief the pain.
We know that he's a diagnosed case of cholelithiasis because he's had an ultrasound done and he's come for laparoscopy for gallbladder surgery.
Yes,
okay, so let's leave that part. But as far as the respiratory complaints are concerned, what was his first initial complaint? Was started how?
And with
started with cough or started with dyspnea?
With cough, ma'am.
Yes, so that is important to realize that he started with cough and he produces expectoration. How much expectoration did you say he produces in a day?
2 teaspoons 5 times a day.
2 to 3 teaspoons, you said 2 or 3 times a day or something like that. So around how much ml is that?
Ma'am, 1 teaspoon is around 5 ml, ma'am. So
he produces around 30, 40 ml?
Yes, ma'am.
Yeah. So what is, when is the sputum production considered to be excessive?
Ma'am, it is considered excessive over 100 ml.
I mean, 20 ml is considered normal. Between 20 to 100 ml, it is increased, but it is worrisome when it becomes more than 100 ml. So in your patient, he has got a cough and he is producing expectoration for the last 5 years, but that cough has never been. So what are the important features to ask in cough that you have asked?
Ma'am, history of
the color, the volume
yes,
of expectoration, yes.
Color, volume as aggravating and relieving factors. If was the cough followed by dyspnea or was the dyspnea followed by cough? Any history of ma'am orthopnea or PND? And ma'am, was it relieved on medications or what medications, ma'am? Diuretics or bronchodilators?
So your patient had cough for 5 years. It was no precipitating factors that's happening on and off for the last 5 years, producing expectoration. Then 3 years ago, he also started developing dyspnea. So what do you mean by dyspnea? What is dyspnea?
Ma'am, dyspnea is subjective sensation of breathlessness.
Okay, so it's an uncomfortable sense of breathing. It's a discomfort during breathing. So now when a patient of the age group of 50-year-old male develops dyspnea, then how do you know it's not a cardiac problem?
Ma'am, we can differentiate between cardiac dyspnea and respiratory dyspnea based on history, ma'am. So in cardiac dyspnea, it is generally...
Can advance your slides also, Anshuman? Yes. Now,
in cardiac dyspnea, the dyspnea is usually followed by a cough, and the dyspnea is the predominant symptom. It will be associated with chest pain or palpitations, and there will be a history of orthopnea and PND, and it will be relieved by taking diuretics or inotropes. Whereas in respiratory dyspnea, ma'am, there will be cough followed by dyspnea, and cough will be the predominant symptom. There will be there might be orthopnea, but PND will not be there, and it is relieved by bronchodilators and rest.
Okay, so you took although that is why you took a history of chest pain, palpitations, orthopnea. You've taken, so this is all important to be taken in the history so that we can differentiate between a cardiac cause and a respiratory cause. So in this patient, you will see that he had first cough, and after 2 years, the dyspnea was set in. And the predominant presenting symptom 5 years ago was cough. He has no history of orthopnea. He has no history of chest pain. And he responded well to bronchodilators. So we think that he is probably a respiratory problem is underlying in this case. I mean, of course, you people have to understand that patients at the age of 50-year-old man could have both. You could have cardiac and respiratory, but this seems to be a predominantly respiratory problem. So we have to take a targeted history, which Anshuman has taken, to rule out all associated factors that indicate whether it is cardiac or respiratory in origin. Okay, very good. Now, you said something about the grading. So the dyspnea has to be graded. So initially, you said he was. What is his grade of dyspnea? How do you grade dyspnea?
Ma'am, initially my patient was, we will grade ma'am according to MMRC scale, ma'am. Initially, my patient was of grade 1 and is currently on grade 2, ma'am.
So initially when he came, what is MMRC 1?
Ma'am, MMRC 1 is when the patient has a dyspnea on walking on a level field or up a slight hill, whereas in dyspnea grade 2, ma'am, the patient walks slower than his peers, ma'am, and has to stop while walking on a level ground.
Okay, so in this case, your patient was initially MMRC 1 5 years ago, 3 years ago, and now for the last year or so, he is unable to keep pace with other people of his own age and he has to keep resting. So he comes into MMRC 2. Okay, so now we have some more information. We know that he has a respiratory disease. We know that he has got dyspnea, which is of a moderate degree. I will not say that this is severe dyspnea. Okay, and so what happened to him 5 months ago? What happened and what is the implication of that?
Ma'am, 5 months ago, patient had a history of exacerbation where he had to be admitted. And
what do you mean by an exacerbation?
Ma'am, when the patient while on medication has a history of breathlessness, which is cannot control by his usual medication, and then has to be admitted for further therapy and addition of a second therapy, ma'am, second drug.
Okay, so what is the clinical implication of an exacerbation?
Ma'am, if the patient second exacerbation, if there is an exacerbation, ma'am, we have to update his treatment, ma'am, and he becomes a slightly higher risk than normal, ma'am.
Yeah, so an exacerbation either means number one, he's not compliant for his medication. That could lead to an exacerbation. An exacerbation is an increase in the symptoms requiring a change in treatment. But if the patient is compliant on his treatment and he has an exacerbation or he has frequent exacerbations, that means that the disease process is also rapidly increasing, or the pathological process is increasing, and that gives us a poorer prognosis or indicates an increasing severity of the disease. Okay. So this gentleman was not very compliant, you said earlier, and then he was on one MDI, not very compliant, and then he had this exacerbation. He was admitted, and then he's on a second one, but now he has responded to that. So that is our history. So everybody should, so we've ruled out cardiac asthma. We know the progress of his illness, how it's progressed. So he is basically some sort of respiratory disease. It could be obstructive, it could be restrictive. But since he has been on bronchodilators and he has a history of dyspnea which has responded to bronchodilators, we think that it is probably an obstructive illness. Okay. Yes, so now, what is the other factor in the history which is important, which suggests that he has got obstructive lung disease?
Ma'am, he has a history of cigarette smoking, ma'am, for the past 5 years.
So he has 35 pack years of smoking, which is quite significant. So that is so any person who has got after the age of around 35 years old, any person who presents with cough with expectoration and progressive dyspnea should be assumed to have COPD, and that can only, however, this is just a suspicion, and the diagnosis of COPD has to be confirmed. How? Anshuman, how is the diagnosis confirmed?
And we do a spirometry post bronchodilator therapy, ma'am, and in that the FEV1 by FVC ratio will be less than 0.7.
Okay, so on the basis of clinical grounds, you can suspect that the patient has got COPD, but the diagnosis of COPD is a spirometric diagnosis. It is confirmed only by spirometry, which is done by the pulmonologist usually, not by the anesthesiologist. Okay, so now the smoking is a trigger. Is an important trigger or risk factor for the development of COPD. When should the patient stop smoking, and why does he need to stop smoking?
Ma'am, the patient should stop smoking as soon as possible, ma'am. And if it's an elective surgery, we will advise him at least 8 weeks before the operation. And ma'am, we have to stop if there are 8 weeks have been passed after the smoking cessation, there will be pulmonary function returns almost to the normal level, ma'am. There will be increased mucociliary clearance. The cilia will function normally. The sputum clear will be
Okay,
there.
so you're saying that if you have the time, then you would want the patient to stop smoking for at least 6-8 weeks before the anesthetic in order to reduce the incidence of post-operative pulmonary complications. That is our main concern, that patient should have an uneventful anesthetic. So to decrease the incidence of post-operative pulmonary complications, you need to have at least 6 to 8 weeks cessation of smoking. And smoking has effects on all the organ systems. So that Pallavi will talk about in the summarization. So as you said, after 8 weeks, the immune function returns to normal, ciliary function returns to normal, mucus production returns to normal, and even the incidence of PPC decreases. So we want, if we have time, we want to wait for 8 weeks. Now, supposing you don't have time and you have to do this particular surgery tomorrow, what are the side effects of stopping it suddenly? You tell the patient today, now stop smoking. Should you tell him? Because you're saying it takes 8 weeks.
Yes, ma'am, we should tell them because the amount of carboxyhemoglobin will decrease, ma'am.
So even after a short, even overnight cessation, we'll have two advantages. One is that the carboxyhemoglobin levels will decrease and the nicotine levels will also decrease. So we would like the patient to stop it even today, even though there are some side effects of stopping it. What are the side effects of suddenly stopping smoking?
Ma'am, there will be increased anxiety, ma'am, and there will be withdrawal symptoms might be there, ma'am, for the patient.
So there might be mucus hypersecretion.
Yes,
They might. These are the few disadvantages of suddenly stopping. You see the patient, you say, no, don't smoke now, otherwise tumhari jaan chali jayegi types. So if you stop smoking, then you have mucus hypersecretion, you have stress. The patient, see, smokers smoke under stress. So now surgery is a stress. So they may not be able to handle the stress of the perioperative period, and they might feel more, their mental status may not be so good if you ask them to stop smoking in the immediate preoperative. But having kept both these things in the balance, it still is advisable to tell the patient to stop smoking as soon as you see him. Okay, so we tell him to stop smoking. And then, so now we have another factor which points us in the history towards COPD. We also have a very strong risk factor for the development of COPD. So we have a 50-year-old male with chronic cough, progressive dyspnea, chronic cough with expectoration, and he's also got a very strong risk factor of smoking. So with this, keeping this history in mind, we proceed towards our general physical examination. Anshuman.
Ma'am, my patient was examined in a sitting position comfortably on the bed. He is conscious, oriented to time, place, and person. His height is 172 centimeters with a weight of 62 kilograms and a BMI of 21 kilograms per meter square. He is afebrile on touch. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy, and jugular venous pressure is not raised. His temperature is 98.3 degrees Fahrenheit. Heart rate is 92 per minute. Regular, normal in volume and character. No radioradial or radiofemoral delay. His BP is 112 by 74 millimeters of mercury in the right arm in supine position. Saturation is 97% on room air and respiratory rate of 18 per minute, regular and abdominothoracic.
Yeah. So now, initially in the early stages of COPD, the general physical examination might be absolutely normal. Like you have found in your patient. Your patient has now asymptomatic patient. He's on 2 inhalers. He's quite asymptomatic. His MMRC grade is 2. And he has absolutely got no findings actually on physical examination. He's got no tachypnea. His oxygen saturation is okay. His respiratory rate is okay. He's got no signs, other signs. But if you get a patient who's got a more severe form of COPD, what are the important things that you should be looking out and ruling out in your general examination? Anshuman.
Ma'am, we will look at his posture, ma'am, build and nutrition, his mentation and faces.
So with each thing, you can tell me what you look for. What will you look for in posture?
Ma'am, in the posture, ma'am, the patient might be in distress and he might be trying to recruit his axillary muscle. So he will be in a tripod position and his build and nutrition might be compromised. He might be cachexic. There might be loss of muscles, or the patient might even, if the patient is, might even be overweight or obese, ma'am. His mentation, if the patient has retention of CO2, he might be in CO2 narcosis. So he might be disoriented and anxious. Again, ma'am, the use of accessory muscles might be there, like sternocleidomastoid or alar nasi, and trapezius, pectoralis major, abdominal muscles. He might be coughing, ma'am, so there might be increased sputum production. He might even have an increased respiratory rate or heart rate. The patient might be cynosed, or ma'am, if the patient is in heart failure, there might be JVP or pedal edema.
So the posture, the tripod position, you can see in this figure that he has put next to you. The tripod position, the patient tends to lean. The main pathology is that the diaphragm in these patients becomes flattened due to the emphysematous changes that they develop. So as you all know, the diaphragm is a predominant muscle of inspiration. That does most of the inspiration is done by the diaphragm. And the diaphragm has become flat, so it's lost its curvature. So the diaphragmatic excursions have become much less efficient. So the diaphragm is not able to do the work it's supposed to do. So it takes help from other muscles. So which are the inspiratory accessory muscles, Anshuman? The inspiratory ones are mainly the sternocleidomastoid and the scalene muscles. So they are the ones which activated earlier. And normally expiration is a passive process. You all know that inspiration is an active process. Expiration is passive. But in these people, what happens on expiration? There is air trapping. Yes?
Yes, ma'am.
So there is air trapping. So they need help to push the air out of their lungs. So even their elastic recoil is reduced. The normal recoil is not there. Normally we just stop breathing and expiration may our lungs recoil and the air is pushed out. In may recoil is also not is also reduced in these patients. So they have to use their abdominal muscles, which are the expiratory accessory muscles, which also press upon the diaphragm and press upon the lower on the diaphragm to push the air out of the lungs. So you'll have activation of, but these changes are only seen in the patients once their FEV1 goes to around 30% or 50%. So in the severe or the very severe category of patients, these changes are seen. So when they lean forward also, they, like you can see this guy is leaning on the table. So he is pressing his abdomen or his stomach so that the stomach gets pushed upon the diaphragm and the diaphragm gets curvature and it helps the diaphragm to move up and down in a wider range. So they tend to push their tummy. In case the table is not there, then they tend to push their tummy against their thighs and they lean forward. He might be very anxious, and anxiety is bad for these patients. Why is anxiety bad, Anshuman?
Ma'am, if there is anxiety, ma'am, the patient will have increased respiratory rate and there might be breath stacking, ma'am. The patient will not be able to because he's unable to exhale the air completely because of the COPD, ma'am. So, and say the air might get trapped, ma'am.
Yeah, so it becomes a vicious cycle. They become anxious. When they become anxious, then there's more dynamic hyperinflation because they start breathing fast. They breathe fast to get more oxygen, but when they try to breathe too fast, then their expiratory time becomes reduced and there becomes further air trapping. So it becomes a very vicious cycle for these patients. Okay. So pulse is normally, there could be tachycardia, patient is in distress, and later on in very extreme situations when the patient is during an acute exacerbation, there might even be a pulsus paradoxus. The color, what do you expect in the color?
Ma'am, patient might have cyanosis, ma'am.
Patient might have pallor because of the associated malnutrition, because they are chronically sick patients, because they are not getting well oxygenated, so they do not feel normally hungry. They are very the most severe cases are pretty sick, so they could have anemia of malnutrition, they could have anemia of chronic disease, and they could also have cyanosis due to hypoxemia. Due to basically, what are the main cause of hypoxemia, Anshuman?
Ma'am, mainly, ma'am, because of VQ mismatch, ma'am.
VQ mismatch, very good. And the development of a raised JVP and the development of pedal edema suggests that the patient is going into right ventricular failure. He has developed pulmonary hypertension, right ventricular hypertrophy, and now he's going into right ventricular failure. And these are signs of very severe COPD. Okay, Anshuman, carry on, please.
Ma'am, in the airway examination, it was all within normal limits, ma'am. In the systemic examination, in the abdomen, the abdomen was scaphoid and uniformly moving with respiration. Umbilicus is inverted midway between xiphisternum and pubis. There's no visible scar, pigmentation, ulcer, venous prominence, swelling of pulsation or movement. There's no visible localized impulse on cuffing, and the hernia site and genitals were healthy. On palpation, the inspectory findings are confirmed and the patient is normal temperature and soft to touch and non-tender. There's no palpable lump, no muscle guarding, pulsation, fluid thrill or rebound tenderness, no hepatosplenomegaly, no palpable cuff impulse over the inguinal region, and urinary bladder is non-palpable. The scrotum and testis is normal. On percussion, there is a normal tympanic node, no shifting dullness, and upper border of the liver at right fifth intercostal space at mid-clavicular line. On auscultation, the normal intestine peristaltic sounds are heard and no hepatic or splenic rub. In the respiratory system, ma'am, on inspection, there is no tracheal deviation. The chest wall is AP diameter is increased and the chest is barrel shaped. This bilateral equal movement with respiration, no visible swelling, venous prominence, pulsation, scar or ulcer over the chest and back. No audible wheeze or stridor. There's not no use of accessory muscles of respiration and no suprasternal retraction seen. On palpation, all the findings of inspection are confirmed. There's no tenderness, trachea is in midline. Bilateral equal movements of the chest wall with respiration and the chest expansion on full inspiration is 3 centimeter. Diameter at the nipple level, the AP diameter is 42 centimeter and the transverse is 41 centimeter with a ratio of 1.02. The vocal phragmitis is decreased on both sides. On percussion, it's resonant in all areas in the sitting position. Upper border at fifth intercostal space, upper border of liver at fifth intercostal space in mid-clavicular line, and cardiac dullness could not be located. On auscultation, bilateral decreased air entry in all areas. No added sounds. Vocal resonance is decreased in all areas. The cardiovascular system, central nervous system, and spine examination was all within normal limits.
So, for the postgraduates who are listening, since our presenting complaint is laparoscope patient for pain abdomen for coming for laparoscopic surgery, that is his presenting complaint. So first we do abdominal examination, which is essentially normal, and then we move on to the respiratory examination. In this patient that Anshuman has selected, again, I'm saying is a mild case. All the findings are normal, except I think just the vocal phragmitis is reduced in one place. But when you have a patient with a more severe form of COPD, what are the things to look for in the respiratory examination, Anshuman?
Ma'am, it's important to look for the shape of the chest. It might be barrel shaped.
On inspection, you look at the
On inspection, ma'am, we look at the shape of the chest, ma'am. It might be barrel shaped.
Barrel shape. What do you mean by a barrel shaped chest?
Ma'am, in barrel shape, the AP diameter is increased more than the transverse diameter, ma'am.
AP diameter might be equal to or more than. Normally, what is the ratio normally?
Ma'am, normal ratio is 0.70 to 0.75, ma'am.
Yeah, that is normal, and it could up till 0.9 can be accepted. But once they become equal or the AP is more, then it is definitely a barrel chest. Why do they develop a barrel chest? Again, because of
inflation of the lung.
Because of air trapping. There is a air trapping. Because of the air trapping, there's an increase in the residual volume and the lung becomes hyperinflated. So it cannot increase much in the lateral dimension. So it increases in the AP dimension. Okay, then the patient we've already discussed. Can continue, please, Anshuman? So he might have a barrel-shaped chest. Okay.
The patient might be doing pursed lip breathing. There might be chest and abdominal wall paradoxical movements. Their use of accessory muscles, ma'am.
Why are there paradoxical movements? Again, because the diaphragm is so inefficient.
Yes,
so the diaphragm goes in during inspiration rather than going out. So it becomes a paradox. Okay.
Ma'am, we have to do a chest percussion for findings of hyperinflation and obliteration of cardiac dullness. And there might be displaced upper border of the liver, ma'am. And we have
in fact, in some patients who have got a very hyperinflated lungs, cardiac dullness may be felt in the subxiphoid area. You may not even hear it in the, cardiac heart sounds might be felt in the subxiphoid area. Yes, sorry, carry on.
Ma'am, on auscultation, there might be added sounds, ma'am, like wheeze or repetitions.
There might be wheeze, which is due to the bronchospasm or narrowing of the airways, and there might be crepitations due to the presence of secretions in the airway if the patient has got predominantly a bronchitis picture. So these are all the important things that have to be said when you're doing a respiratory examination. If they're negative, then these must be, when you are presenting the case in the exam, all these things have to be mentioned as either positive or negative. Okay. Now you said that everything is pointing us towards COPD. His history is pointing us towards COPD. On examination, he's got a barrel-shaped chest, which suggesting to us that it is an obstructive lung disease, and his chest expansion is also, how much? 3 centimeters?
Yes, ma'am.
So below 2 centimeters is supposed to be reduced. So it's borderline chest expansion. But chest expansion will be reduced in both restrictive and obstructive lung disease. But his history and the presence of a barrel chest suggests that he has got obstructive lung disease. So do these patients have any other extra pulmonary manifestations that you should be looking for during history and examination?
Yes, ma'am. Ma'am, in COPD patients, ma'am, the other systemic involvement might be there. Like in cardiovascular system, there might be history of ischemic heart disease, hypertension, arrhythmias, or heart failure. In the CNS, ma'am, there might be anxiety or depression. There might be, in the musculoskeletal system, there might be osteoporosis, cachexia, or wasting of muscles, ma'am. And in the hematological system, there might be anemia of chronic disease, or even polycythemia might be there due to hypoxia. In the sleep, ma'am, there might be obstructive sleep apnea or non-specific fatigue. In the lungs, ma'am, there can be lung cancer. In the renal system, there can be chronic kidney disease, and there might, in the other systems, ma'am, there can be a platelet activation, and there might be side effects associated with steroid use.
Okay, so all these things must be remembered. So all these patients can have associated multi-system involvement, and all these things must be looked for in the history and the examination findings. These are the multi-system effects of the inflammatory process of COPD. Because now it's very clear that COPD has both a genetic, and it is due to both genetic and environmental causes. So every smoker doesn't develop COPD, and every person who's exposed to biomass or pollution or doesn't get exposed to what are the most typical example of a genetic predisposition to COPD, Anshuman?
Alpha-1 antitrypsin deficiency.
Alpha-1 antitrypsin deficiency. So those patients could be non-smokers, but they could have alpha-1 antitrypsin deficiency. So when COPD happens, it is not only affecting the lung, it is a multi-system disorder. And all these things should be looked out in the history and the physical examination. Okay. So now we finished, Anshuman. Any more things you want to tell us in the history and examination?
No, ma'am.
So you've completed the history and you've completed the examination. What is your diagnosis?
Ma'am, my patient is a 50-year-old male chronic smoker with symptomatic gallstone disease with a history suggestive of COPD, planned for laparoscopic cholecystectomy.
So he's already diagnosed, ultrasound was done, so he's a smoker with symptomatic gallstone. Now, why do you say history suggests COPD? I think I've already summarized that several times. The history is very suggestive of COPD. And what do you mean by COPD?
Ma'am, COPD stands for chronic obstructive pulmonary disease. Ma'am, it can, ma'am, it is a progressive disease associated with loss of alveolar tissue and persistent progressive airflow obstruction, ma'am. It has two components, chronic bronchitis and emphysema.
So what other obstructive disease do you know of? Now, this guy has got an obstructive disease, you know? He's got a barrel chest, he's got wheezing, he's not wheezing, but he's got history of dyspnea and he's responded to bronchitis. Why is he not asthma? Yeah, asthma.
Ma'am, asthma is usually associated with onset in early life, ma'am, and it has a diurnal variation and a seasonal variation. And the patient also has usually associated allergy or rhinitis, and family history is associated with it, and it is largely reversible, ma'am.
Okay. So asthma patients are often younger. Their symptoms are very episodic. So they have an attack of asthma, then they become normal again. Then they might have another attack of asthma and they become normal again. And there are always some trigger factors. So in your patient, his onset has happened at which age? His onset has happened at the age of around 45. 45 years ago, he started having COPD. So he will be called as a young COPD. The symptoms are progressing over time. And it is continuous symptoms. There is a history of tobacco smoking. There is dyspnea, which you said it becomes better when he takes rest and when he takes his bronchodilators. He does not have any presence of any comorbidities, but we should look for comorbidities in all these patients. And he has got this largely irreversible airflow limitation has to be confirmed by spirometry. Okay. So now we have in our minds, we have sort of excluded the diagnosis of asthma in our minds, and we are thinking that this patient has got COPD. Okay. Now, when you come to what COPD also you said is a progressive disease, and it has two components. COPD, Dr. Pallavi at the end, when she summarizes, she's going to discuss the pathophysiology of COPD in detail, so I won't waste the case time on that theoretical part. But COPD can have basically a bronchial involvement, or it can have basically an involvement at the alveoli at the parenchymal level. If the bronchial involvement is more, then it's called a chronic bronchitis. If the alveolar component or the destruction of alveoli is the predominant feature, then it has more of an emphysema. So they are not completely separate diseases, but some patients, depending upon their genetic and environmental factors and the response of their bodies to the inflammatory triggers, can have predominantly COPD and predominantly emphysema. So how can you differentiate? What about your patient now, Anshuman? What do you think he has got? COPD or emphysema or bronchitis?
Ma'am, my patient is more pointing towards, ma'am, emphysema, ma'am.
Why do you say that?
Ma'am, in the emphysema, there is a lower body mass index. The patient is of a age usually 50 to 75. There are fewer cardiovascular comorbidities. There are fewer metabolic comorbidities and has a less muscle mass. There is less respiratory insufficiency, infections, ma'am. And the airway cor pulmonale is also uncommon, ma'am. There is a low elastic recoil and appearance is usually of a pink puffer, ma'am.
Okay, so your patient has got a, what is your BMI of your patient?
I'm 21.
Okay, your patient has got a low BMI. He's a thin patient. He's lean, right? And he has got onset of dyspnea. He's does not have any JVP or pleural edema. Correct. And he does not have any history of infections. He never doesn't have a yellow cough ever, and he's not had repeated infections. So your patient fits more into the category of emphysema. Yes.
Yes, ma'am.
What are the previous slides that you missed, Anshuman? Okay, so we had bronchitis. So again, you can read out, tell them this slide also. This is more explanatory, Anshuman.
In the age usually bronchitis presents in the age of 40 to 45, whereas emphysema is in the 50 to 75 range. There is more mild dyspnea in bronchitis and severe in emphysema. The cough is early and copious sputum in bronchitis, whereas there is late and scanty sputum in emphysema. Infections are more common in bronchitis compared to emphysema, and respiratory insufficiency is early in bronchitis, whereas in emphysema it's an end stage thing. Cor pulmonale is more common in bronchitis compared to emphysema, and airway resistance is increased in bronchitis, more increased in bronchitis compared to emphysema. There's a normal elastic recoil in bronchitis, and the chest radiograph shows prominent vessel and large heart size, whereas in emphysema it shows a hyperinflation and a normal heart size.
Okay, so your patient fits into that category. Okay. Okay, so now you made a diagnosis of emphysema.
Yes, sir.
Your patient, how can you assess them? Your patient, by his clinical presentation, he does not seem to have a very severe form of disease. But if you get a more sick patient who's got active wheezing, who's more symptomatic, how will you assess the severity of this disease? Because severity assessment is important. How will you assess the severity?
And we will assess the severity on the basis of the clinical symptoms, ma'am, like clinical presentation, like if the patient is active wheeze, repeated infections, MMRC grade, or how much the patient how many medications he is taking, or if there is need of inhaled or systemic corticosteroids, and the frequency of exacerbations, how many times he was admitted, recurring admissions, and on the basis of the PFT, spirometry.
When is it considered to be a high frequency? More than
And
two? More than two excessive, the patient has more than two exacerbations in a year, that is considered to be a high risk. So the clinical presentation is, of course, very important. What is his, all those things that we said, what is his respiratory rate, what is his facies, what is he having any air hunger, is he using his accessory muscles, what is his MMRC grade, is he grade 3, is he grade 4, dyspnea at rest. So all these things will of course point to the severity of the disease, and as he said, the frequency of exacerbations, and then the severity can also be confirmed by PFT. In fact, I'm telling you again and again that the clinical presentation is a suggestion of COPD, but the diagnosis, the patient will be labeled COPD only when his PFT shows an post bronchodilator FEV1 by FVC ratio less than 70%. Only then you can formally label him as COPD. Now, in your patient, what do you think, Anshuman? What is his? Okay, next slide. How do you classify based on PFT?
Ma'am, based on the PFT, ma'am, we first do a spirometry, post bronchodilator spirometry, ma'am, for this patient. And if it shows FEV1 by FVC ratio less than 0.7, then it is a COPD, and we grade according to the FEV1 ratio. If it's more than 80%, it's mild. If it's 50 to 80, then it's moderate. If it's 30 to 50%, then it's severe, and less than 30% is very severe.
Now, supposing this patient, we have not sent this patient to the pulmonologist. Now, supposing you send this patient to the pulmonologist, what do you think, based on this clinical picture, what do you think what he's going to be? Mild, moderate, severe, very severe?
Ma'am, probably mild to moderate, ma'am.
He might probably be mild. Is there some entity called pre-COPD also, or there's a word PRISM, preserved ratio impaired spirometry? What is that? So that is the patients who have all the clinical symptomatology that we have discussed. But when you do spirometry, there you find that the FEC1, FE1, FEC ratio is not less than 0.7. So then you cannot label them. So they are called pre-COPD. So these are the patients that nowadays there's more and more awareness that you must catch these patients before they develop COPD so that you can make lifestyle interventions in these patients. So, anyway, having said that, our patient might be pre-COPD, our patient might be mild COPD because he doesn't really have very many symptoms. Okay. Okay, then. So now we have think that our patient has got COPD. We think that it's a mild form of COPD. So now you said that initially this guy was on one inhaler and then he had an exacerbation 5 months ago and he was put on a second inhaler. So what do you think he's on? What treatment is this person receiving?
Ma'am, initially he might be put on a long-acting beta agonist, and after the exacerbation, when the second inhaler was added, it might be long-acting muscarinic antagonist, ma'am.
So we think that he's on 2 drugs, that maybe one is a long-acting bronchial. Okay, so that is the most likely scenario, that he's on these 2 drugs. So now you've seen this patient, he's come to you and he's on these 2 drugs. Now you are your diagnosis is confirmed, you've taken a proper history. Now, having all this in mind, what are your main concerns, anesthesia concerns in a patient of COPD coming for surgery?
Ma'am, we have to rehabilitate the patient, ma'am. We have to so that we can avoid perioperative pulmonary complications. We have to advise the patient to stop smoking, ma'am, and we have to maintain his. We have to advise the patient to continue his bronchodilator therapy so that there are no exacerbations in the period. We have to advise the patient for adequate chest physiotherapy and lung recruitment maneuvers in like incentive spirometry, ma'am, so that the pulmonary function can be improved. And we have to do perioperative risk stratification for.
Okay, so the first time the patient actually presents to us, when he comes to us in the PSC clinic, if we have time and it's not a very emergency surgery, normally a gallbladder will be a sort of time-sensitive surgery. So we have few weeks to prepare the patient. So the first thing that we should be doing is sending the patient, especially if it's a mild case like this gentleman, I may not send him to the pulmonologist. But if it's a patient with more severe symptoms or you feel that he's got an audible wheeze, he's still not well controlled on these treatment that he's taking, then we must send the patient to the pulmonologist. And why do we want to send him to the pulmonologist? Not for anesthesia fitness, please, all of you. We do not want him to give us PSC fitness. We want the pulmonologist to tell us.
Ma'am, to modify his treatment, ma'am,
Yes, we want the pulmonologist to assess the patient. We want that because he's a specialist. We want him to assess the patient. We want him to confirm the diagnosis of COPD. We want him to assess the severity of the COPD. And we want him to tell us that this patient's COPD treatment is optimized. This is what we want. Whether the patient is fit for surgery or not fit for surgery, this is our domain. Many of us write medicine opinion for PSC fitness. That is a wrong statement to be given. We want him to tell us as a specialist, we want that specialist to tell us the status of that particular system of the patient. So he will tell us, he will do PFT if he feels it's necessary. He will confirm the diagnosis, he will quantify the severity, and he will tell us whether the patient is optimized. Stop smoking, you already said, should be done as early as possible. So as soon as we catch the patient, we should stop him from smoking and get as much time as we can. And ideally, we should have 8 weeks interval if it's an elective surgery. What is the indication for corticosteroids? Corticosteroids will be added if there is
eosinophil count is more than 300.
Yes, if the eosinophil count is high in the sputum and if the patient is symptomatic, not responding to these 2 inhalers, he might require. In the perioperative period, if he's got very severe COPD and he's not, sometimes because we are saying it's irreversible, patient may still have some degree of bronchospasm when he comes to us, in spite of optimization. So in those cases, we may even need to start some oral or intravenous parenteral corticosteroids for the perioperative period. That is in the more severe cases, maybe the severe or the very severe category. We can start antibiotics if we feel the patient has got infection. Only then we should start antibiotics. And as he said, the importance of these maneuvers, like teaching the patient incentive spirometry, must be done in the pre-op period. In the post-op period, when they are already in pain, they will never learn it and they will never do it. So it is a known thing that you have to teach them in the preoperative period, and only then it has almost 50% reduction in postoperative pulmonary complications if they are taught in central spirometry preoperatively, and they can do it in the postoperative period. Okay, and then depending upon your departmental or hospital protocols, you can have some perioperative scoring system which can score the patients for postoperative pulmonary risk. There are many scoring systems, as CAT score is there, Gupta score is there. But I think the clinical presentation of the patient and ASA grading is also enough to tell us that this patient is sick or not very sick. Okay, so now you have prepared your patient for surgery. This is the prehabilitation. What is prehabilitation? Anshuman, what does the term prehabilitation means?
Ma'am, prehabilitation includes, ma'am, we have to improve the patient's nutritional status, ma'am. We have to, in this case, ma'am, we have to improve his lung functions, recruitment of lungs, and we have to optimize the patient for lung recruitment maneuvers. And we have to ensure that there are no infections, and we have to ensure that the patient is taking his bronchodilator therapy, ma'am.
Okay, so pulmonary rehabilitation or pre-rehabilitation is to make the patient optimum prehabilitate before the surgery. What is the optimum period for prehabilitation time? Around 6 weeks.
6
That is sort of the time that you require for prehabilitation. So apart from the pulmonary rehabilitation in these patients, it's also neuromuscular. They must do some exercising. They must build up their muscles. They must hydration, steam inhalation. Then apart from that, if they have blood pressure control, whatever other illnesses, diabetic health or blood sugar control, so everything, all systemic. If they're very anxious, they must be counseled. These patients tend to be very anxious, and anxiety is a very bad thing for the perioperative period, which is going to happen because it leads to deep breath stacking. It can cause dynamic hyperinflation. So when we talk about prehabilitation, it's a multi-system attack on all his problems to make him optimized for the surgical procedure. Okay. Sometimes examiners like to ask this question: what is a 5-prong attack for respiratory diseases? What is that? 5 prongs, the most important 5 prongs.
Ma'am, 5 include, ma'am, cessation of smoking, dilation of airways, loosening of secretions, removal of secretions, and education, motivation, and patient care.
Okay, so now you've given your patient the good advice. You've told him I prehabilitation का तूने सब बता दिया कि अपनी diet ठीक करो, अपना you start exercising, start in central spirometry, start doing steam inhalation at home, and now you are now getting him ready for what is your aims of your anesthetic?
Ma'am, to decrease perioperative pulmonary complications, ma'am.
So the main aim of our anesthetic is that the patient should not land up in any pulmonary complication. We should not have any intraoperative complication. Patient should undergo this laparoscopic cholecystectomy uneventfully, and he should not develop any postoperative pulmonary complications. What are the main risk factors for pulmonary complications?
Ma'am, the patient age more than 60 years, the ASA grade more than 2, the history of congestive heart failure, a history of pre-existing pulmonary disease like COPD, and history of cigarette smoking. It can be procedure related also if it's an emergency surgery or an abdominal or thoracic surgery.
So out of these, which ones your patient has? So your patient has which ones?
Ma'am, there is a pre-existing pulmonary disease with a history of cigarette smoking, and it's an abdominal surgery under because we will be doing laparoscopic cholecystectomy, so it will be undergone under general anesthesia, ma'am. So which is also a risk factor.
So what are the important strategies that we have implemented? We have done we have done so in the next.
Yes, we have done when we have advised the patient for smoking cessation, and we have started the patient on adequate bronchodilator therapy. The patient has no history of any respiratory infection, and we have tried to educate the patient for the volume expansion maneuvers, ma'am. And we will be using a minimally invasive. We will advise the surgeon to do a minimally invasive surgery, which in this case will be a laparoscopic surgery. And since it's a lab procedure, we can't do it under regional anesthesia, ma'am.
All right. Okay. So have you now with this background in mind, now what pre-op order of investigations will you order?
Ma'am, I will order a complete blood count for the patient, ma'am. Which will show us we want to look at hemoglobin, which can be there might be polycythemia also, and there might be anemia also because of chronic disease and nutritional decreased nutritional status, ma'am. And we want to look at platelet count for if we want to plan for post-op regional post-operative blocks, ma'am. I want to look at the patient's RBS and kidney function test and liver function test as routines. Also, ma'am, the liver function test we want to look at because if the patient decreased albumin, it also becomes a risk factor. And for kidney function test, ma'am, I want to look at electrolytes because the patient is on long-term beta agonist, so there might be decreased potassium. And we will also look at ECG and chest X-ray. And if the ECG,
What do you expect in the chest X-ray, Bachan?
ma'am, in the chest X-ray, ma'am, there might be lung hyperinflation, increased intercostal distances. There might be a tubular heart. There will be flattening of the diaphragm.
What is there in your patient? Show the X-ray of your patient.
Yes, ma'am. My patient has hyperinflated lung, flattened diaphragm. So there's a increased retrosternal airspace.
That is seen on lateral view, not in this X-ray, yes? Huh?
And there is a decreased vascular markings in the peripheral zones. There might be, ma'am, bulla or lucent areas and prominent pulmonary arteries. The increased bronchovascular markings are also seen, ma'am.
So in the X-ray, depending on whether it's predominantly emphysematous or prominently bronchitis, the X-ray findings might be a little bit different. This is like an emphysematous patient in which there is hyperinflation, flattened diaphragm. But in a patient of chronic bronchitis, you might have cardiomegaly and you will have increase in bronchovascular markings. Okay. What do you expect in the ECG of this patient?
Ma'am, in the patient ECG, I will expect, ma'am, right axis deviation, ma'am. There might be P pulmonale, evidence of right ventricular hypertrophy. There might be low voltage QRS, pure R wave progression, RBBB or incomplete RBBB, and atrial arrhythmias are also common in patients of COPD.
So these findings will be more in the chronic bronchitis patient. In this particular patient, the only thing we might have is a low voltage QRS because of the high overinflated lung fields, but we didn't have that also. ECG of this patient was normal. Okay. Then Anshuman,
Yes,
what about the role of echo? Would you like to do an echo in this patient?
ma'am, if the patient ECG is suggestive of ECG, either ECG or the history is suggestive of, ma'am, heart failure, then I will suggest a 2D echo, ma'am.
Okay, but in this patient, I think there's no indication for total echo. What else would you like to do? Would you like to do an ABG?
Ma'am, I would like to do a morning ABG, ma'am, for a baseline measurement of PaO2 and PSO2, especially because the patient will be undergoing laparoscopic surgery and there's an insufflation of the peritoneum with CO2. And in case the patient, despite our best efforts, lands up in the requires post-op mechanical ventilation, so we will have a baseline ABG, ma'am.
Yeah, actually what he's saying is you can say it either way. There is actually no ABG doesn't change in these patients until they are come into the moderate category and that FEV1 is less than say 50%. They don't, ABG is maintained. However, what he's saying is also acceptable to me because it is not a very invasive investigation. It can be done in the bedside, and in case you land up in a complication or patient has CO2 retention, goes on to the ICU, then you have a baseline ABG. So you can justify it either way. Actually speaking, an ABG is not required in such a stable patient, but on the other hand, it is fairly harmless. It can even be counted as a bedside PFT, so I will accept that. Okay. Then what about PFTs? What is the role of PFTs in these patients?
Ma'am, spirometry is not required for my patient, ma'am, because it will not change my anesthetic management very much.
Okay, it has been shown in actually no, the ASA, NICE, no anesthesia related guideline has suggested any guidelines for preoperative PFT. That they, in fact, they emphasize that you must do clinical evaluation of the patient. If you order as anesthesiologist, you can order a PFT if the patient is a very severe COPD coming from major surgery, that is either upper abdominal, thoracic or lung resection. PFT is a must. Apart from that, PFTs do not decrease or they are not to be used for prognosis of the patient. If at all PFTs are to be used, they can be considered as a therapeutic measure. You can send the patient for a PFT if you feel that his lung condition can be further optimized, then you could send the patient to the pulmonologist to have a look at his PFT and see whether these PFTs can be improved by giving further bronchodilators or whether his maximum bronchodilator benefit has been achieved in this particular patient. So to that extent, when he came to us the first time, we have already sent him to a pulmonologist. But of course, this is a very stable patient. So PFTs are not to be done routinely except in patients undergoing very major surgeries, thoracic, upper abdominal, patients with moderate, with severe or very severe COPD, and where the surgery is expected to be of a long duration, more than 3 hours in a complicated surgery, then you might order preoperative PFTs just for your patient prognostication. But otherwise, there is no role of preoperative PFT. In this patient, there's absolutely no role of PFT. He should have already been seen by the pulmonologist, and his severity of his COPD should have been graded by now. Okay. So now with that background in mind, all that, can you do, if you don't want to do PFTs, you can do some bedside PFTs?
Yes, ma'am. The bedside PFTs of my patient were all within normal limits.
Okay, so this I think Dr. Pallavi will talk about in detail. Okay, so now you've done everything. What pre-op orders will you give to this patient? Now we have to quickly rush. What are the pre-op orders?
And we'll take a written informed consent. I will advise NPO for solids for 8 hours and for clear liquids 2 hours. I will advise the patient to continue taking his MDI as per schedule and to bring them to the OT also. I will do an advise incentive spirometry preoperatively and to arrange an SGU bed for the patient and tablet alprazolam 0.25 mg at the night before surgery.
So again, I'm emphasizing again, these patients are sensitive to opioids and to any CNS depressants and to benzodiazepines also. But if it's a good idea to give them a little bit of Alprax so that they do not hyperventilate and they do not land up with development of autopep before they come to us. Okay, so now you've given the preoperative orders, and now you can, this is a laparoscopic cholecystectomy, you have to go for GA. But if you have the option, what is the better choice of anesthesia in these patients, GA or regional?
And a regional anesthesia is a better choice, ma'am, for
Okay,
patient.
so quickly tell us advantages and disadvantages of both GA and regional.
Ma'am, in general anesthesia, the advantages include good ventilation and oxygenation. We have a definite airway and reduction in dead space, which allows for suction of secretions, and it's comfortable for the patients. And volatile anesthetics also cause bronchodilation. Whereas the disadvantages of GA are that there is airway instrumentation and there can be bronchospasm because of a hyperreactive airway. There is a risk of pneumothorax from positive pressure ventilation or use of nitrous oxide or bulle rupture. There might be residual effects of neuromuscular blocking or volatile anesthetics and opioids. And if opioids further decrease respiration and ability to cough, ma'am. In general anesthesia, there will be decrease in the functional residual capacity, and the use of volatile anesthetics abolishes hypoxic pulmonary vasoconstriction. So there will be a further VQ mismatch for the patient, and auto PEEP may develop, which may cause hemodynamic instability. Whereas in the regional anesthesia, it's usually preferred for lower limb or lower abdominal surgeries. The advantages include that there is a less chance of bronchospasm or laryngospasm because of the airway is not being touched, ma'am. There is less requirement of sedatives, opioids, or muscular blocking. There is no effect on hypoxic pulmonary vasoconstriction, no decrease in FRC. The chances of pneumothorax and nitrous are decreased. Pneumothorax from nitrous use or positive pressure ventilation is decreased, and it allows for good post-op pain control. Whereas, ma'am, in the disadvantage of regional anesthesia can be lost very rapidly if the patient is requiring sedation, ma'am. And the long-term regional operation under regional anesthesia might be uncomfortable for the patient.
And if you give you should not give a block more than sensory level of more than T6 or a motor block more than T10, because that takes away the abdominal muscles. So the patient may not be able to cough effectively after surgery. Okay, now again, so now our patient is for GA. How will you conduct the GA now, Anshuman? Quickly, I think we are running short on time. So after preparing the OT, you will prepare the OT, you will check all the resuscitation equipment, emergency drugs, suctioning, extra, everything has been checked. Patient has gone into the OT. What all monitoring will you use?
Ma'am, I will use ECG, NIBP, SpO2, ETCO2, and we will also check for inspired and expired anesthetic agents and monitor the MAC of the patient. If the surgery is being under TIVA, ma'am, I will use a BIS monitoring. I will also use an neuromuscular junction monitoring and airway pressures, ma'am.
Patient is undergoing laparoscopic surgery now. Is there an additional problem because of the pneumoperitoneum is going to cause some respiratory changes in this patient?
Yes, ma'am. Because of pneumoperitoneum, in the respiratory system, there might be decreased thoracopulmonary compliance, ma'am. The elevation of diaphragm might cause atelectasis and decrease in FRC. And the if we use endotracheal tube, it might become endobronchial. And the increased PSO2 will also lead to metabolic changes like increased PSO2 in the blood, ma'am, because of absorption, which will decrease cardiac contractility.
Change the slide.
It can lead to depressed cardiac contractility, and the ADR in the body, ma'am, can the increased PaCO2 will predispose to arrhythmias due to catecholamines, and there will be
So after the induction of anesthesia, you have to increase the minute ventilation by 25% in all patients undergoing CO2 pneumoperitoneum. Okay. So now you are prepared for all this. Your patient is there. You have to do laparoscopic cholecystectomy. What precautions will you take during induction of anesthesia? You put the monitors. Why do you want to have neuromuscular junction monitoring in this patient?
Ma'am, because during reversal of the GM on any residual effect of any muscle.
Yes, because these COPD patients, especially the most severe patients, are already at a respiratory disadvantage. So these patients, if they have residual neuromuscular blockade, it might just dip it in the, they might cause complications. They do not tolerate any residual neuromuscular blockade. So you can do neuromuscular junction monitoring. If the patient is planned for TIVA, then you should do BIS monitoring. Okay. What precautions during induction of anesthesia?
Ma'am, we will use propofol, ma'am. Because propofol has a minimal effect on HPV, ma'am, and it upturns the airway reflexes best, ma'am. And we will avoid, ma'am, if the patient is having very low BP or cardiac reserve is decreased, we can use ketamine as it is also a bronchodilator, ma'am. But it will increase the secretions in the airway.
And the important thing is that whenever before instrumenting the airway, then you must ensure the adequate anesthesia depth by ventilating the patient with an inhalation agent also, so that you have a good depth of anesthesia when you put the airway device. Okay. So what is the airway device of choice in these patients? What would you like to put, endotracheal tube or supraglottic airway?
Ma'am, because it's a surgery with the surgery is less than 3 hours, ma'am. It's a minor surgery. I would like to go for, ma'am, supraglottic airway.
Yeah, I won't say it's a minor surgery, but yes, this surgery can be done with supraglottic airway. So see, whenever a patient comes, supposing the patient is like your patient is well stable, well controlled, his airway pressures are not very high, then you can go for supraglottic airway device, because you know that airway pressures are going to increase further after creation of pneumoperitoneum. So keeping that margin, you must have around 1.5 times airway pressure margin. So supposing your patient's airway pressures are around 20 to 25, you must have a seal pressure of around 30 to 35. But if the patient has already got a very severe COPD, he has already got a wheeze, then you know that when they create the pneumoperitoneum, then the airway pressures might exceed the seal pressures and you may not be able to ventilate your patient. So in that case, you might want to go for an endotracheal tube. But in this particular patient, I agree with you, you can go with supraglottic airway device. Okay, so you've chosen a supraglottic airway device. What is your choice of inhalation agent?
Ma'am, I will use, ma'am, sevoflurane, ma'am, because it is less pungent, ma'am. It's sweet smelling. It is causes less airway irritation, ma'am.
And it is also shorter acting. If these patients develop air trapping and they develop bronchospasm intraoperatively, inhalation agent also gets trapped inside. So we must use short-acting inhalation agents. We have two of them, sevoflurane and desflurane. Desflurane is relatively contraindicated because it causes airway hyperreactivity. What is the role of nitrous oxide?
Ma'am, we will avoid nitrous oxide, ma'am, because the patient might have bulla, which might rupture because of use of nitrous oxide.
Nitrous oxide also limits your FiO2. So these two reasons, in the more severe patients, you may want to avoid the use of nitrous oxide. What is the role of TIVA?
Ma'am, TIVA might be beneficial for this patient, ma'am, because it has no effect on hypoxic pulmonary vasoconstriction.
Yes, TIVA is also a very good option for these patients. Okay. All right. So now what about your analgesia? Okay, muscle relaxant. What is your choice of muscle relaxant?
Ma'am, I will use the short-acting muscle relaxant like vecuronium, ma'am, because
intermediate acting muscle relaxant.
Intermediate acting, sorry, ma'am.
Yeah, intermediate one. And you will avoid which one?
Ma'am, I will avoid my metrocurium, ma'am, because it causes
histamine. It causes histamine release. Okay. Now, what about the analgesia component?
Ma'am, we will use paracetamol, ma'am, for the patient intraoperatively, and I will also use, ma'am, opioid sparing blocks, ma'am. We will avoid high doses of opioids intraoperatively, and I will avoid diclofenac.
So you will use a multimodal analgesia regime, which will comprise of paracetamol, opioid sparing, because these patients are very sensitive because the respiratory center, you don't want to depress their hypercapnic or hypoxic drive for respiration. So we use low dose, maybe 1 microgram per kg of fentanyl, paracetamol, and we will use some form of block. So which are the blocks that can be used for lap poly?
Ma'am, we can use a subcostal tab, we can use a erector spinae plane block, paravertebral block, or quadratus lumbar block.
You can use, or if you don't have access to ultrasound or you're not conversant in ultrasound, you can even do just port site infiltration and intraperitoneal installation local anesthetic. Something must be planned because it's very important that these patients are pain-free because they already have decreased lung volumes. And if they have uncontrolled pain, then they will have inability to breathe and they might land up in CO2 narcosis. So you have to provide very good analgesia. Then what are the ventilatory strategy in these patients?
Ma'am, we will use ma'am pressure control ventilation with low tidal volumes of 6 to 8 ml per kg, and we will keep the respiratory rate at a lower level, ma'am, to allow complete exhalation. We might even use decreased IE ratio to allow for to prolong the expiration time. The peak airway pressure should be less than 30 centimeters of water, and the FiO2 should be titrated to keep SpO2 more than 90%.
So now you're giving anesthesia to your patient. What is your main concern intraoperatively?
Ma'am, increased airway pressures, ma'am, are my main concern, ma'am.
So you think that the patient might develop peak airway, increase in airway pressures due to, okay, this we have discussed, the perioperative multimodal analgesia. What is the role of diclofenac? You said you'll avoid it. Why?
Ma'am, because diclofenac causes inhibition of COX. It causes COX inhibition, COX 1 and 2. So there is decreased prostaglandins and it will lead to bronchoconstriction, ma'am.
And it increases the leukotrienes increase, so that they predispose to all this edema. And so it is more important to avoid it in asthmatic patients who have a more responsive sort of irritable airway. But in COPD, also you should avoid it if possible. Okay, now suppose the patient suddenly develops increased airway pressures, you are monitoring airway pressures suddenly go up in the saturation from 97, it becomes 95. Then what will you think?
Ma'am, if there is sudden increase in ma'am airway pressure and there's a decrease in blood pressure, I will think about ma'am bronchospasm, ma'am, or pneumothorax, ma'am.
Okay, but there are other multiple causes that you must rule out. What are the different causes of rise in airway pressure?
Ma'am,
It could be
there can
bronchospasm due to inadequate depth of anesthesia. It could be due to, if you put an endotracheal tube, it could be due to kinking of endotracheal tube or migration or endobronchial migration of endotracheal tube. It could be due to a pulmonary embolism. It could be due to a pneumothorax. It could be due to all these reasons. But in this particular patient, the ones that come to mind, because your patient is COPD. So what you do immediately, you see this on the monitor and the saturation, I said, falls a little bit, airway pressures go up. You will immediately, first thing you'll do is auscultate your patient.
Yes,
And if you can auscultate the presence of wheeze and the diagnosis is confirmed, supposing there is decreased air entry on the right side, it could be a capnothorax, it could be a ruptured bulla, it could be a tension it could be a pneumothorax, which will go to a tension pneumothorax. So immediately you have to auscultate the patient and make your diagnosis. But in this patient, you auscultate and there's bilateral wheeze as auscultated. How will you manage?
Ma'am, we will manage, ma'am, by giving ma'am meter dose inhaler to the patient. We will we will give propofol, deepen the plane of anesthesia. We will give inhaled short-acting beta agonist. We can also give IV corticosteroids, and we will increase we adjust the ventilator settings and decrease the IE ratio so that there is less of gas trapping, ma'am. In cases it's not reversible, ma'am, we can even use magnesium and epinephrine.
All right. The other complication that might occur intraoperatively is the development of auto PEEP or gas trapping, and this will be more if the patient develops bronchospasm. So when you have this expired, the EtCO2 showing a shark fin pattern, then this is the NISORA guidelines for bronchospasm. Just for the completion's sake, they are saying what we have said: first line treatment and second line treatment. And as he said very rightly, it's better to give an IV drug like propofol for deepening the level of anesthesia. But if the patient is having severe bronchospasm and you increase the inhalation agent, it doesn't reach the site of action. So it's better to give an IV drug when there is severe bronchospasm. Okay, next slide, Bacha, please. So bronchospasm, the other thing is air trapping. So what is air trapping?
Ma'am, when there is air trapping, ma'am, when the IE ratio is normal IE ratio, the patient doesn't have adequate time to exhale, ma'am. So there might be retention of air inside the lungs, ma'am, which we call as auto PEEP or intrinsic PEEP or air trapping.
So that has consequences. What are those consequences? It's not a good thing to happen. The air keeps again stacking inside the lungs. Ultimately, there will be an increase in intrathoracic pressure,
which will lead to decreased venous return, and it will increase the pulmonary vascular resistance, and which will lead to an RV strain, and there will be distended RV, which will impinge on the left ventricle, ma'am, thus thereby decreasing the left ventricular output also.
Yes, because of the ventricular interdependence, the septum will shift towards the interventricular septum will shift and it will decrease the left ventricular output. Patient might land up in hypotension. So the patient suddenly develops hypotension on the table. Then what will you look for? How can you identify whether auto-PEEP is happening? Then you look at.
Yes, ma'am. I mean, the flow time curve, we will see that there is incomplete emptying of the air, ma'am.
Very good. So you see in the flow time curve, does not reach the baseline and the next breath starts. That means that there is some development auto-PEEP. Now, if the patient is having a cardiovascular instability, then you can just disconnect the tubings. Immediately that PEEP will get dissipated and your patient's BP might come up. The other thing that might lead to hemodynamic instability is, of course, the presence of a development of a tension pneumothorax due to a ruptured bulla. So these are the two differential diagnoses of sudden hemodynamic instability in these patients on the table. Okay. Okay, then next. So what are the important things during reversal?
Ma'am, during reversal, we have to ensure, ma'am, complete reversal of the neuromuscular agent, muscle relaxant, ma'am. And we have to, theoretically, ma'am, it is said that the anticholinergic drug could precipitate bronchospasm due to stimulation of postganglionic cholinergic receptors in the smooth muscles. But it is, ma'am, such bronchospasm is not cannot be occur, ma'am, because of bronchodilating effects provided by simultaneous administration of anticholinergic drugs.
So it's not really much of a clinical problem. Okay. Then supposing the patient has been, if the proceed LMA is there, like in this patient, you can extubate it quite gently because the LMA is much easier to extubate as compared to endotracheal tube. If the patient has been intubated for a procedure, then you can give some IV lignocaine or inhaled bronchodilator before extubation. And you can consider deep extubation, or you can consider doing a Bailey's maneuver in which you shift from endotracheal tube to LMA. Okay. The other important thing is the post-op care management. Last slide, Anshuman, then we'll give it to Pallavi.
Ma'am, in the post-operative period, when we have to ensure adequate analgesia so that patient lung recruitment maneuvers can be done, the patient can be advised early ambulation, and ma'am, he has adequate cuff reflexes. We have to give titrated O2 therapy using Venturi mask, ma'am, and we have to advise incentive spirometry.
What is the problem of giving higher FiO2 to these patients? Why are you saying titrated oxygen therapy? What is the problem with higher FiO2?
Ma'am, with higher FiO2, the patient with COPD usually have a hypoxic drive, ma'am, because if the patient has severe COPD, ma'am, there will be patient has already high PaCO2, which doesn't have, the patient is desensitized to the CO2 trigger, ma'am, so they have a hypoxic.
Actually, nowadays considered to be the last reason. The most important reason is titrated oxygen therapy means you titrate the oxygen therapy to a PaO2 of SpO2 of around 88 to 92%. If you give higher FiO2s, it inhibits again HPV is the most important thing. Your higher FiO2s inhibit HPV. Then it also interferes with the carriage Haldane effect or the carriage of carbon dioxide in the blood. And lastly, it may inhibit the hypoxic drive. Okay. Good pain relief is very, very important. We've already discussed this because they already have decreased lung volumes. If they don't breathe deeply and they don't cough because of pain, then the patients will land up with post-operative pulmonary complications. So each of these components is very, very important. Deep breathing exercises. Early mobilization is the most important factor in preventing post-operative pulmonary complications, and that is only possible if the patient is pain-free. So already Anshuman has given some form of block to this patient. He has given multimodal analgesia, given some amount of block, and used an opioid-sparing anesthesia technique. So that finishes our case. I think the patient has been extubated. He's successfully been extubated, and Anshuman, well done. Now we'll just give it to Dr. Pallavi to summarize quickly the important theoretical aspects in these patients. Dr. Pallavi, please. In the meantime, if there are any questions in the chat box.
No questions, ma'am.
Okay.
Thank you, ma'am, and thank you, Dr. Anshuman. A very good morning to all of you. From here, I'll be taking this discussion further on chronic obstructive lung disease for a patient who has been posted for laparoscopic cholecystectomy. Now, chronic obstructive pulmonary disease is a heterogeneous lung condition which is characterized by chronic respiratory symptoms, which is because of abnormalities in the airways that can cause persistent, often progressive, and irreversible airflow obstruction. The slide isn't moving. Anyways. Sorry, ma'am, the slide isn't moving. Yes.
Yeah.
Okay. The COPD usually presents with spectrum of emphysema, chronic bronchitis, and asthma, and overlap of symptoms can always be seen. This particular table shows how different sites of airway from bronchus to alveoli are involved with different types of COPD, and etiology and pathophysiology will be discussed in subsequent slides. Two important components of COPD is emphysema and chronic bronchitis. Emphysema occurs because of the lung alveoli and airspace enlargement, whereas chronic bronchitis presents with chronic cough and phlegm, which might be present or not be present with small airway obstruction. Chronic bronchitis is defined as cough with sputum for 3 months in a year for 2 consecutive years. The lungs on COPD show alveolar damage with loss of their elasticity and shape, making it hard for the patient to exhale. There is air trapping, and bronchial tubes, they often get inflamed, narrowed, and congested with thick mucus plug. All these things, they lead to alveolar collapse during exhalation, and decrease in rigidity of the bronchial wall also leads to bronchial collapse during exhalation. Increased gas flow velocity in narrowed bronchioli lowers pressure inside the bronchioli, which further decreases the airway and causes airway collapse. Increased pulmonary secretion will cause bronchospasm and obstruction, and destruction of lung parenchyma presents with enlargement of the air sacs or emphysema. In bronchitis, we see because of the irritants, there is excess of mucus producing goblet cells in the lining epithelium. There is hypoplasia of submucosal glands, inflammation, and the chronic inflammation, they leads to fibrosis. Coming to the pathogenesis of emphysema, there is imbalance in the protease antiprotease system, oxidant antioxidant system, leading to cellular apoptosis and defect in lung repair system. All these leads to destruction of the alveolar spaces and elastin fibers. Physiological implications are airflow obstruction and gas trapping, leading to hyperinflation, generation of autopeep, altered VQ distributions, which leads to pulmonary gas exchange abnormalities, leading to arterial hypoxemia, which may present with or without hypercarbia, and patient may present with dyspnea. One of the late sequelae of COPD is pulmonary hypertension, which may be due to destruction of capillary beds secondary to emphysematous changes and or hypoxic vasoconstriction of pulmonary arteries. Long-standing pulmonary hypertension leads to right ventricular hypertrophy and may precipitate as right ventricular failure, known as call pulmonary. Coming to two important presentations of COPD patient, is the first one is cough with sputum production. Initially, it may be intermittent, followed by persistent cough, which lasts throughout the day. Patients of COPD usually produce small quantities of tenacious sputum while coughing. Patient of COPD, we should or cough, we should also look into the other causes of cough, which may be intrathoracic or extrathoracic. Patient might present with inspiratory or expiratory wheeze with chest tightness in a very distressful condition, and these patients are often fatigued with feeling of tiredness or exhaustion, and they are unable to execute their daily activities. Coming to the etiology of COPD, it has been classified based on the triggering factor. Like genetically determined COPD is called COPD-G. COPD due to abnormal lung development is D. Environmental changes like cigarette smoking cause COPD-C, whereas COPD-P is because of biomass and pollution exposure. COPD-I is because of infections. Associated with asthma is COPD-A, and COPD of unknown cause can be called as COPD-U. When a patient with COPD comes to us, it is very important that we consider whether the spirometry is to be performed or not. So there are certain clinical indicators which has to be taken in mind, like dyspnea that is progressive over time, worsen with exercise, or persistent in nature, presence of recurrent wheeze and chronic cough, recurrent lower tract infections, and other history of risk factors like exposure to cigarette, biomass, pollution, etc. Smoking is one of the dominant causes of COPD. So in next slide, we will be discussing smoking and its effect. Smoking causes impaired phagocytosis, impaired iron metabolism. Lipid metabolism is also impaired with increased cytokine release. The derogatory effects of smoking in CVS are increase in carboxyhemoglobin that reduces the oxygen delivery and increases the work of myocardium, release of catecholamines that causes coronary vasoconstriction, and decreased exercise capacity of the patient. Major risk factor for chronic pulmonary disease is decreased in mucociliary activity, hyperactive airways, narrowing of the small airways, decreased pulmonary immune function, and mucus hypersecretion. These are adequate shift of oxygen leading to tissue hypoxia, impaired wound healing, and hepatic enzymes dysregulation. When a patient comes to us, we also quantify the patient as a heavy smoker, light smoker, like that. And two indicators which we take is pack year and smoking index. Pack year is number of packs per day the patient has smoked multiplied by the number of years. A pack year of more than 40 has high risk, whereas 60 pack years presents with higher risk of post-operative pulmonary complication. Smoking index is number of cigarettes per day and multiplied by total number of years. A patient can be mild, moderate, or heavy smoker based on smoking index of less than 100, smoking index of 100 to 300, or more than 300. There are beneficial effects of smoking cessation. It shows decreased carbon monoxide and nicotine levels, and P50 increases from 22.9 to 26.4 in first 12 to 24 hours. Carboxyhemoglobin level normalize and ciliary function improves within 48 to 72 hours. Sputum production decreases by 1 to 2 weeks. In 4 to 6 weeks, there is improvement in pulmonary function test. 6 to 8 weeks, the patient's immunity increases, and decreased perioperative morbidity has been seen if smoking has been stopped for 8 to 12 weeks. However, if the patient is persistent and doesn't stop smoking, there are disadvantages to smoking cessation as well in the immediate pre-operative period, like increased or rebound hypersecretion, patient's fear of inability to handle the stress, nicotine withdrawal, irritability, restlessness, sleep disturbances, mood depression, and anxiety. COPD, the final diagnosis is made with the help of spirometry. An assessment of the severity of the airflow obstruction can be done. Spirometry also helps us in follow-up assessment and identification of rapid decline. As already said, we usually measure the post-bronchodilator FEV1 by FVC. Now, if it is less than 0.7, a diagnosis of COPD is confirmed. These two graphs show difference between a normal volume time graph and a COPD graph. In a normal patient, FEV1 and FVC are normally 4 liters to 5 liters, but in COPD, we see that FEV1 is decreased to 1.8 liter, whereas FVC is just decreased to 3.2. So the decrease in FVC is less as compared to decrease in FEV1, giving to a reduced FEV1 by FVC ratio. The gold criteria has been discussed: mild, moderate, severe, and very severe. Gold 1, 2, 3, 4 with FEV of 80%, 80 to 50%, 50 to 30%, and very severe when it is less than 30%. This particular volume loop shows the shape of expiratory limb is characteristically curved or dipping in shape in a COPD patient. It is because of the reduced expiratory flow or increased reserve volume, particularly at the lower lung volumes. The peak expiratory flow is classically reduced and airflow is lower than expected, especially during exhalation. The lung volumes, particularly RV, can be increased due to air trapping in the obstructed airways. We often do bedside PFTs. These are easily done and gives a fair estimation of the pulmonary capacity of a patient. We can ask for forced expiration time or duration that a patient can continue to exhale forcefully after a maximal inspiration. If a patient expires for more than 6 seconds, it suggests COPD. Sebra says breath holding time. We ask patient to breathe deeply, not forcibly, and then hold breath. If patient can hold breath for more than 25 seconds, it is satisfactory. 15 to 25% is borderline, and less than 15 seconds suggests poor cardiopulmonary reserve. In single breath count test, we ask patient to take a deep breath and count aloud slowly as fast as possible. The count should be at a speed of 2 counts per second. Normally, a patient should be able to count up to 20, but if patient counts less than 15, it suggests respiratory muscle weakness or poor ventilation. In Snyder's match flow test, the patient's blows out match held at 6 inches. A positive test is inability to blow the match, and a negative test shows maximum breathing capacity of more than 60 liters per minute and a FEV1 of 1.60 liter. Peak expiratory flow rate can be measured with de Bono's or Wright's flow meter. The maximum flow rate achieved during forced expiration starting from full lung inflation. Normal values in male are 400 to 700 LPM. In women, it is 300 to 500 liters per minute. 70 to 80% predicted in mild, 50 to 60 in moderate, and less than 50 in severe COPD. Laryngeal height can be seen, which is the vertical distance between top of the thyroid cartilage and supraesternal notch that is measured during quiet respiration. If it is less than 4 centimeter, it is suggestive of COPD. Before we progress further, it's very important to separate obstructive lung diseases from restrictive lung diseases. Obstructive lung diseases are characterized by reduction in airflow due to partial or complete obstruction, whereas in restrictive lung disease, there is reduction in the volume of lung or thoracic capacity. Spirometry in obstructive lung disease shows reduction in FEV1, and FEV1 by FVC ratio is also reduced, but normal vital capacity. Spirometry in restrictive lung disease shows reduced total lung capacity, but preserved FEV1 by FVC ratio because both FEV1 as well as FVC are decreased in such patients. Increased pulmonary compliance is seen as disease progresses in an obstructive lung disease, but restrictive lung disease, the lungs become rigid and pulmonary compliance is lost. Certain examples of COPD are emphysema, chronic bronchitis, whereas restrictive lung disease are interstitial lung disease, kyphosis, obesity, hypoventilation syndrome, muscular dystrophy, etc. This slide shows gold ABE assessment tool where we grade patient into A, B, and E. A patient comes into E if a patient has an exacerbation history of more than 2 moderate exacerbation or 1 leading to hospitalization, irrespective of the MMRC or CAT score. A patient is grade A if has a MMRC score of 0 to 1, CAT less than 10, or 0 or 1 moderate exacerbation not leading to hospitalization. With the same number of exacerbation and hospitalization, the patient becomes category B when MMRC is more than 2 and CAT is more than 10. If a patient is in group A, more than 2 moderate exacerbation or hospitalization, then we put patient on long-acting beta-2 agonist or long-acting muscarinic antagonists. Whereas group A patients can do well in a bronchodilator. If patient advances to group B, we add both LABA and LAMA. Treatments of patient with COPD consists of smoking cessation, annual vaccination against influenza, pneumococcus, inhaled bronchodilators, corticosteroids, long-acting anticholinergic drugs, home oxygen therapy. If PaO2 is less than 55 and hematocrit is more than 55, or there is evidence of poor pulmonary and diuretics, if right ventricular failure is there, lung volume reduction surgery, lung transplantations, etc. It is important to manage a severe but not life-threatening exacerbation as well. So we assess the severity of the symptom, take an ABG, do chest radiograph, administer supplemental oxygen therapy, obtain serial ABGs, venous gases, and pulse oximeters. Bronchodilators are used. We can also consider oral corticosteroids, consider antibiotics when there are active signs of infections like fever or pneumonia, consider non-invasive ventilation, whose indications will be further discussed. And at all time, we have to monitor that the patient is not dehydrated. Fluid balance has to be monitored, and we may consider subcutaneous heparin or low molecular weight heparin for preventing thromboembolism, and identify and treat the associated comorbidities like arrhythmias, heart failure, pulmonary embolism, etc. Like ma'am said, prehabilitation is very important in such patient to prevent post-op pulmonary complication. It typically begins 6 weeks prior with at least twice weekly supervised session progressing to aerobic and resistance training. A low BMI is a significant independent predictor of increased mortality because of the decreased FRC. A weight gain of even 2 kg can improve patient's functional status. Smoking cessation can be done by behavioral support and pharmacological therapy. Drugs used are dual nicotine replacement pack, bupropion, nortriptyline, cytosine A, etc. Mood, both anxiety and depression is common in COPD patients, and 1 out of 4 COPD patient presents with some sort of depression. Mind-body interventions such as yoga, relaxation, mindfulness were associated with significant improvements in post-operative outcomes. And we can also do pharmacological optimization, which has been discussed in previous slides. Coming to post-operative ventilation and non-invasive ventilation, post-operative mechanical ventilation may be required in patients with severe COPD with a pre-op FEV1 by FVC less than 50% or PaCO2 of more than 50 millimeter of mercury after major abdominal surgeries or in intrathoracic surgery. The aim is to adjust FiO2 and ventilatory settings to keep SpO2 in the range of 88 to 92% and a PaCO2 in the range to maintain an arterial pH of 7.35 to 7.45. If these aims are not achieved, we go for invasive or non-invasive ventilation. Specific indications of NIV in COPD patients is extubation of high-risk patients to CPAP or bilevel positive pressure airway or BiPAP that may reduce the air trapping and work of breathing. Major causes of morbidity and mortality arising during mechanical ventilation in these patients is because of excessive or dynamic hyperinflation with intrinsic PEEP, which increases the work of breathing severely. The aim of NIV is to improve pulmonary gas exchange and to give rest to the compromised respiratory muscles sufficiently to recover from fatigued state. Coming to the mechanism of action of BiPAP, there are 2 pressures applied. One is EPAP, which is expiratory positive airway pressure. Sets IPEEP resulting from expiratory airflow obstruction. Inspiratory positive airway pressure or IPEP augments tidal volume for any given respiratory effort that leads to less mechanical disadvantage, decreases the respiratory rate of the patient and decreases the work of breathing, and there is improvement in the ventilation which shows with reduced PaCO2. The following are the indications for non-invasive positive pressure ventilation. A pH of 7.3 or 7.25 and patients who are non-responders to medical therapy with decreased PaO2 less than 50 and PaCO2 80 to 90 and pH of less than 7.2. But the patient should not be sick or moribund and should be able to protect airway, should be conscious and cooperative. Patient should be hemodynamically stable. There should not be accessory respiratory secretions. Comorbidities should be lesser in number. Patient should have declined intubation or refusal to intubation. And as a weaning facilitator, we can also use NIV, and domiciliary MPPV for patients with recurrent admissions can be used. Initial settings in BiPAP is 10 centimeter of IPAP and 5 centimeter of EPAP. Pressures less than 8 centimeter by 4 centimeter IPAP, EPAP should not be advised as they may have inadequate response. And we adjust IPAP and EPAP to achieve a tidal volume of 5 to 7 ml per kg. I would take the discussion further towards analgesia because analgesia is very important in such patient for post-operative early ambulation and other factors that has been described. And I would particularly like to focus on the role of thoracic segmental anesthesia for laparoscopic cholecystectomy. So renewing the interest in thoracic spinal anesthesia, segmental spinal anesthesia speaks for itself and the block is restricted to specific segment of the body. It has been shown that in MRI images that the mid to lower thoracic segment of the cord, it lies anteriorly and there is a CSF filled space between the dura and the cord. And there is a greater depth of posterior subarachnoid space in thoracic spinal cord. So injury to spinal cord is not an issue here. In this particular slide, we can see that our patient, because the patient is undergoing laparoscopic cholecystectomy, the thoracic spinal A needle insertion level should be between T8 to T11 with a local anesthetic volume from 1.5 to 2.5 ml to achieve a sensory level of T2 to T5. I would like to end the discussion with benefits of thoracic segmental spinal anesthesia. It is a good alternative anesthetic agent in high-risk procedures. There are fewer respiratory and cardiac complications. Better perioperative pain control is there. Early recovery from gastrointestinal function is seen. Less post-operative nausea and vomiting. Early ambulation discharge from hospital has been seen. There is lower incidence of deep vein thrombosis, and other benefits are better pain control without opioids, decrease in opioid requirement during or after the procedures. Thank you. So what is known is laparoscopic cholecystectomy can be performed under segmental thoracic spinal anesthesia in patients who may be unfit for general anesthesia. And the new thing is there are negligible intraoperative and postoperative side effects of laparoscopic cholecystectomy under segmental spinal anesthesia. Caution is to be observed in patients taking 2 or more antihypertensive drugs, as they may have episode of prolonged hypertension with need of vasopressor support. These are my references. Thank you.
Thank you very much, Pallavi. That was very quickly and very, very concisely presented. Thank you very much. I think she's covered all the points that had to be explained that we went through in the case presentation. Are there any questions, organizers? I'm sorry for exceeding the time.
No issues, ma'am. There are no questions as of now, but it was an excellent moderation by you, ma'am. I'm sure that the PGs must have benefited from the expert guidance that you have given to the PGs.
Thank you very much. Thank you.
Thank you so much, ma'am.
Thank
you, Dr. Pallavi.
Thank you, Pallavi. Thank you, Dr. Anshuman. Very well done. Thank you.
Thank you, Dr. Anshuman. Thank you, Dr. Pallavi.
Thank you, ma'am.
So after an exciting session of the long case, we now move on to our next session. And before we are skipping the tea break as we are slightly behind the schedule. Before going on to the next session of ARDS and weaning, we will be having a small 1 minute of MCQs for the PGs to answer for 30 seconds. Can we have the second question, Sudhi? Oh. Second question is, in a patient with COPD, which of the following is the primary concern when using high concentration of oxygen during anesthesia? A option is risk of airway obstruction. B is risk of oxygen-induced hypercapnia, increased risk of breathing, or development of atelectasis. The answers will be flashed after 2 lectures. We'll be skipping the tea break now, as we are slightly behind the schedule. So we continue with our next session, which is a very important session, which is on ARDS, mechanical ventilation in ARDS patients, and on weaning. To chair this session, we have Dr. Animinder Kaur ma'am with us.
Thank you. Thank you, Dr. Anupama.
Dr. Animinder ma'am CV. Ma'am is Director Professor and Head of the Critical Care Medicine at our hospital, ABBIMS and Dr. RML Hospital. Ma'am has various achievements to her name. She is an awardee of Pratibha Samman in 2024. She is a recognized supervisor, guide, and examiner for critical care medicine in Guru Gobind Singh University and NBMS. She is a recognized PhD supervisor for critical care medicine in Guru Gobind University. She has about 50 publications, including publications and also book chapters. Her area of interest are focus and hemodynamic monitoring. We welcome you, ma'am. And we have 2 speakers. Ma'am, would you like to introduce the speakers?
Thank you, Dr. Anupama, for a kind introduction. So our first speaker is Dr. Ankit Sharma. He is a professor in GB Pant Hospital, and he has a number of achievements. And he's a lead intensivist in the first liver transplant in Delhi government, and also he's a course coordinator in the PDCC in the intensive care that they are running in the GB Pant Hospital. So welcome, Dr. Ankit. You'll be speaking of
Dr. Ankit will be joining us later. We'll have a recorded session from him. We can continue with that now.
Greetings from Jipma, New Delhi. First of all, I would like to thank the organizers of Appec 2025 for giving me this invitation to talk about this extremely important topic of acute respiratory distress syndrome. Now, this topic is huge in itself, each subset being a seminar of its own kind. So what I'll do is rush you through the snippets of the important points in the management and the other aspects of ARDS. The overview of this seminar would include definition, history, epidemiology, a brief about the pathophysiology, then focusing upon the diagnosis and its management. So how do we define ARDS? ARDS is acute, severe, life-threatening form of non-cardiogenic pulmonary edema, which is associated with characteristic clinical radiological features, plus physiological consequences such as refractory hypoxia, sepsis, and multi-organ dysfunction syndrome. It's got a huge burden on the healthcare system. The Lung Safe study, one of the largest observational study on this aspect, tells us that approximately 10% of the ICU admissions suffer from ARDS, with almost 20% of these meeting the criteria. And it is associated with extremely high mortality, as high as 27 to 45%. Now, first mention in history is seen in Lancet in 1967 when Professor Ashbog described the syndrome of severe dyspnea, tachypnea, cyanosis, which was refractory to oxygen therapy, loss of lung compliance with possible benefits of PEEP, and benefits with steroid with pathophysiology of diffuse alveolar infiltration. Now, since then, in 1994, a collective effort was made to define it in a better way, and the defined American European Consensus Conference gave us 2 definitions. One was acute lung injury and ARDS, both depending upon the key metrics of timing, oxygenation, chest radiography findings, and pulmonary artery wedge pressure. Acute in onset, if less than 300 PF ratio, was ALI, less than 200 is ARDS, regardless of PEEP. Chest radiography telling us about the bilateral infiltrates seen on the X-ray, with ruling out of the left atrial hypertension, that is to rule out any cardiogenic pulmonary edema, a pulmonary artery wedge pressure of less than 18 millimeters of mercury was taken. But it has a lot of limitations, as the definition of acute was not there. Inconsistency in the PF ratio because the PEEP application would change it. poor inter-observer reliability of chest radiograph interpretations, and possibility of coexistence between high pulmonary artery wedge pressure and ARDS was seen, and the risk factors were not formally included. So it led us to the development of newer definition, that is Berlin definition, which came in 2012, published in JAMA. It defined it as a symptom that begins within 1 week of the insult. The timeline was given. Bilateral opacities on chest imaging, which was shown in the form of not completely explained by the presence of effusion, lobar, or lung collapse and nodules. A PF ratio of less than 300, while on PEEP, more than or equal to 5 centimeters of water. This PEEP introduction was there, and not fully attributed cardiac failure or volume overload, right? And they also classified ARDS into mild, moderate, and severe depending upon the ratio of PF ratio. That is more than 200, less than 300, mild, less than 200 but greater than 100, moderate, and severe was anything PF ratio less than 100 with a PEEP of more than 10 centimeters. So this definition is still valid. It is the consensus definition which is accepted as the latest definition when we are trying to categorize the ARDS and plan the treatment for these patients. But there were other problems, because in most of the resource limited setups, you don't find the ABG. So the way out was found by Kigali, and the Kigali modification was introduced in 2016, where they replaced the PF ratio by SpO2 to FiO2 ratio. That is just taking the saturation from the pulse oximeter and dividing by the FiO2. A ratio of less than 315 without requirement for specific level of PEEP was introduced for the definition of defining and recognizing the ARDS patients. But still, they found that there is further need of refinement of this definition. A new global definition of ARDS was introduced in American Journal of Respiratory Critical Care Medicine in 2024. This definition came up after the massive catastrophe that was seen during the COVID time, and most of these patients were on novel therapies, oxygen therapies like high frequency nasal oxygen, NIV, CPAP. So with the introduction of these newer modalities of oxygen therapy, there was a need to further define the ARDS category, and then this category subdivision, depending upon whether patient is on HFNO of flow of 30 liters per minute or NIV CPAP with more than 5 centimeters of expiratory pressure, we find PF ratio of less than 300 or SpO2 to FiO2 ratio of less than 315. Again, you can recognize the ARDS bedside. The rest of the division of ARDS remains the same. Modified definition and resource limited setup. Again, the introduction of SF ratio was there. Also, they recognize the importance of having the risk factors and origin of edema. The timing and the chest imaging again remain the same. So ARDS is a patient with ARDS can easily be recognized if the cardiac element has been ruled out, PF ratio is sufficiently low, the risk factors are being recognized, the timing is classically defined as per the guidelines of less than a week, and chest imaging rules out the possibility of hypoxemia not completely explained by effusion, atelectasis, and nodules. So this is about how do you recognize the patient of ARDS. Etiology, it could be direct or indirect injury to the pulmonary lining. Direct injury, most common causes are pneumonia, 59%. The ARDS is attributed to a predisposing pneumonia, then followed by sepsis, 16%, trauma, 14%, and toxic elements like inhalational injury and etc. by 8%. The pathophysiology, it is triggered by alveolar epithelium injury, direct or indirect by capillary endothelial injury. Both these will lead to diffuse alveolar damage, leading to fibrin-rich proteinaceous deposit in the alveoli and alveolar basement membrane damage. The microthrombi formation in the capillaries due to upregulation of the procoagulation cytokines lead to the classical vasculitis and the subsequent lack of flow to the areas of ventilation. So this pictograph defines how the complement gets activated by necrotic apoptotic type 1 cells, which are forming the main lining of the alveoli. The type 2 cells remain preserved. This leads to the activation of macrophages, which release the pro-cytokine. There's sort of a surge in the cytokines, which lead to increase in the pro-inflammatory markers like TNF alpha, IL-1, IL-8, and all these further leading to the deposit of microthrombi in the adjacent capillaries. So in nutshell, the alveoli becomes filled with proteinaceous material. The blood supply is hampered because of the formation of the microthrombi. Classically, the histopathology is divided into 3 phases: exudative phase, less than 7 days of onset, leading to diffuse alveolar damage. The repair mechanism starts. Type 2 cells differentiate into type 1. They start releasing surfactant, and the initiation of repair lasts up to 21 days. Further followed by fibroproliferative phase. Most of the survivors regain the lung within a year, and this is how the progress of the ARDS eventually occurs post-injury. Now, few basic concepts we need to understand here. When there is alveolar damage, there is decreased lung compliance. It leads to increased work of breathing. Diffuse alveolar filling, ventilation perfusion mismatch will occur, which lead to hypoxemia. Surfactant inactivation and decreased production, end expiratory alveolar collapse. Favorable response to positive expiratory pressure is explained by this. And dead space ventilation, because the blood flow has been obstructed by the formation of microthrombi in the capillaries. And the systemic inflammatory response that leads to multiple organ dysfunction occurs because of leaking of the pro-inflammatory mediators into the circulatory system. Right? So now we move on to the second concept, that is the baby lung concept, which is a very popular concept when you're dealing with patients of ARDS. ARDS results in significant reduction in the amount of normally aerated lung. Hence, the amount of preserved lung with normal compliance is decreased. So the normal adult tidal volumes will cause overdistension of the remaining normal lung, which is also referred to as the baby lung concept. Now, after COVID-19, 2 specific phenotypes of ARDS were recognized. One is the low elastance, high compliance variant, and the other is high elastance or low compliance variant. They are structurally different types of phenotypes which demand different kind of management. The L phenotype with low elastance and high compliance, the structure of the lung remains fairly preserved, low lung weight, low recruitability. The PEEP will not affect here. And here the main problem is with the microthrombi formation in the microvasculature, whereas the H type, high elastance, low compliance one, is the classical ARDS, which we have the understanding of low compliance, because here the VQ mismatch is occurring at an exaggerated way. Hypoxemia ensures early, high lung weight, but they have high recruitability. PEEP will be effective in the management. So recognition of the phenotype of the ARDS is important because it will lead to immediate changes in your management. So how do you work up a patient? You send all the routine investigations, you send all the cultures, endotracheal blood and urine, cardiac workup is done to rule out any cardiac involvement, pro-BNP marker, 2D echo, rule out cardiogenic pulmonary edema, bronchoscopy may be required to get the samples. In the imaging, which give you the hallmark signs of ARDS, chest X-ray, and high-resolution CD scan, and increasingly finding the use of point-of-care ultrasound in the form of lung ultrasounding. Chest X-ray or CD chest, which is better? CD is gold standard, chest X-ray is quicker and expensive. CT helps in quantifying recruitment and subphenotyping. That is the point where we can change our management if we have the classical phenotype of the ARDS, which is in front of us. And increasingly, lung ultrasound, as I told you, is being utilized for rapid evaluation. And how it helps us, you simply put the probe, see the B lines, the amount of wetness increases by the severity, and you can easily recognize these patterns by getting into the habit of doing a lung ultrasound. And bedside, you can see the severity of the ARDS, and it will help you in the management of the particular case. So in the management of the ARDS, the mainstay of ARDS management is the respiratory support. So non-pharmacological strategies, mechanical ventilation, NIV, non-invasive ventilation, invasive ventilation with low tidal volumes, and the application of PEEP, whereas in rescue therapies comes the role of recruitment maneuver, prone positioning, and other things. In pharmacological strategies, when to use muscle relaxant, steroids, diuretics, and rescue therapy in the form of inhaled vasodilators, which has a very specific role in that particular phenotype where the microvasculature has been affected. Now, most of the subsequent talk, I'll be taking snippets from these guidelines, which were recently published in Intensive Care Medicine Journal, ESICM guidelines on the acute respiratory distress syndrome management. So I will just be presenting in this short time the clear snippets and the hallmark of the management features. Just like sepsis, even the ARDS has been given the recognition to be managed in a particular time frame. And this beautiful paper, which was published in ICE Intensive Care Medicine Journal, gives us a particular timeline of how to do the management of these cases. So it tells us to rule in the diagnosis of ARDS within the first 3 hours of respiratory support. Decision whether to use NIV, HFNC, or CPAP is to be taken at that time. Then to decision to continue or discontinue NIV has to be done within the first 12 hours. To implement the low tidal volume strategies, optimize based upon the various features we'll be discussing in detail in the subsequent slides. Initiate PEEP-based low FiO2 PEEP cable therapy, which was given to us by the ARDS network. We'll also be discussing about it. So in a nutshell, it is telling us that it is a time-bound management. If you do not follow this time-bound management, the mortality of these patients will go very high. So as early as 12 hours, major decisions need to be taken for the management of these cases. Now, what modality will you choose? HFNC, NIV, or invasive ventilation? A word of caution, whenever there is a case of mild ARDS, we are all tempted to put in the NIV or the HFNC, but a word of caution here is don't use NIV in those patients who have worsening respiratory fatigue due to increased work or breathing or persistent hypoxemia, less than 90% saturation or non-rebreathing face mask or NIV or HFNC or worsening hypercarbia. Just don't use it. Go in for the conventional intubation and invasive mechanical ventilation. HFNC, it is the talk of the town, new kid on the block, or everybody is tempted to use it. How does it help? It has a CPAP effect. With every 10 liter per minute flow increase, it gives you a PEEP increase by 0.7. So it has a CPAP effect. It improves oxygenation and decreases work of breathing. It leads to dead space washout, high minute ventilation delivery. Humidification is much easier for the patient to tolerate and also leads to better mucociliary clearing. So the recommendation in the guideline was to use HFNC and NIV in those patients with non-cardiogenic pulmonary edema, or it can be beneficial, but you must understand when not to use it. So this is a score which you can all apply, be familiar with. It's called HACR score. It uses the variables of heart rate, acidosis, consciousness level in the form of GCS, oxygenation, PF ratio, and respiratory rate. So each point is given a particular score. If the score of 5 or below suggests a low risk of NIV failure, anything exceeding 5 indicates a high risk of NIV failure. So if you score this thing on your patient regularly, you will be getting a clear-cut picture of when not to use NIV and when to proceed for invasive mechanical ventilation. Invasive mechanical ventilation, the key concepts here to understand before you move on to the steps of doing it are driving pressure and positive end expiratory pressure, that is PEEP. This is the graph. If you give a sustained volume with a particular flow, this is the kind of pressure time graph you will receive. There's a peak pressure. Once the flow stops, it drops to plateau pressure. It further drops to the amount of PEEP that you have set. So the difference between the plateau and the PEEP is your driving pressure. This driving pressure gives you an indirect inference about the compliance of the lung. So driving pressure, tidal volume upon the respiratory compliance static, CRS. So bedside delta pressure is equal to P plat minus PEEP. And a lot of studies have shown that delta P, that is the driving pressure, is independent predictor of survival in patients with ARDS. Reduction of tidal volume or increase in PEEP was found to be beneficial, only it is associated with decreasing the driving pressure. So the target driving pressure is kept around 14. So you must keep in mind that if you are increasing the PEEP or manipulating the tidal volume, if your target pressure, driving pressure is increasing, you are not giving any good to the patient, you might be harming the patient. Right? So moving on to the steps of initiating the lung protective mechanical ventilation in ARDS, the tidal volume titration start with 6 ml per kg of predicted body weight. Now here it is important. Predicted body weight is the weight that is given for all practical calculations of tidal volume according to the height. So in males, it is 50 plus 2.3 in height in inches minus 60. In women, it is 45.5 plus 2.3 in height in inches and minus 60. So measure the P plat every 4 hours or with every change in PEEP. If the P plat, that is plateau pressure, is more than 30, decrease the tidal volume to 5 or 4 ml per kg. target plateau pressure should always be 30 centimeters of water unless specified in certain specific cases like morbid obesity. Your target plateau pressure should be 30. Higher target up to 35 may be accepted in obese patients, right? Once you are done with the tidal volume, coming to the respiratory rate, with lower tidal volumes, high respiratory rate are required to maintain the minute ventilation. The upper limit is 35. Do not increase the rate if the partial pressure of carbon dioxide is less than 20. Target pH is 7.3 to 7.45. IE ratio is generally acceptable range. 1 is 2 or 1.1 to 1 is 3 is also acceptable depending on the particular situation. So if you start having on your ABG, you have a picture of acidosis. What to do? If the pH goes below 7.3, increase the respiratory rate till the pH is 7.3. So here you are increasing the minute ventilation. If still remains 3 and the respiratory rate has been crossed, consider bicarb infusion. If less than 7.5, then you need to increase your tidal volume and accept a high P plat of 30. So don't forget that you are still dealing with a ARDS situation and you have a baby lung in your patient where there is a chance of polytrauma or barotrauma because the compliance of that small part of the lung, which is normal, will be affected by your tidal volumes. Even in the worst cases of ARDS, there is a fraction of lung which is normal and maintains its normal aeration. So it is important for us to remember that we are just ventilating that normal fraction of lung and not the whole lung. So concept came of permissive hypercapnia. Low tidal volumes would invariably lead to carbon dioxide retention. So where do you draw a line for hypercapnia? The guidelines suggest that 60 to 70 can be targeted. pH of 7.25 has also found to be safe. pH goal remains 7.3 to 7.45. Now comes to the main game in managing these patients on mechanical ventilation with ARDS is to titrate the PEEP, get that magical figure on which the highest compliance is achieved and the best oxygenation can be achieved. So there are two tools. There are a lot of tools. The most important thing is the PV loop, which you can see on the screen of your ventilator. So there is an inflection points, lower and the higher, where they suggest that the compliance between these 2 points, the compliance of the lung is the best. So advantages of PEEP, it's a basic physiological thing. Just for the sake of quick recap, promotes alveolar recruitment, improves FRC, oxygenation, prevents atelectasis, but at the same time, it has certain drawbacks: over distension, decreasing cardiac output, venous return is reduced, and can lead to increased ICP and increased planned circulation. So how do you titrate the PEEP? Optimal PEEP is the PEEP which one gives best recruitment and oxygenation and also prevents villi, that is ventilator-induced lung injury, prevents cycles of recruitment and recruitment, also prevents alveolar distension. So there are a lot of ways how do you titrate PEEP. The earliest one is the ARDS-net low PEEP table, where FiO2 and PEEP are correlated, and as the FiO2 is increasing, you start increasing your PEEP, but you have a danger of going overboard and causing more damage. So a lot of other things came in, driving pressure-based incremental or decremental PEEP, which we commonly do. We increase or decrease PEEP by 2 centimeters. Keep looking at the plateau pressures and peak pressures. Where they start becoming divergent or the driving pressure starts to increase, that is the point you stop. You start reducing the PEEP at that point. There are other methods of using transpulmonary pressure because transpulmonary pressure has been gained a lot of significance. It is the actual pressure which distends the lung alveoli. The goal is to keep end expiratory transpulmonary pressure to -2. Then you just discussed about the PV loop. How do you select the PEEP just above the lower infection point? And other things, modern things are available like stress index. That can also be used for titration of PEEP. Now, there is a subset of patients which will not respond to your initial management. So the PF ratio remains less than 100. Saturation remains less than 88. With an FiO2 of more than 0.8, despite all your efforts to optimize the ventilation. So there are the things you can use. There are 8 P's. You use more recruitment maneuvers, induce diuresis, you prone the patient, you paralyze the patient for achieving better ventilation. There is pleural effusion, you evacuate that, use of inhaled nitric oxide to cause vasodilatation in that subset where the microvasculature has been affected, and proactive use of advanced modes of ventilation like APRV, steroids, and ECLS are further things. So let's quickly just review what is a recruitment maneuver. It's a method to open the collapsed alveoli. How it is They find reaeration of previously gasless pulmonary units. Difference between expected respiratory compliance versus measured after peak is increased. You use PV loops to induce the recruitment maneuvers. There are a lot of recruitment maneuvers types are available: sustained inflation, stepwise recruitment, decremental PEEP method, single size, and proning. Advanced modes of ventilation, the one which finds most mention in literature is airway pressure release ventilation. Here they've seen that the success in extubation which was achieved was very significantly higher in the group where APRV was used. Up to 39% of the patient lead to successful extubation. Now, discussing about the APRV is beyond the scope of this talk, but still to touch upon it, a higher and a lower pressures are delivered during the respiratory cycle, and the patient is allowed to breathe in both these phases. Spontaneous breathing is allowed. So difference between the two is the one which leads to the effective ventilation to these patients. And it has been found that this is a beneficial mode to be used in ARDS patients. Coming to the proning, proning is simply allowing your patient to be ventilated chest down. So what is the physiology behind it? Why is it so popular? Why did it gain so much of popularity? So once you prone the patient, it was found that the compliance of the lung is spontaneously increased. The dorsal alveoli get more space to open up. So this significant effect in the physiology led to the acceptance of proning as a method of treating patients with ARDS, which were refractory to simpler management protocols. How does proning help? It improves the VQ ratio, reduced ventral lung compression, recruits the dorsal lung regions, reduction of ELI, enhanced secretion clearance, improved chest wall compliance. Timing and duration, start early in moderate to severe ARDS where PF ratio is less than 150, prone for at least 16 hours, at least for 2 days, but duration has not been mentioned in the guidelines. And this was the PROSIVA trial which brought into the picture. Trial had to be stopped midway because significant amount of benefit which was seen in the patients who were prone led to the acceptance of this trial, and this has become a mainstay in the treatment of refractory hypoxemia in ARDS patients. But there are certain contraindications you should always be aware. Absolute unstable spinal fractures, unmonitored increase in ICP, relative open abdomen. Obviously, you cannot be proning these patients. So that finds a strong recommendation in the guidelines. What about the neuromuscular blockade? There were trials like Accurasis have shown that neuromuscular blockade for 48 hours has mortality benefit, which was sort of challenged by another trial, Rose trial, but the former was a strong trial. So 48 hours of neuromuscular blockade in ARDS became the norm. But until the recent guidelines, they've suggested strongly against the routine use of infusion of neuromuscular blockers to reduce the mortality in patients with moderate to severe ARDS. So you should not be paralyzing these patients unless you have a strong indication to do so. For example, you cannot prone the patients without neuromuscular blockade. Here it is advisable, but not as a routine method. Should not adopt neuromuscular blockade to it, give it to any patient of ARDS just to improve the ventilation. How to do it and when to do it? Not more than 48 hours, only if PF ratio is less than 100. The most advocated agent is cisatracurium because it is known to decrease inflammatory cytokines, and initiation of use should be within 48 hours of onset of ARDS. Fluid management, debatable topic. Restrictive and liberal approach both have been studied very closely. Restrictive approach limits excess fluid accumulation, reduces the risk of pulmonary edema, improving oxygenation. However, it may lead to renal hypoperfusion, so there is more chance of AKI in these with adoption of restrictive approach, whereas a liberal approach may worsen pulmonary edema, reduce oxygen delivery, damage to distal organs due to fluid overload and hypovolemia. So what is required is close monitoring of hemodynamics, dynamic indices of volume flow and volume status, fluid responsiveness. That is very crucial to guide the fluid therapy. What about the corticosteroids? The 3 trials as early as 2007, the Meduride trial, which was most popular. Villar et al. Also mentioned in Lancet in 2020, and then Lane et al. Mentioned that pooled analysis revealed that glucocorticoid use was associated with reduced mortality with a very significant percentage. So when do we use it? How do we use it? So I am discussing about the results and the recommendations given by the Meduride trial, where they use methylprednisolone in early ARDS. They gave recommendation for early severe ARDS and late unresolving ARDS. Early definition, they included up to 7 days of the insult or the detection of ARDS. Early severe ARDS, they said that if you use methylprednisolone in the dose of 1 milligram per kg as a bolus, keep on using it up to the 4th week, and there is a particular method of using it, 1 milligram followed by 0.5, 0.25, and further tapering. Whereas the unresolving ARDS, which is observed after 7 days, the dose was higher. And it has shown some promising result. And use of steroid is still debatable. It has to be very carefully decided which subset of patient. Timeline of ARDS, early ARDS, definitely it might be useful. Late ARDS, it might even be harmful. Coming to the extracorporeal life support, ECLS techniques that provide cardiopulmonary support and gas exchange, 2 of them are popular, ECMO and extracorporeal carbon dioxide removal, that is ECOR. Veno-venous ECMO is the configuration most commonly used for respiratory support, key modality in the management of ARDS, whereas ECOR is to provide carbon dioxide removal without providing substantial amount of blood oxygenation. Where the permissive hypercapnia is failing, ECOR can be your lifesaver. Indications for ECMO, instituted when despite optimized protective ventilation and with a higher FiO2, the pH still remains low, PaCO2 is rising, PF ratio cannot be achieved. But the timeline has to be kept in mind. It has to be less than 7 days of ARDS. Contraindications, any condition that precludes the use of anticoagulation, because the ECMO cannulas require to be used with severe, well, exaggerated form of anticoagulation. Otherwise, the entire system will fail, right? Not going into the detail, this trial which made ECMO as a mainstay of therapy in refractory hypoxemia was CESAR trial. Talking about the inhaled vasodilators, as I told you, that subset of patients in ARDS where microvascular thrombi has been affected leads to dead space ventilation, will not be affected by your PEEP therapy. Inhaled vasodilators can be a lifesaver. The agent used is inhaled nitric oxide. The randomized controlled trials of INO in the treatment of ARDS have shown short-term physiological benefits, but still not the mainstay of therapy, has not been accepted as the mainstay of therapy. And when to wean the patients once your patient has started to recover. So there is a timeline of weaning, the weaning path. You have to recognize when the patient is ready to wean, ready to breathe, and ready to extubate. Common protocols are followed for weaning as in any other condition. The reversal of cause of respiratory failure, with good sensorium, spontaneously breathing, with a good acceptable FiO2 of more than 200, hemodynamic stability, ability to cough, respiratory rate is within physiological limits of less than 35, PEEP is less than 8, RSBI, that is rapid shallow breathing, is less than 105. Now, when do you extubate? You put patient to a spontaneous breathing trial. A successful trial will let you know that the patient is now ready for extubation, right? So this is a pictograph depicting of what we have discussed so far. So the mainstay of therapy in ARDS when you're dealing with respiratory failure per se is using lung protective ventilation, low tidal volumes, 6 ml per kg of predicted body weight, keeping your plateau pressures less than 30, check for hypercapnia, allow for permissive hypercapnia, go to higher levels of PEEP if the PF ratio is falling, use neuromuscular blocker, prone positioning, and finally, the role of ECMO cannot be overlooked. So the new guidelines are clear about certain things: protective lung ventilation with low tidal volume, early proning, strong recommendation from both American Thoracic Society and European societies, whereas they have a difference of opinion when to introduce ECMO. ESICM strongly endorses the use of ECMO. Strong recommendation against the use of neuromuscular blockers and corticosteroids, conditional recommendation for use from ATS guidelines, whereas it's not been addressed in ESICM. So in summary, it all begins with low tidal volume, protective low tidal volume ventilation, moving on to other aspects like prone ventilation, conservative fluid management, keeping a tab on the driving pressure, newer modalities of monitoring like mechanical power reduction, use of inhaled nitric oxide, inhaled pulmonary vasodilators depending on the recognition of the phenotype, careful use of neuromuscular blocker, glucocorticoids, and coming to ECMO in those cases which are refractory, but the timeline of 1 week is there. You can bring these patients out. So thank you so much for patient hearing. For any questions,
Thank you, Dr. Ankit, for a very well covered, massive topic of ARDS. So, if there are any questions, you're welcome.
Ma'am, there are no questions as of now.
Okay, then
No
we can
questions.
quickly move on to the second speaker. Yeah, introducing the second speaker, that is Dr. Sohan Solanki. He is a professor at the Tata Memorial Hospital, Mumbai, and he has a number of major achievements, like he is the Best Researcher Award in 2022 and a Young Anesthesiologist Award in 15. Along with that, he has a number of over 100 publications in many national, international journals, and he has editors of 2 books. And his main areas of interest are that he has opioid-free oncoanesthesia and difficult airway management, and again, research methodologies again is another area of interest. So welcome, Dr. Solanki, for your next talk on weaning.
Thank you. Thank you, madam. I will share my able to see?
Not able to see. You started sharing, but can't see the slides. There's some issue with the, I think, can I send my slide and you can share it? Yes, you can. You can send the PPT and share it from our end.
So where should I send?
You can send it to me.
Okay, on the group only or somewhere else?
WhatsApp. You send me on my personal WhatsApp. I'll just share it.
Okay, okay. I'll just send it. Okay, let me just try again. Yeah, able to see now?
Yeah. Yes, we can see. We'll make it full screen.
Okay.
Yes.
Okay, thank you very much. I'm Dr. Sohan Solanki, and I'll be speaking on this winning and how this winning fails sometimes when we try to win. So in this talk, we'll talk about like what is winning, how do we win, how do we predict the winning success and failure, and what are the various reasons when there is the failure of the winning, and how we overcome this winning failure. And we also talk something about what is extraction failure, why it occurs, and can it be predicted, and how do we manage extraction failures. So winning is a gradual this withdrawal from the ventilation, and where we transfer work of breathing from ventilator to the patient, and it may take several hours to several days. Whereas the discontinuation is just sudden withdrawal of the support from the patient, and it is mostly suitable for a patient with the short-term ventilation, like a post-op patient or any drug overdose patient, where you can directly discontinue rather than wean. And what is weaning failure? Weaning failure is where the inability to the patient to sustain a spontaneous breathing for 24 or 48 hours. And what is extubation failure? It is the need for the re-intubation within 48 to 72 hours. So it is all the definitions here. So we'll go by this case. This is a 54-year-old male with mild COPD. He was intubated for respiratory failure following bilateral pneumonia. So he had 4 days of antibiotics and ventilation, and X-ray is now clearing. His PEEP is 595, This FiO2 is 40%, and this SaO2 on EBG is 96%. He's awake, he's making effort to breathe. So now, how do we wean, and when should we wean? So we'll just talk on this about, yeah. So, sorry. So to wean, we need certain prerequisites in the patient. So like there should be always an improvement of the etiology of the respiratory failure. So for whatever reason the patient was put on the ventilator, there should be improvement in the etiology. There should be appropriate respiratory drive as indicated by the spontaneous breathing. Also, there should be return of the adequate airway protecting function, and this will be need for the infrequent suctioning from the airway. So this the like there should not be any like major secretion in the airway and the your respiratory tract. So also we need the patient should be alert. Then and when we assess the patient, there should be no dyspnea, no use of accessory muscle. There should be no any abdominal paradox. There should be no agitation, no anxiety, and that the patient should not be having any tachycardia. Patient should be hemodynamic stable. His oxygen should be good. The PF ratio should be at least more than 150 or more than this 200. His SpO2 should be more than 90 or 92%, and FiO2 requirement should not be more than 0.4 or 0.5, and the PEEP should be at around 5 centimeter water. It should be okay, and this should be a good this negative respiratory force, like it should be more than the 25 centimeter water, and this RSBI should be less than 0.5. We will talk about RSBI later on, and should be this expiratory tidal level should not be too high to the not support the breathing. So when we talk about this RSBI, is the this rapid shallow breathing index. So it is the this respiratory rate divided by the tidal volume in liter. So we'll talk in the next slide about this, and this would be also a good compliance rate. Oxygen should be all in that particular manner, and your airway oxygen the pressure we can also see in the next slide. So this RSBI is what is the this rapid shallow breathing index. I told you it is the this respiratory rate divided by the tidal volume in liter. So suppose this patient is having this rate of 25 and tidal volume of 300. So this RSBI is 25 divided by 0.3. So that 0.3 liters is taking. So it's the 83. It means so it is less than 105. So the patient passed the RSBI test. So now it is ready for the weaning. But suppose this patient is having this rate of 40 and taking only 200 ml of tidal volume. It means if 40 divided by 0.2, it is only 200 of the sorry, it is 200. So the patient did not pass the RSBI test and is not really ready for the ventilation. So in this breathing, like whenever there is some respiratory failure, always it is the low tidal volume and high respiratory rate that lead to the failure of the weaning. I also told about this airway occlusion pressure 0.01. It is the airway occlusion pressure. It is the negative pressure in the first 0.1 second of the inspiratory effort against the occluded airway. It is always an effort independent measure of the respiratory drive. So it is the normal value is around this 1 to 2 centimeter water. And if it is high, like if it is more than 3 or 4, then it can suggest that there is an increased distress in the patient. And if it is low, it means the patient is having a low effort or a very weak inspiratory effort, and or a major central depression of the breathing. So that if the patient is having either a high or a low this P.01, it means the patient is still not ready for the weaning. So we should do this weaning either by a physician like guided or a protocol guided. So like I can talk about this study. This is the randomized control trial of the 350 patients where they divided like into the physician and the protocol and directed weaning, and the primary outcome was the duration of the the ventilation, and the secondary outcome was the need for reintubation, the length of hospital stay, the hospital mortality rate, and the cost. So this found that whenever there was a weaning based on a particular protocol, the weaning was higher in patient with the protocol directed weaning. Also, the duration of the ventilation was also like shorter, and the hospital cost was also low in patient with in whom the wean as per the protocol. In So like in another study, they made this protocol of like this spontaneous awakening trial along with this spontaneous breathing trial, and they like divided into like again two group, this SAT with SBT and the usual care with the SBT. So they found that the patient in whom we like did a protocol guided weaning was having the the weaning success was good, the patient were extroverted better, and the mortality was also low. So they say always say make a protocol based for the weaning. So what protocol they made? So they after the year they like started of the the ventilation. So they like did this the spontaneous awakening test, and then they perform, and then they did this SBT, and then they perform SBT, and then they consider extubation. If any of time this either SAT or the SBT failed, they again put the patient on the ventilator. So that every morning you can assess the patient for the readiness of the SAT and the SBT, and then you can decide if the patient is ready for the weaning or not. So like what are the signs of the various failed SBT? So like whenever your patient is having a high respiratory rate, like more than 35, or this low SpO2, or the patient is having a tachycardia or a sustained increase in the heart rate, or like either the hypertension or hypotension, patient having agitation, diaphoresis, anxiety, or increased work of breathing in terms of like patient is using that SSG muscle, or patient like breathing is paradoxical or asynchronous, or there is just some intercostal detection or a nasal flaring. In all these cases, you can say that my patient will fail SBT and patient is really not ready for the weaning. When you say that my patient passes the SBT, so like you can have a good fair chance that my patient will be off ventilator for next 48 to 48 hours, and then you can extubate if the patient is awake, if he can protect the airway, if there is some sufficient strength of the cuff and patient is able to clear the secretion, and also there is a presence of the cuff leak. So the cuff leak we see to see any like leak from the cuff when we did the deflate the cuff. So it means it will there is no some edema into the airway. Also, if there is if the patient need any re-intubation within 48 hours, we can say the failed extubation. In that case, we can consider to do a tracheostomy. If you think that your patient is unlikely to get extubation again in near future, and if your patient is failing extubation again and again, so in those cases you can consider doing a tracheostomy for the faster weaning. So why do they this weaning failure occur? So the main reason is the incomplete resolution of the illness, which lead to this mechanical ventilation or development of the new problem. And there is always an imbalance between the respiratory muscle load and the neuromuscular competence of the body. So about the factor which can cause this weaning failure is the like it may be some because of increased load in the lungs, it can because of the some bronchospasm, airway edema, or some upper airway obstruction, or patient having OSA. It may be sometimes the tube king, or the tube is blocked by some secretions or incrustations. In all these cases, your patient can have an increased load, and also there may be some like effusion, pneumothorax, flares, chest, obesity. All these can cause the increased chest wall elastic load, and that can lead to the weaning failure. And also, like patient we can have a increased load as because of the increased lung elastic load, like in the hyperinflation because of auto PEEP or the intrinsic PEEP, and also because of some edema, infection, atelectasis. All this can lead to the increased load in the lungs. About the decreased neuromuscular competence, it may be because of the some drug overdose or some brainstem lesion, or because the patient not had sleep enough, or because of some disease like this hypothyroidism and this malnutrition or respiratory alkalosis, or because of some muscle disease. And also like there is some muscle weakness because of some electrolyte imbalance or like myopathy. All these things can correlate to the this decreased neuromuscular competence and can lead to the weaning failure. this winning failure can also be because of the thing is this critical illness polyneuropathy, which is the like major cause of the winning failure in the ICUs, and also that some other like disease like the Guillain-Barré syndrome, myasthenia gravis, or some palsy of the nerve or spinal cord, that can all lead to the winning failure. Sometimes like because of the during winning there maybe some heart failure or the serious failure, because whenever we like convert from the mechanical ventilation to the spontaneous breathing, there's always a change of the positive pressure to the negative pressure that can lead to the increase in the venous return and the RV preload increase. So that can lead to the RV failure also. So like in those cases, we can use an NIV to like reduce the afterload, and then we can also give some drugs to like overcome this problem. This study published in Chest in 2017, they found like what are the like various recommendation based on the patient and doctor and some policymaker, and they made them answer 6 questions based on how we should like wean the patient from the ventilator. And they found that whenever we want to like wean any patient which is acutely hospitalized for more than hospitalized and the ventilator for more than 24 hours, we should always do an initial SBT with the inspirated pressure augmentation. Like we should always do SBT with at least 5 centimeter water of the PEEP. We should not be directly do the this SBT with the TPs directly. So we can give some like inspirated pressure when we do the start the weaning. Also, we should always stop or reduce the sedation level whenever you try to do the SBT. And also we can use this NIV before extubation in this patient, so that there will be some positive pressure. We can like open the airway and can help in better weaning. Also, this should be we can have some protocol to rehabilitate this patient for the early mobilization. Also, we can have a proper protocol of the weaning, and we should always have a cuff leak test whenever we suspect any edema or the problem of the post-extubation stridor. In those cases, we should do a cuff leak test, and if this negative cuff leak test, we should always give some steroids to prevent any reintubation. So these are the 6 questions they answered, and I think this is all very important when we try to wean the patient from the in the ICU. So like now the question is like, is there any role of the NIV when we try to wean? So like it can be like NIV can be used either for the preventive treatment to like before the after the extubation, or as a rescue therapy for the extubation failure patient. So this our ICCM guideline, they say that the SBT in any patient who are trying to in whom like any COPD patient with tried to wean, the SBT should be given at least after 48 hours of the vestibular on the mechanical ventilation. And if the patient fails the SBT, then we again stabilize the patient before trying to wean. And after stabilization, extubate the patient on the NIV only, and apply initially we should apply NIV continuously for at least for a day. We should only discontinue the NIV only for like patient for feeding or drinking, something like that, and gradually we should reduce the NIV according to the patient requirement. So NIV is a very useful things when we try to wean. So it will always prevent your extubation failure, and it can also give you the rescue things when the patient is having a extubation failure. Now thing is that can the tracheostomy help in better weaning? So like this study published in 2010, JAMA did this early versus late tracheostomy, and the equal number of patients were divided randomized to the either early track or the late track, but they found that there was the less VAP in the patient with the early track. There was the less ICU stay, the less days on the ventilator, but there was no difference in overall mortality in the patients. Again, this study also review of the 13th trial of more than 2,400 patients, and they also found that there was no difference in the all-cause mortality in the ICU. That in the ICU if we do either late track or early track. Okay. but the incidence of the VAP was lower. They were like, but there was no difference in the 1 year mortality. Again, this trackman trial, they the early versus late track, and they also found there was no difference in the all-cause mortality, no difference in the 2 year mortality, no difference in the median length of ICU stay, and they also found that there were the track related complications were higher in the patient with the early track. Now it comes to the like final things, like talk about the failed extubation. So why the patient failed extubation? There are certain reasons where the patient can fail the extubation. The patient may need the re-intubation within like 24 to 48 hours. So like the main reason like that the patient having the hypoxemia or the increased volume of breathing, or the patient is not able to clear the secretion from the body, or the patient is not adequately alert, or like the decrease in the consciousness, and all of the regions can lead to the various failed extubation. And the patient in the and also the ICU mortality or the overall mortality is also always high in the patient who failed extubation rather than the patient who never failed the extubation in the ICU. So like other things we can predict where the failed extubation, like we can also see like these 4 simple types. We can tell the patient to open eye, we can like follow the eyes, we can grasp the hand, we can tell the patient to stick out the tongue. This is also a good like a test. We can do this bedside test just to see that the patient will fail extubation or not. Also, this is like again this good test. This minute ventilation is recovery time, where like we can like see the in how much time the patient is recovering the minute ventilation. So that is also an important test to see the patient they will fail extubation or not. Sometimes you can also see this difference between the PuC2 of the arterial versus gastromucosal blood. So that will also tell you about the patient. Is also a good predictor to see the patient will fail extubation or not. Also, you can do a cuff lick test. You can do ultrasound of the larynx and the upper airway, and also you can do ultrasound of the diaphragm before you extubate the patient, and you can predict the patient will my patient will fail extubation or not. Also, like whenever you suspect that your patient may fail extubation and or patient may go into the post-extubation stridor, in those cases you can give some steroids before after the extubation to prevent the reintubation. So there's a study like they did in the 760 patients, with they give the 20 mg of this methylprednisolone and versus the placebo only, and they found that the incidence of post-extubation and edema was very less in the patient with the steroid, and there was no incident, there were very less incidence of the reintubation, and the patient were having very less incidence of the edema, and also so the steroid can help to prevent the reintubation and the post-extubation stridor. So like you should always have a weaning protocol in your ICU or in your hospital. So a weaning protocol can be like we can do a daily interruption of the sedation. So you can fix your time of the stopping sedation. You can time of the assessment. You should screen patient daily. You can perform RSBA test daily. You can do SBD for 2 hours, and the patient passes the SBD, like if the patient having a good cuff strength, a good CNS status, and there no secretion, and the patient having like cuff leak, then you can extubate that patient. And for the extubation should be done on a proper time with the proper personnel in the ICU. And after the patient fails the SBD, should always give time to recover the patient before you again try for the SBT. And do not use the SIMV as a weaning tool. Always use either CPAP or the TPs for SBT. So SIMV is found to be inferior in terms of the SBT, in terms of like this weaning failure and extubation failure. And always consider a tracheostomy, and consider the systematic extubation and NIV in COPD patient. So in the COPD patient, it can help in better to preventing the this extubation failure. And always a balance between the excessive aggression and excessive caution should be there in the ICU. Like I can tell, we should not be hastening like too much for the weaning, we should not delay also too much weaning. So like I can say like these patients should not be weaned. We can say weans not like patient having a disease or a heart disease or any electrolyte imbalance, patient with anxiety, any neuromuscular disease, patient with infection, or patient with like some malnutrition, opioids, and thyroid disease. These patients should not be in hurry to wean. So I will also acknowledge my teacher, Dr. David Divetia, and thank you very much for listening. And I'm ready to have any questions there.
Thank you, Dr. Solanki, for a very lucid presentation on weaning, how to do weaning, and what do you understand by weaning failure. So this house is open for questions. If there are any questions from any of the PGs or residents.
There is one question on weaning, just not received. Why is it so difficult to wean a COPD patient?
So like COPD patient, like they always have like the auto peep and like this thing, air trapping and all these things. So so I can say like airway things the better. So like auto peep and all these things, they are always difficult to wean, and like okay. So
Dr. Solanki, I would just like to add something that it's a very good question that why the COPD patients are very difficult to wean, because they have there are problems in their heart-lung interactions, you know. So whenever we are talking about a COPD patient who is for weaning, we have to understand that there is a concept of weaning induced pulmonary edema, because in these patients, they have a right heart failure. They have a right heart dysfunction. And once the patient is changed from a controlled ventilation to a spontaneous breathing, there will be an increase in preload and an increase in afterload also.
yes, yes.
Many a times this thing gets evident, you know, they go into pulmonary
so like
edema.
I mentioned in the spontaneous breathing or like this exercise in those patients. So like
Yes.
whenever we try to wean, there's always like RV failure. All these things can lead to weaning
Yes.
failure.
I think this particular thing we see not only in COPD patients, but also patients having other kinds of cardiopathies, like your patients with some underlying cardiomyopathies are there, some myocarditis are there. So most of the times we see that the cardiac issues involved with weaning, they are generally not covered. So we have a separate topic on that, you know, the cardiovascular dysfunction associated with weaning. So I think that is again another topic to cover.
Yes, ma'am. I think that should answer the question. Thank you, Dr. Sohan. We have another question for Dr. Ankit. I think Dr. Ankit has logged in. Is Dr. Ankit there?
Hello, ma'am. Yes. A very
Yes,
good
ma'am.
afternoon to all.
So we have
And so
very good
sorry I could
afternoon.
not join earlier because was busy in one of my own workshops. But please, I would happy to answer any questions.
We are happy to have you now. So the question is, are there any important drawbacks of the current revised definition of ARDS?
See, what we have till now as a definition of ARD, new definition, global definition of ARDS law is still a commitment, but it has not been accepted as a part of a definition in the guidelines, any of the guidelines, ISCCM guidelines or European Society guidelines. And what they did was to deliver the drawbacks which were there in Berlin definition, like the impact of the risk factors, which was one and the most important thing, and the new modalities of oxygen therapy, which came in vogue during the COVID time, like having a CPAP or HFNC. So these 2-3 things included in Berlin definition almost makes it complete. But yes, the consensus about the actual timeline from the onset of risk factors or the onset of symptoms is still not clear. I think that is a gray area still remains unanswered. Whether we should take the time of onset from the onset of symptoms or the onset of risk factor detection, that makes it a very complex one. So it's still a debatable topic. But till now, as a definition, we accept the Berlin definition as the one which is there in vogue in the guidelines. But the consensus statement tries to answer these deficiencies in the Berlin definition. That is what is the new global definition, but it's still not accepted as a definition. Guideline it has not come into the guidelines so far. Yeah.
There is another important thing in the new global definition, that is the role of lung ultrasound.
Yes,
Because
yes.
you see, in resource limited settings where there is no availability of chest X-ray or even CT scan, it is difficult to transfer the patient to the CT room.
Exactly.
So,
The role of the ultrasonography for evaluation of ARDS, depending upon the number of B lines, coalesced B lines, and complete whiteout pattern. Still, it is not. It is there. Definitely, it has a lot of meaning because it gives you a right there bedside method of determining the severity of the ARDS. But so much of observer variability is there that to accept it straight away in the form of a guideline, I think they will have to do a lot of RCTs to do that.
Yes, ma'am. I think that should answer the question very well. Thank you, ma'am, for your expert comments. And thank you, Dr. Ankit, for joining us. Thank you, Dr. Sohan. We would like to conclude
Thank you
this
so much,
session.
ma'am. Thanks a lot, ma'am.
Thank you, Dr. Renu.
It's a privilege to
Thank
be
you.
a part of this program. Thank you. Ji.
Our pleasure.
Thank you.
Thank you, Anunda ma'am, for an expert session. Thank you so much. So with this, we conclude
Thank
this session on ARDS and weaning. So as we are behind schedule by almost 40 minutes, so we will be going on to the long case, which is a very interesting case of long-standing diabetes on insulin. Patient is on insulin, posted for amputation of the right foot. To moderate the case, we have our expert, Dr. Bharti Wadhwa ma'am. And can we have her CV? Madam is Director Professor at Maulana Azad Medical College. She has various achievements to her name. She is a National Coordinator for Academic Program at NBMS. She is a Member Education Review Committee in ICA. She is a Fellow of ICA. And she is an examiner of MD, DNB, and DA courses. She is an external expert in various committees. And she is an expert in PGDIMS, Rohtak University. She is a faculty expert at NIMS, Port Blair, and ESI Corporation. Her areas of interest are obstetric anesthesia, analgesia, and research. We are fortunate to have such an expert in our session. So without wasting further time, I would like her to take over the session. We have with us our PG, Dr. Amala, final year PG, and we have our Dr. Tisha and SR who will be summarizing the case. Over to you, ma'am.
Good afternoon,
Thank
ma'am.
you. Wishing everyone a very good afternoon. Today we have a case of diabetes mellitus, and it's a very important case for the exam point of view. Not only is it very important in the Viva, you will invariably get a question in your theory exam also on this topic. So we'll start with Dr. Amla presenting the case to us. Amla, try to wind up quickly because we'd like to come straight away to the discussion of the case then.
Yes, ma'am. Good afternoon, ma'am. My patient, Mr. Ravi, 60-year-old male, a resident of Rajendra Nagar, Delhi. He is a painter by occupation. He came with chief complaints of wound over the left foot since 6 months, blackish discoloration over the left foot since 3 weeks. History of presenting illness. My patient was apparently well 6 months back when he developed a small traumatic wound over the lateral aspect of left foot. Initially, it was size of his finger breadth, localized to the base of little toe, later progressed to the size of his palm, involving the lateral aspect of foot, extending up to the lateral malleolus, associated with foul-smelling yellowish discharge, along with swelling and redness extending into leg. It was not associated with pain. Over the past 3 weeks, patient also noticed blackish discoloration over the tip of little toe, which has at present extended into forefoot. It was associated with on and off fever without chills and rigor, which was relieved by over-the-counter medications. No aggravating and relieving factors, no history of prolonged standing or lifting heavy weights, no history of difficulty or pain while walking or at rest. No history of deformity in foot or toes. There was no history of similar complaints on the other leg. There is associated tingling and numbness sensations of both lower limbs. He also noticed increased frequency of urination, thirst, and easy fatigability. No history of repeated falls, loss of consciousness and weakness of limbs. No history of chest pain, breathing difficulty, palpitation. No history of facial swelling, burning maturation. No history of giddiness on standing, nausea, vomiting, abdominal bloating, constipation, but complaints of nocturnal diarrhea occasionally. No history of blurring of vision or frequent change of spectacles. No history of fainting episodes or altered sensoria. Past history, no history of similar complaints in the past. Non-case of type 2 diabetes mellitus for 8 years on medication. No history of hypertension, asthma, tuberculosis, coronary artery disease, jaundice, seizures, or thyroid disorders. No history of any prior hospitalization or blood transfusion. No history of any non-drug allergies. Personal history follows mixed diet, no history of smoking and alcohol intake, no drug addictions, increased bladder movements with a frequency of more than 15 times per day, and increased bowel movements, due to which my patient had altered sleep pattern. Treatment history, patient was previously on tap metformin 500 mg BD since 8 years, currently on tap metformin 1000 mg BD and tap sitagliptin 100 mg OD, and injection glargine 10 units subcutaneous HS since 3 years. He was non-compliant to medications. Family history, no history of similar illness in the family, no history of other long-standing illness amongst the family members. General physical examination, patient
Just wait, Amla. Let's just go back to your slide. Now, from your history, what do you infer from your history?
Ma'am,
What do you think this patient is suffering from?
I have a 60-year-old, my patient is a 60-year-old male patient having a progressively non-healing wound, which was progressive in nature, which was painless, most likely due to diabetic ulcer.
So you have a patient with a diabetic ulcer. Now, in your history, you mentioned a very important point in your history. I don't know whether you realized or not, was that the ulcer had no pain. It was not associated with pain. It's an infected ulcer. There's redness, there's swelling, but there's no pain. So what does that signify for you from the history? Your voice is gone.
He's having features peripheral neuropathy, ma'am. He's diabetic.
So you also have a patient with a peripheral neuropathy. Is my voice cracking or your voice? Am I audible, or are you having a problem with the net? Am I audible?
Since he's having a decreased sensitivity.
Am I audible? Am I audible?
Yes, ma'am, you're audible. Yes, ma'am, you're audible.
Because Amla's voice is going off and on and off. It's not very clear.
We'll check her connection, ma'am.
Yeah. So basically what I was trying to tell you here was that this patient, the history, don't keep switching off your, you switched off your microphone. I can't hear Amla.
Amla, say something. Ma'am, I can hear right now, ma'am. I can hear.
Okay, but I think you've been repeatedly switching off your microphone, so just be careful. You don't touch that, huh?
Yes, ma'am.
So we have a patient with a peripheral neuropathy. From the history, we know that the patient has a peripheral neuropathy. Patient is a long-standing diabetic. Patient has an infected ulcer. Anything else from your history?
Ma'am, my patient is also giving features of autonomic dysfunction, where he's complaining of nocturnal diarrhea, ma'am.
Yes, very good. That is, again, so we have a patient with more or less peripheral neuropathy as well as autonomic neuropathy. Right. So now we go on to our examination. And since we already have a lead in the history, we'll focus on our examination also similarly. Please go ahead with the examination.
My patient was conscious and oriented to time, place, and person, 70 centimeter, BMI 23.5 kilogram per meter square, no pallor, icterus, cyanosis, clubbing. Lymph nodes were palpable in the left inguinal region. Pitching pedal edema was present in the left foot. Gait was not accessible and meds also not accessible. Vitals, pulse 88 beats per minute in right radial artery, regular in rhythm, normal in volume, pulse is palpable except left dorsalis pedis, blood pressure 130 by 80 millimeters of mercury in supine position and 118 by 68 millimeters of mercury while standing, measured in the right upper arm. SpO2 98% on the room air, respiratory rate 14 per minute, abdominothoracic.
Is that change in blood pressure significant?
Yes, ma'am. It is suggestive of orthostatic hypertension, ma'am. More than 20 millimeters of mercury change in systolic BP and more than 10 in diastolic BP, ma'am.
Right.
Can I continue?
Yes, please continue.
Temperature, febrile to touch, 39.1 degrees Celsius. Jugular venous pressure not visibly raised. Air, ma'am, this connection with, there is issue with the connection. Yes. Ma'am, we are just reconnecting the network. There's a connection problem.
No problem. Though I can hear you clearly.
Airway examination. Airway examination, no visible facial deformity, mouth opening 5 centimeter, modified Mallampati class 2, no loose or buck teeth or artificial dentures, thyromental distance 7 centimeter, higher mental distance 6.5 centimeter, sternomental distance 13 centimeter, neck range of movements adequate with no
Tell me
restriction.
the positive findings.
Ma'am, there's no positive finding in the airway examination, ma'am.
No, you don't say there's no positive finding. You don't use the term like that. You say the airway appears to be essentially within normal limits. And all the dynamic and the static indices are also within the normal ranges. Okay.
Yeah.
So what is a prayer sign? What is a palm print sign?
Ma'am, in prayer sign, ma'am, we are asking the patient to approximate both the palm, and we are looking whether the patient can completely approximate. This is if the patient is not able to do, we say that prayer sign is positive. That means my patient is due to prolonged diabetes, patient is having glycosylated depositions within the stiff joints, and the patient is having a Charcot's arthropathy, ma'am. So this will predict towards a difficult airway where patient will have difficulty in extending at the atlanto-occipital joint as well as the cervical joint and temporomandibular joint.
Okay. So are there any other reasons for a difficult airway in a diabetic patient? You see, because the Palmer sign and the prayer sign, they are very rarely seen. I haven't yet seen a patient who had a positive prayer sign or a palm print sign, honestly. But apart from that, is there any other reason for which your patient might, you might say that my patient, yes, has a difficult airway?
Ma'am, since my patient is having a feature suggesting autonomic dysfunction, he can have risk of aspiration, ma'am.
No, I'm just asking difficult intubation or difficult mask holding. Any other reason for that in a diabetic patient apart from your glycosylation and your stiff joints and all that?
Scleroderma of diabetes.
Scleroderma beta, it is on the posterior neck and upper back. What will that do?
Neck extension will
Yes,
have a
so there are two things that happen when such a case. Yes, you can have scleroderma of the diabetes, which is a much more commoner presentation than a positive prayer sign or a Palmer sign. The impaired atlanto-occipital joint mobility can be present even before you have a proper prayer sign. The other thing is because of the scleroderma, you may have an increased neck circumference, which may or may not be associated with a poor neck range of motion. And very often it is seen that obesity is coexists with diabetes mellitus. So diabetic patient may be obese, which may be the other reason for a difficult airway in a diabetic patient.
Okay.
Next.
Local examination. Inspection, single large ulcer with irregular borders, approximately 7 into 8 into 3 centimeter in size, extending from second metatarsal to the lateral malleolus with inflamed edematous sloping edge and ill-defined margin. Blackish discoloration extending from the tip of the little toe with bloodstained discharge is seen. Palpation, non-tender sloping edges with irregular margins, indurated base with a depth of 3 centimeter, bleeding on touch with warm surrounding skin. Dorsalis pedis was not palpable. Respiratory, coming to systemic examination, respiratory system.
What does the non-palpable dorsalis pedis signify?
Ma'am,
Very
peripheral.
important finding.
Yes, ma'am. Ma'am, ulcer was extensive for my patient, and due to peripheral vascular disease also, dorsalis pedis peripheral pulses can be non-palpable.
Yeah, so that means the macrovascular changes have already started in this patient. Now, when you have something like this tells you that your cardiovascular examination has to be done in a very thorough manner. This signifies this for you. Next.
Yes. Coming to systemic examination, respiratory system, on inspection, no obvious deformities of chest, trachea appears to be central, respiratory rate 15 per minute, regular abdominothoracic, no use of accessory muscles of respiration, chest movements bilaterally equal, no visible swelling, scar or venous pulsations, no audible wheeze. Palpation, inspiratory findings are confirmed, tracheal position is midline, no tenderness, no bony deformities, bilateral equal movements of chest wall. Percussion, resonant not in all areas. Auscultation, bilateral vesicular breath sounds in all areas. No added sounds. Vocal resonance normal. Bedside PFT, breath holding time 26 seconds. Coming to cardiovascular examination, on inspection, no precordial bulge, no visible pulsation.
I think you can just tell me if in systemic examination if there's a positive finding. And quickly just scroll through your slides and let me know if there's any positive finding in your systemic examination.
Ma'am, cardiovascular examinations was within normal limit, and abdominal examination also, ma'am, there was no positive findings.
So you use the term no abnormality detected on examination of the cardiovascular and respiratory system. And yes, now you can tell me about the central nervous system.
Ma'am, in CNS, there was sensory deficit elicited to touch, pain, and temperature in bilateral lower limbs, ma'am.
Okay, right. So in your history, I just want to highlight a few points. You took a very nice history, and I just, for the rest of the students. So what Dr. Amla focused on was that she took a history of one, as you should, of the type of diabetes mellitus. Duration of the disease is extremely important for how long the patient has been a diabetic, because that will tell you the associated complications. We are well aware that the associated complications are the micro and the musculovascular complications, which will include your cardiovascular disorders, a nephropathy. There can be an associated neuropathy. There can be retinal injuries, eye-related retinal damage, and other ones like there can be postprandial gastroparesis. Apart from all this, she took a very good history of associated risk factors. She ruled out any history of smoking, alcohol, her lifestyle. The lifestyle history is also important. Every diabetic patient, along with a history of complications, you must focus on whether the patient has a proper glycemic control or not. So if you had heard her history properly, she was looking at episodes of any acute episodes of any fainting, which would have been a hypoglycemia, any hospital admission, which could have been a hyperglycemia, diabetic ketoacidosis, drug therapy, and with special reference to your insulin intake and how the drug therapy has been progressing. You know, we started with metformin, and now she was on metformin, sitagliptin, and on insulin. So that is telling us that the disease is now progressing, and the patient is requiring more drug therapy for the same management. So these are important factors. Any recent infection, like in this patient, it was an infected ulcer. It's very important. So all these histories have to be very carefully taken whenever you're taking a patient of diabetes. Examination also very well done, Amla. She ruled out everything. You go for a general physical examination. In general physical examination, you must always do all the tests for autonomic neuropathy. Like she did, she actually actively sought out orthostatic hypotension. It's always advisable wherever possible to get a fundus examination done to rule out diabetic retinopathy, and it has been observed that direct presence of diabetic retinopathy correlates with cerebral changes. So it is a parallel change in the cerebral neuropathy and diabetic retinopathy. They move in parallel. So that will give you a very good idea of your cerebral circulation. Airway examination is to be done very, very carefully in these patients. And this is how you should always, rule out your important things in a diabetic patient. For autonomic neuropathy, it's a very complex part. So can I ask you, Amla, what would you like to focus whenever you're examining a patient for autonomic neuropathy?
Ma'am, first I would like to see whether the features of loss of sympathetic function as well as features of loss of parasympathetic function. Due to loss of sympathetic function, patient can have orthostatic hypotension, then bladder atony, retrograde ejaculation, and hydrosis. And due to loss of parasympathetic function, my patient can have resting tachycardia, increased heart rate, reduced heart rate variability, then stress urinary incontinence, erectile dysfunctions, gustatory sweatings, and in features of gastroparesis also, where patient can have early increased satiety and abdominal bloating, nausea, vomiting, constipation, diarrhea, etc.
Yeah, so all this is really nice, very well spoken. But when you are practically doing, it is basically three things that you should do. You can do a heart rate variability. You can do an orthostatic hypotension testing with blood pressure. And third is your Valsalva's maneuver. So these three tests, all the students must very well know about. And especially Valsalva, and you should know that Valsalva has an early stage, it has an intermediate stage and a late stage. So that you must know this very well. I don't want to spend too much time because we are short of time. I basically want to focus that these are the three tests that you must be well aware of if you want to clear your exam. So focus on these three. And what is the classic type of neuropathy that is seen in a diabetic patient? There's a very classic, it's called, it's classic pattern of neuropathy.
Ma'am, distal symmetric diffuse sensory motor neuropathy, ma'am.
Yeah, so either you have that distal symmetric glove and stocking, which we call it, or you can have, and with that, you may or may not have autonomic neuropathy. So why are we focusing so much on a diabetic autonomic neuropathy? How does that affect us as an anesthesiologist? What is the anesthetic implication of a diabetic patient with an autonomic neuropathy?
Ma'am, autonomic neuropathy patients are, due to gastropathy features, they are having increased risk of aspiration. So during our, when we are giving...
say this, I think a better way to say this is that the patient has a delayed gastric emptying. So there is gastroparesis, there is postprandial gastric fullness, and this patient may require to be treated as a full stomach patient. Otherwise, the patient is at risk of aspiration.
Yes, ma'am.
Okay.
Yes, ma'am.
Better way to say it?
Yes, ma'am. Yes, ma'am.
And?
Ma'am, patient can have increased response to sympathetic response to laryngoscopy, intubation, or extubation. And there are chances of intraoperative arrhythmias, ventricular ectopics, and even silent MI. And patient can also have...
No. Silent MIs and all that is not because of your autonomic neuropathy.
Cardiovascular manifestation.
You can have intraoperative hypotension because your baroreceptor control is now lost. So you can have either you can have an exaggerated response to tracheal intubation, you can have unexplained intraoperative hypertension, you can have arrhythmias leading on even to cardiorespiratory arrest. Okay. You can have altered respiratory reflexes, altered ventilatory drive to your hypoxia and hypercapnia. And very, very important is there can be unawareness of the hypoglycemia. Okay. So these are the problems that we can face. And as you can see, they are all very important concerns if a patient is having an autonomic neuropathy.
Yes.
Okay, great. So I suggest everybody do read up all the tests for autonomic neuropathy, but the three tests that you cannot do without is the heart rate variability, your orthostatic hypertension, and Valsalva's maneuver. And you must also know the proper values. I think Tisha has made a beautiful presentation on that and she can cover it in that. Now, can we come to the investigations of this patient?
Yes, ma'am. Ma'am, investigations, my patient's HB was 11.5, total leukocyte count was 12,000, platelet was 2.5 lakhs, Renal function test, urea was 18, creatinine was 0.75, serum electrolyte, sodium 142, potassium 4. Liver function test, total bilirubin was 0.66, AST, ALT, and ALP was 45, 49, and 98. Total protein was 7.06, and albumin was 4.2. Blood sugars, random blood sugar was 192 milligram per deciliter, fasting was 132 milligram per deciliter, postprandial was 180 milligram per deciliter, and HbA1c was 8.5%. Okay. Thyroid profile, T3, T4, and TSH was within
All
normal
were
limit.
normal. We'll just say normal. Huh? Next slide.
Urine routine normal, urine microscopy, sugars was present, ketones negative, chest X-ray within normal limit, ECG, 2D echo within normal limit, and viral markers were negative.
Okay. So we've covered all the investigations here. Now, to be noted here, it's very important to do a cardiac evaluation, as we said in this patient. But most of these patients, they have silent MIs. And how does a silent MI manifest? Can you just tell me?
Ma'am, in ECG, ma'am, I can see, I look for changes of ST.
In the history, like patient is not giving history of chest pain, classic chest pain, but you think that this patient could have had a silent MI. So how do you suspect that?
Ma'am, patient will have palpitations, breathlessness, and decreased exercise tolerance.
Yeah, so an unexplained fall in exercise tolerance is a very important pointer in a diabetic patient. So this will always signify a very high cardiovascular risk. And if you have a patient who is having this kind of a history, a recent fall in the exercise tolerance or meds, you should evaluate even more aggressively. And another very good indicator for silent MIs or cardiovascular risk in a diabetic patient is a coronary calcium score of more than 400. Do you think we should go for biomarkers like NT-proBNP or troponins?
Yes, ma'am. Since my patient is having features suggestive of autonomic dysfunctions, I would like to investigate.
Why autonomic dysfunction and biomarkers? What is that correlation?
Ma'am.
So there is a lot of controversy regarding the biomarkers, preoperative biomarkers in a diabetic patient, with one school of thought insisting that it is a very good method to have early detection because of the high prevalence of silent MIs. But as such, there is no recommendation for this. But anytime you feel your patient, you suspect from your history and examination, you should, or if you have a patient with a very uncontrolled diabetic status, you're taking up as an emergency, and you have a very high HbA1c, because you are all aware that HbA1c also correlates with a poor cardiovascular prognosis. So it's probably a good idea to go for a biomarkers like NT-proBNP or troponin whenever you are in doubt, right? So I'll come with I'm gonna ask you simple things like definition. How do you classify a patient as diabetic? Could you help me with that?
Diabetes can be type 1 diabetes or type 2 diabetes. In type 1 diabetes, patient is usually present in earlier onset of diabetes.
How do you diagnose a patient as a diabetic?
Ma'am, patient will give complaints of polyuria.
No. What are your
Diagnostic
investigations
criteria,
which will help you clinch a diagnosis of diabetes?
Ma'am, I look at the blood sugar levels. Fasting blood sugar of 100 to more than 126 milligram per deciliter, and a random blood sugar more than 200 milligram per deciliter, or a postprandial blood sugar of more than 200 milligram per deciliter.
So any one of these three?
Yes, ma'am. Or an HbA1c of more than 6.5%. Any
one of these three will make a patient diabetic.
Yes, ma'am. Any two of these.
Any two of these. Very important thing here, not any one. I may have had a good meal a day before and I get my fasting done and it comes out to be high. That doesn't make me diabetic. Very important. And very often, you have in the OTs, you're doing the pinprick blood sugar from a glucometer, and you also have a venous blood sugar. Which of these two is perhaps better, or is there any, are they same, or is there any difference between them?
Ma'am, venous blood sugars are always 77% less than the arterial, ma'am.
How much less?
7%, ma'am.
No. Arterial, you said. What you do by pinprick is your capillary blood glucose. So the capillary blood
Yes, ma'am.
glucose
Arterial
and the venous blood glucose, they have a difference of 15%, right? So that should be kept in mind. And why do we always do a glucometer? We often have a preoperative sugar, and when we get the patient in the OT, the surgeon tells you the morning sugar was 128. But you still go into the OT, and then you again, before taking up the patient in the OT, you always take a sample from the glucometer. Why do we do that?
ma'am,
Take a guess.
ma'am, see, surgical stress and the that can increase the glucose of the patient. So we
Yeah,
need to
very
monitor
good.
intraoperatively every hourly, and glucometer is easily available for us in the OTs. So
Yeah,
we
very good. So what we do is that, as I've just told you, the pinprick one, the glucometer one, is the capillary blood glucose. What the surgeon did in the morning was the venous blood glucose. So there is again a difference of 15%. Whenever in the OT, we always take a baseline glucometer, because each glucometer has its own code, if you have seen. So we are going to be doing the monitoring through that glucometer, and we establish a baseline. And as you very correctly said, by the time the patient has reached to the OT, the stress might have increased from, a 80 sugar, the patient might be at 130. So we are able to manage our blood sugar much, much better with that. So well done, good answer on that. We have definitions of pre-diabetic and all. I'm not going to go into all that. I just want to ask you one thing. How important is HbA1c for us?
Ma'am, HbA1c will give a glycemic control of the patient. It will increase the HbA1c of more than 6.5%. That the patient is having increased chance of microvascular and macrovascular complications. And it will give a blood glucose control of the last 2 to 3 months of the patient.
So how does it change my management?
Ma'am, if my HbA1c is more than 8.5%, if I'm taking a patient for an elective surgery, I should postpone the surgery. I should first optimize the patient and then take. But in case of emergency surgeries, ma'am, I have to go. I have to carry on with the surgery, ma'am.
So very well answered again, Amla. You're right when you say that it gives you the glycemic control over the last 60 to 90 days. And it is also a predictor of the risk of cardiovascular and microvascular complications in the patient. Even though there are some textbooks and some articles that say that 8.5 is the cutoff for HbA1c, but the evidence related to that is lacking. How it impacts us as an anesthesiologist is that if you look at the hemoglobin moiety, now it carries basically your oxygen. When the glycosylation happens, when it converts from a normal hemoglobin to an HbA1c, the glycosylation also impairs the oxygen carrying capacity of the hemoglobin. And this is very beautifully explained in Miller under the topic of hyperglycemia. If anybody wants to go and read up, where there is electrolyte imbalance there along with hyperglycemia, this is beautifully explained. And this causes a distortion of your oxygen dissociation curve. And now this particular hemoglobin cannot carry oxygen and deliver oxygen as effectively as your normal hemoglobin can. So this is how it impacts our anesthetic management. Okay. Now, let's just talk about this patient. Now, you told me the hemoglobin is, let me see, what was the hemoglobin of this patient?
11.5, ma'am.
Let's go back to the slide. Yeah. So if we look at now this patient is taken up for debridement, right? Debridement or amputation?
Amputation, ma'am.
Okay, so she wants to go for an amputation. Okay, so Amla, now tell me, we have a random of 192, we have a fasting of 132, we have a postprandial of 180 and a HbA1c of 8.5. Will you take this patient up for surgery?
Ma'am, since my patient has been posted for elective amputation, I can first optimize the patient and then take up. If I'm taking the patient for emergency amputation, then I will
No,
have
please,
to.
there is nothing like an elective amputation. You have an infected limb. Amla,
Okay.
you have a
Ma'am, then I have
impending
to.
gangrene. It from the foot you land up, probably there's going to be a forefoot amputation. With that, you'll probably land with the above knee amputation. So no, this is an infected case, and this
Okay.
is a patient who has the gangrene is spreading. So it is not, it is absolutely not to be postponed for optimization. And see, when you're looking at optimization, you have to go for something, you can do optimization in something which is not that time sensitive, where you have that 2-3 months to bring down the HbA1c. Again, it's going to take you 2 to 3 months. So only in those cases do we take it down, right? So we have to take this patient up. What do you think of the sugar control? Do you think it's a good control or is it a bad control?
No, ma'am, my
Or an
patient's
average control?
HbA1c is, ma'am, 8.5%. So he is having a poor control, ma'am.
And now you have a fasting of 132. Supposing the HbA1c was 7. With this fasting and postprandial levels and this random level, will you take this patient up for surgery?
Yes, ma'am. It is a good control, ma'am. I'll take up the patient.
So can I just ask you, what are your pre-operative blood sugar goals before you take up a patient for surgery?
Ma'am, fasting blood glucose should be 80 to 126 milligram per deciliter. Random blood glucose should be less than 180 milligram per deciliter, and an HbA1c of less than 0.5%, ma'am.
So from your definition, though, it is not looking very nice. So supposing the blood sugar fasting was say 148 or something, or 150, would you still take up this patient up, or will you send it back to the surgeon?
Ma'am, I will take up the case, ma'am.
So it's very important whenever you're going for a pre-operative evaluation checklist in a diabetic patient to realize that there is no evidence-based guidelines that exist as to when to cancel a patient over hyperglycemia. You don't see a single value because your patient on the day of surgery might be very anxious, might be having a much higher fasting or a postprandial blood sugar, but you have to see the control over the last 3-4 days. That is a better way to assess your patient for surgery. HbA1c less than 7 is always very much welcome. But however, if you have a fasting blood sugar between say 250 to 300 or even more than that, will you still take up Amla, this patient, for surgery?
Ma'am, since it is an emergency surgery, I will have to take up the patient.
No, you will not. This is a fasting of 250 to 300. This is a patient who is going towards diabetic ketoacidosis. Only when your
First,
fasting,
I'll optimize the patient.
yes, only when your fasting is above, some books are saying 250, some books are saying 300. So whenever I take the safe limit of 250. Whenever it goes beyond 250, you will never take up the patient. You will investigate the patient thoroughly, because as your sugar rises, what happens, which is very worrying, it is that your electrolyte imbalances happen. What will happen to your electrolytes with the higher sugar? What will happen to the sodium? What will happen to the potassium?
Ma'am, so the patient can have hyperkalemia and hyponatremia, ma'am.
Yeah. So a patient might be, along with that, the patient might be going into a catabolic state, might be having ketones. So you have to first, if you have a very high fasting blood sugar, you will not take up the patient. You will investigate the patient. You will rule out a diabetic ketoacidosis. You will start a insulin and a sugar trip, and only then you will take up the patient for surgery. So this is very important to understand that there is no, as I'm going to repeat, there is no evidence-based guideline that says that as to when to cancel a procedure due to hyperglycemia, but very high fasting blood sugars up 200 to 300 can tell you, that guide you, that the patient may be going towards a DKA, so always be, or a hyperosmolar coma, so always be very careful about that. More than that, assess the patient for stability based on the previous few days readings. You should also look for the need for the procedure, the risk of the procedure, and the ability to achieve the glucose control in case you are postponing the surgery. If you feel that the patient will benefit, yes, go ahead. But if not, then you can actually reassess that. Okay, so Amla, what are your preoperative advice on this patient?
Ma'am, I would ask surgeons to take it as a first case. I would ask for an
Why
NPO
as a first case? Why is a diabetic patient always a first case?
Ma'am, diabetic patients, due to they have an altered glucose control, they are more prone to have hypoglycemia during fasting state.
No, we don't give them insulin. We are not giving them OHA. No insulin, no sugar. Why will they be fasting? Why will they be hypoglycemia? We are not giving them OHAs or we are not giving them insulin. No, and that's not the correct answer.
Ma'am, prolonged fast.
So I just a thought, Amla, we really, trouble ourselves so much. I think we can manage a diabetic patient. Don't give insulin, don't give glucose. Problem should be solved.
Okay.
No? But we never do that. We always give insulin also in the OT. We give glucose also in the OT. We could have made life much easier. What will happen if we don't give insulin and don't give glucose? If there's no glucose, where will the substrate come from?
Yes, ma'am. Fat breakdown of fats, lipolysis would.
Lipolysis. And what does that lead to?
Diabetic ketoacidosis.
That will lead to ketone body formation. So why we do not keep the patient fasting for so long is not because the patient will develop hypoglycemia. If you are not giving any OHAs or insulin therapies, the patient will not develop hypoglycemia, but the patient will go into a catabolic state and will develop ketones and go into acidosis, which you don't want, the metabolic acidosis. Keeping the patient first on operating list minimizes this risk, shortens the preoperative fasting, and also potentially allows you to resume the patient's normal intake later on the same date. So you can reduce the total duration of fasting as well, and you can resume the normal meals and the normal therapy earlier.
Yes,
okay, right. Next, first case, next.
Ma'am, I would ask for an NPO, 12 hours for solids, heavy
12
meals.
hours for solids. हम कह रहे हैं कि minimize fasting और तुम अब 12 hours कर रहे हो. Why?
Patient is having autonomic dysfunction, so even to avoid the risk of aspiration, I am keeping a prolonged NPO for the patient.
Is that the best way to handle a gastric delay?
Or ma'am, I can
You should simply go for an acid aspiration prophylaxis. You have so many patients who have a gastric delay. We never increase the NPO guidelines, Beta.
Yes, ma'am.
We go for acid aspiration prophylaxis in patients who are trauma patients or patients who are pregnant. All of them have a delayed gastric emptying, like a patient with autonomic neuropathy. So we ensure that this patient gets an acid aspiration prophylaxis. Okay, next.
Ma'am, I would ask to continue the OHAs on the night prior to the surgery, and
No,
80%
we'll come to that later. We'll come to all that later. Tell me the other ones. Drug therapy we'll come to later.
Ma'am, I would ask for on the morning of surgery, I would ask the patient to get a serum electrolyte, FBS, and urine ketones, and then I would ask to arrange the blood and blood products for this patient, since it is expected blood is there for amputation.
Okay.
And I will take a written informed consent for my patient.
It be a normal consent?
Yes, ma'am.
Don't you think this patient is at higher risk than any other normal patient?
Yes, ma'am.
A diabetic patient, even if it is a well-controlled diabetic, even then that patient becomes a very high risk for us because of the presence of micro and vascular angiopathies that are associated in a diabetic patient. A diabetic is always a high-risk informed consent. And it's very important here that you always advise a very good angiolysis for this patient. As we are repeatedly saying, stress has a very important component for sugar management. and that is required. So now you have a patient who's on metformin, sitagliptin, and glargine. Now, what will you do for your metformin?
Ma'am, metformin, I would give the night prior to the surgery, I would give the full dose. And on morning of surgery, I would withhold the metformin dose.
So your textbooks all do say that you should withhold the met OHAs. Now, right now, what is happening is that there are two schools of thought. One is your ADA, which is your American Diabetic Association, and then you have the Royal College, the Center for Post-Operative Care, Perioperative Care, the CPOC guidelines. So both of them are conflicting, whereas the CPOC guidelines, they say that since metformin does not cause any hypoglycemia, it should not be stopped, it should be continued on the morning of surgery. But most of your textbooks are following the ADA guidelines. So I would suggest for the purpose of exam, you must follow those guidelines, but you should be aware that there has been a change in the guidelines of CPOC, and we are expecting a change in the ADA guidelines also shortly, wherein the OHAs would be OHAs apart from sulfonylureas, because sulfonylureas are the only OHAs that cause hypoglycemia, the rest do not. Now, supposing if this patient, Amla, I want to ask you, supposing this patient had associated CKD, which is very common in diabetic patient, in that case, would your metformin management change?
Yes,
Or
ma'am.
be the same?
Yes, ma'am. I have to stop it at least 24 hours prior, since my patient was prone to have lactic acidosis.
Excellent, very good. So if your patient has associated CKD, then you will not omit on the day of surgery, but at least 24 to 48 hours prior. What about your sitagliptin?
Ma'am, sitagliptin also, I'll give full dose in the night prior to the surgery, and the morning of dose I have to omit.
Excellent. And glargine?
Ma'am, glargine, on the night prior to surgery, I would give 80% of the insulin, and on the morning of surgery, I would withhold the insulin.
Very good. So it's very important that we have very clear information about how we have to manage our OHAs. Most OHAs you can give the evening before and are to be omitted on the morning of surgery, with the exception of one, and which is that?
Ma'am, SGLT2 inhibitors, ma'am.
Yes. So SGLT2 inhibitors should be stopped. How?
At least 48 to 72 hours prior.
Right. And why is that?
Ma'am, they are prone to have euglycemic diabetic ketoacidosis. Ma'am.
And why does that euglycemic diabetic ketoacidosis happen?
Ma'am, SGLT2 inhibitors, they inhibit the glucose reabsorption from the proximal convoluted tubule. So these patients will have glycosuria. Their blood glucose would be less than 200 milligram per deciliter. And since body will consider it as a starving state, and it will start breakdown.
Catabolic state. Very nice. Excellent. Now, nowadays, a very new concept has come up, and you may be soon encountering patients who come with a subcutaneous insulin infusion pump. I know so many people with type 1 diabetes, and they have gone and they've got these amazing devices. These are basically, they are like pacemakers. You insert them subcutaneously, you stitch them up, and the body is sugar is detected by these devices, and the rate is adjusted. So how will you manage if a patient already is on a continuous subcutaneous insulin infusion pump? Okay, this was a tricky one, and I'll answer this for you. Now, these pumps, there is a device by which you can modify your rates also. So if the patient is on a continuous subcutaneous infusion pump, then you can continue with the basal rate, which is your nighttime rate, or you can reduce by 10 to 25% if the patient has been complaining of frequent hypoglycemias. This is one way. If you're not comfortable with this subcutaneous insulin infusion, or if it's a major surgery, then you can stop the infusion totally and you can go for a IV infusion, the way we do your variable rate intravenous insulin infusion. And if it's a minor surgery and not expecting too many shifts, then you can simply go with your nighttime basal rate. So this was something interesting that I just wanted to add. Now, why are we, what is our sugar goal for glycemic management? What is our goal? What are we looking at? What is our primary goal when it comes to glucose management?
Ma'am, I should avoid hypoglycemia. I should avoid diabetic ketoacid, hyperglycemic features like diabetic ketoacidosis or hyperosmolar hyperglycemic syndrome, and I should have a good glycemic control.
Yeah, so that's what we are figuring out, because hypoglycemia is very bad because of its cerebral problems. Hyperglycemia can lead to hyperosmolarity, dehydration. It can give you a poor outcome in cardiorenal outcome. It leads with a increased risk of infection. It impairs the chemotaxis, phagocytosis. So it leads to, as we've been reading, it leads to non-enzymatic glycosylation of proteins. So, this weakening of endothelium, it disrupts glucose also disrupts the autoregulation. So we have a lot of problems with this. So what are your intraoperative, like how will you manage this patient? Okay, before that, what would you like to take up this patient under? Would you like to take up under general anesthesia or regional anesthesia, and why?
Ma'am, I would like to take my patient under regional anesthesia combined with a combined spinal epidural and a low-dose spinal anesthesia, ma'am.
Why?
Ma'am, since my patient is having autonomic dysfunction, I want to avoid an exaggerated sympathetic response hypotension intraoperatively. So I would like to give a low-dose spinal anesthetic drug.
Okay, no, I'm thinking why regional?
First, ma'am, my patient is having a surgery of the lower limb, and then and then ma'am, I can post-operatively, I can resume the diet earlier so that I can restart the oral medications earlier. I can do early mobilization for my patient. The risk of associated difficult airway, risk of aspiration, I can avoid with the regional anesthesia, and I can have an excellent post-operative analgesia with this, and also the risk of post-operative nausea, vomiting can also be decreased with regional anesthesia.
Right. So very important thing is that you have an early detection of hypoglycemia when an awake patient. As you very correctly said, there's reduced metabolic and endocrine response to surgery and anesthesia. You can do your glycemic control better. All the problems of general anesthesia, as you said, very rightly, difficult airway, risk of aspiration, exaggerated response to laryngoscopy, all that's taken care of. So it seems like an excellent idea, but can there be some problems with this, especially in this patient?
Ma'am,
Can there be problems with CSE, especially in this patient?
Ma'am, since my patient is having a long-standing diabetes, I may find difficulty to place a good spinal or epidural due to stiff. I can.
Don't go there. There's no stiff back.
Okay. And ma'am, patient positioning of the patient can cause altered sympathetic response also due to autonomic dysfunction in this patient.
What are you saying? Please explain what are you saying. You were going so beautifully, Amla. What did you say right now?
Ma'am, since my patient is having peripheral neuropathy, there can be exaggerated nerve injury to this patient while giving
Okay, wait. No, okay, no, you're losing it now. Okay. So the biggest disadvantage in such a patient is you already have a patient with a peripheral neuropathy. We have ruled that, we have already established that, and you're giving a regional block. So there can be medical legal concerns with that. So to avoid that, the peripheral neuropathy must always be well documented in your file. The patient should be informed about it, and only then you should give. As you very correctly said, in any neuropathy, there can be extra sensitivity, there can be unpredictable effect of your local anesthetic. So you're going to give lesser doses. As you have said that you like to give a very low dose in your spinal, and in case the block doesn't come, then you can supplement by your epidural. Since these patients already have a nerve damage, they are more prone to neurotoxicity. So you will avoid the use of any vasoconstrictors in this patient. And since this patient has an autonomic neuropathy, we've already established that this patient can have a very steep fall in the blood pressure because these patients have exaggerated hypotension because of the loss of the baroreceptor reflexes. And very important that these patients are prone to infection. So strict asepsis should be followed whenever you are going for regional anesthesia in a diabetic patient. In this patient, we had a count of 12,000. It's a little borderline count. So looking at the count is very important. If the counts are raised, if your TLC is raised, you should never, never, never go for a central uraxial block in such a patient. And
Okay.
this patient had gave you history of fever also. The patient was febrile. So no, I would have not gone for regional anesthesia in this patient, because that can lead to sepsis. It can lead to formation of an epidural hematoma. It can lead to epidural abscess. It can lead to subarachnoid infection, and that can lead to an even worse complication. Okay. Now, supposing if I needed to go for general anesthesia in this patient, what should I have gone for? What type? Inhalational, opioid-based, opioid-free, and why?
Ma'am, I would go for a rapid sequence induction since since my patient is considered to be full stomach.
You love the full stomach part. Okay. My question was but something else. I want to ask you, should I go for an inhalational based? Should I go for a opioid based, or should I go for an opioid free anesthesia?
Opioid based anesthesia since
No.
it can decrease the stress response.
No. Because you just told me this patient has autonomic neuropathy, right? An autonomic neuropathy, your all drives to hypoxia, hypercarbia, everything is lost.
Okay.
You will make an opioid-based anesthesia patient extremely sensitive to postoperative complications,
Okay, ma'am.
right? Always remember this, that in a diabetic patient, opioids tend to cause a lot of postoperative ventilatory impairments. So even if you're giving opioids, you can go for opioid sparing, that is give lesser titrate. Personally speaking, I prefer to go for opioid sparing, opioid-free anesthesia in these patients. And of course, the other alternative is always your inhalational agent. Inhalational agents, however, tend to sensitize the myocardium to the exogenous and endogenous catecholamines. In this patient, when you already have an autonomic neuropathy, when you have an underlying cardiovascular concern, so in those patients, again, you have to be very careful when you're using inhalational agents. And yes, as I said, that you've got to weigh all your issues and concerns, and you have to tailor your management accordingly.
Yes,
What IV fluid would you like to give intraoperatively?
ma'am, balanced salt solution, ma'am, or normal saline. I can also give normal saline.
So what would you like to give?
Normal saline, ma'am.
Okay, so when till a few years back, it was a rule that the moment a diabetic patient came inside, the technician would be asked to make a normal saline. Otherwise, there was always a ringer hanging. And we felt that ringer lactate is not a great idea because it can lead to, neoglucogenesis in the liver. The lactate can be metabolized to glucose, and that would impair our glucose control. And then the ringer has potassium, and we don't want to give potassium. So for many years, we have not been giving ringer in these patients. But then we realized that when we were giving normal saline, what was happening? We were landing up with
Hyperchloremic acidosis, ma'am.
Yes, you were landing up with hypochloremic acidosis. So nowadays, the recommendation does not really say that you go for normal saline. You can give either ringer lactate or you can give normal saline. What I personally follow, and many of us love it, is that we alternate our ringer with normal saline so that we can minimize the use of both without causing any complications. So this is how you can manage your fluid in this patient. Okay, now intraoperatively, how will you manage your glucose control?
Ma'am, intraoperatively, I would like to keep a glucose control between 100 to 180 milligram per deciliter. Even
So
if
here, we were having a talk. I'll just add this for the benefit of Amla, and Amla said 140 to 180. And she was correct in her way, because the ADA does say that you manage between 140 to 180 for the majority of critically ill and non-critically ill patients. And this is what your textbooks are also saying. I think your Stolting says 140 to 180. But what she's quoting is from the WHO surgical safety checklist. And I think this is something that we are following also routinely, and practically we keeping between 100 to 180. Yeah, so please go ahead, Amla, and sorry for interrupting you.
And then, ma'am, I would have I'll do hourly blood glucose monitoring. Whenever
Very
my blood glucose is more than 200 milligram per deciliter, I will start an insulin infusion 1 units per ml, and I'll titrate according to the blood sugars of the patient. Along with that, I'll also start dextrose with 10 to 20 milliequivalent of potassium at 100 to 150 ml per hour.
Yeah. Right. So she's right. She said that monitor every hourly. You should go for a shorter monitoring intervals in cases where the blood sugar is less than 100. If the blood sugar is less than 100, then please do not wait for 1 hour. You go for faster, smaller intervals. If the rate of fall is very rapid, like you started, you gave started insulin at 200 blood sugar, and then after an hour you saw the sugar level was say 110. So that's a very rapid fall. So in those, go for shorter intervals. Patients undergoing coronary bypass graft surgery, we go for shorter intervals. And patients with high insulin requirements, these are the patients in which you go for shorter intervals for monitoring.
Yes, ma'am.
Right. Okay. So the ADA says 140 to 180. The WHO surgical safety list says maintain between 100 to 180. And why do we use the value of 180?
Ma'am, beyond 200, patient renal threshold is reduced and patient can have glycosuria, ma'am.
So there are many, you will come with many multiple regimens for maintaining this blood sugar intraoperatively. And what I would suggest to you is that follow the variable rate intravenous insulin infusion, which is the VRII, VRIII. This is what everybody is following these days. The rest of the regimens have more of a historical value than anything. You should know the Vellore regime. Basically, variable rate infusion is nothing but a modification of your Alberti's regime. You should know their names. You should know what they are. But nobody is going to fail you if you don't know them. But you should know your variable rate in intravenous insulin infusion. What is tight control management? This is a word that people love to use. What is tight control?
In tight control regimen, I would like to keep the glucose within 90 to 120 milligram per deciliter. This is mainly done in case of cardiovascular surgeries in pregnancies and in
neurosurgical patients, global ischemia patients. Right. So is it a good method? Any care that we need? So in tight control is basically 79 to 120 milligram per deciliter, and it's a very narrow range. As you can say, it's a very tight range for high risk patients. These are patients who are at at a higher risk of cardiovascular concerns. Now, the problems with tight control, as you can see, is that these patients will be at increased risk for perioperative hypoglycemia. You need intensive monitoring. You need much shorter intervals for monitoring. You also need to monitor the serum potassium levels. The advantage of tight control is that it improves, it has been seen to improve wound healing, improved immune function, and this becomes very important for cardiopulmonary CABG cabbage patients because otherwise there is a risk of sternal infection and all, and it has also shown to have improved neurological outcomes in high-risk neurosurgical procedures. So this is a little bit about your tight control. Now you've been able to manage, your patient very well. And now what are your post-operative considerations?
In post-operative period also, I should continue the insulin infusion till my patient is able to resume normal diet. I would continue my blood sugar monitoring in post-op also, and then I would keep a watch on the hydration status as well as the serum electrolyte of the patient. And then once the patient is starting resumes a normal diet, I'll restart the OHAs and insulin according to the patient's normal medications.
So again, well answered. Now, I'd just like to re-emphasize a few points. You have to make sure of few things which are very important in a diabetic patient. Keep your patient warm, keep your patient comfortable, keep your patient pain-free. Okay, there should be no hypothermia. Pain will again lead to, impaired stress response, right? We don't want that. Ensure that you're giving good analgesia. Comfortable, I mean, patient should not be having any PONV. It should be aggressively treated for two reasons. One, of course, the stress associated with it. Two, whatever, if the patient is going to keep vomiting out whatever the patient eats, you will never be able to resume the OHAs or the insulin properly. Patient becomes at risk for severe hypoglycemia in the post-operative period, where the monitoring is much lesser as compared to in the intraoperative period. Dexamethasone, can it be given or not in a diabetic patient? Yes, it can be given. A single dose that we are using does not cause any impairment in the glucose control. In poorly controlled diabetics, there might be an issue, but in that, you go for your monitoring, will continue in that. Oxygen is a good idea in the post-operative period. Your target glycemic range remains the same as it was in the intraoperative period. All dextrose drips should be half neutralized. You should write your orders yourself. And OHAs. Now, this is very interesting when to start your OHA. In a tiny little corner of your Miller, it says that with the first meal, give half the dose of OHA. Amla, any idea why that has been done?
Ma'am, there is increased chance of vomiting with the first meal. So
Yeah, one, there is increased chance of vomiting, and right after a surgery, you may not be eating the same quantity volume of the meal as you may have been used to eating. So you probably be taking smaller, much smaller portions. So they say to give half of that. And what I follow in my institute is that I resume the OHA not with the first, but with the second post-op. Second post-op proper meal. I tell the surgeons, I tell the attendants, जब ये ढंग से खाना खा ले तब दीजिएगा, not with the first, with the second, because we are more scared of a hypoglycemia than a hyperglycemia in a post-operative area. And of course, insulin to be continued as per sliding scale every 4 hours is the recommended guidelines. So other thing, your patients might be having some sort of nephropathy, so be careful with the use of non-steroidal anti-inflammatories in such patient.
yes, ma'am.
So with that, I think we've been able to manage this patient quite well, Amla.
Yes, ma'am.
Very well done. Good job there. We've not talked about diabetic ketoacidosis and all that because we've left that for Tishya. She'll be covering that beautifully, but I think we've been able to manage this this particular case quite well. So thank you. Well done. We'll let Tishya present her slides. And I'm not sure, am I to take the questions now or at the end of Tishya's presentation?
At the end of presentation, ma'am.
Right. So over to Tishya for her really well curated presentation.
Good afternoon, everybody. I will be summarizing the case. Starting with the criteria for diagnosis of diabetes mellitus, fasting blood glucose of more than 126 milligram per DL, postprandial of more than 200 milligram per DL, HbA1c of more than 6.5. Any two of these factors, if present, diagnosis brings us to the diagnosis of diabetes. Diabetes can be classified as type 1, type 2, type 3, according to the pathology or the etiology of the cause. The anti-diabetic drugs classification are broadly classified into 4 types: insulin sensitizers, insulin secretagogues, decreased insulin absorption of glucose and excretion of glucose from urine. Then we have insulin preparations. These are also classified into 4 types: rapid acting, short acting, intermediate, and long acting, depending on their duration of action. The metabolic effects of anesthesia and surgery in diabetes mellitus. The metabolic effect of starvations. This induces a catabolic state, which causes release of catecholamines, cortisol, and growth hormones. These have anti-insulin effect, and insulin requirement in this period becomes unpredictable. Interruption of oral food intake further prolongs after GI procedures, leading to starvation ketosis. The metabolic effect of major surgeries result in non-epinephrine stress response, also leads to release of counter-regulatory hormones and inflammatory mediators like tumor necrosis factors and interleukin-1, which in turn reduces the skeletal muscle insulin sensitivity and leads to hyperglycemia. And a hypoglycemia exacerbates the catabolic effect of surgery. These neurohormonal changes lead to metabolic abnormalities, including increased insulin resistance, decreased peripheral glucose utilization, impaired insulin secretions, and increased lipolysis. Protein catabolism leading to hypoglycemia and in ketosis in some. This effect can be attenuated by starting an infusion of insulin and glucose to maintain the blood glucose levels of 100 to 180 milligram per DL in a perioperative period. The perioperative management mainly depends upon the type of diabetes mellitus, compliance to treatment, blood sugar levels, presence of complications like autonomic dysfunction or end organ damage, and the nature of surgery, major, minor, elective, or emergency. The preoperative evaluation in diabetes mellitus involves history and physical examination, the type and duration of diabetes, the level of control, frequency of blood glucose monitoring, long-term complications, associated comorbidities, frequency of hypoglycemia, pharmacotherapy and review of medication, lab assessment, and type of surgery. The pre-operative evaluation has been very nicely covered with by Amla, so I'll be skipping this. Diabetic autonomic dysfunctions. There are various tests that we perform. The tests are performed for the parasympathetic system and the tests are performed for sympathetic system. For the parasympathetic system, we see the heart rate variability in response to standing, deep breathing, and Valsalva maneuver. And for the sympathetic system, we are seeing the blood pressure variability in response to standing, Valsalva, and the sustained hand grip. The scores, the normal values which we get with systemic blood pressure decrease in upright position should be, if it is more than 30, it is significant. And similarly, the RR intervals in upright position, if it is less than 1, then it is significant. Diastolic blood pressure increase during hand grip test, if it is less than 10 millimeters of mercury, then it is significant. Respiratory dysarrhythmias of 10 is significant, and Valsalva quotient of less than 1.10 is significant. If we get a score of more than 2, then we have to make definitive modifications. Investigations. We do hemoglobin, TLCs, urine routine, serum creatinine, fasting, postprandial blood sugar levels, and glycosylated hemoglobin. Glycosylated hemoglobin being important to us since it implies good control of blood sugar control over the preceding 8 to 12 weeks. Serum electrolytes, to detect the abnormalities in patients with vomiting, diarrhea, poor oral intake, or tube feeding. Also in patients on insulin therapy and OHA, it is very important since there may be electrolyte imbalance. ECG, echo, and chest X-rays are also done as well. Pre-op guidelines for patients on OHA. Metformin is omitted on the day of surgery until oral intake is resumed. Day before the surgery, we take as normal. There is increased chances of lactic acidosis, especially in renal insufficiency. DPP4 inhibitors withhold on the day of the surgery until oral intake is resumed. This is said by American Diabetic Association, whereas CPOC says to continue. No dose adjustment is required on the day of the surgery. It causes the effect of DPP4 inhibitors is that they worsen nausea and vomiting by delaying gastric emptying. Sulfonylureas are to be omitted on the day of the surgery. A day before the surgery, they are supposed to be taken as normal. The complications associated with them is that they're associated with hypoglycemia. SGLT2 inhibitors, they are to be omitted at least 24 hours before the elective surgeries as mentioned in Miller's, whereas ADA says to withhold 72 to 96 hours before surgery, and CPOC says to withhold 48 hours before surgery. SGLT2 inhibitors have higher incidence of developing euglycemic ketoacidosis in the post-operative period. Hence, we are asked to omit at least 24 hours prior. Thiazolidines are to be held on the day of the surgery until oral intake resumed. CPOC says to continue. Preoperative guidelines for patients on insulin. Long-acting insulin, small amount, 1/3 to 1/2 of the usual morning dose of long-acting has to be taken. The evening dose has to be reduced by 20% and 80% of the normal dose has to be given. Daily pre-mixed insulin are reduced. The morning dose is reduced by 50%. Evening dose, no dose adjustment is required. Short-acting insulin, the morning dose is omitted. The evening dose is given as is. Continuous subcutaneous insulin infusion pumps continue in the morning dose. The lowest basal rate is continued on the morning of the surgery. Preoperative orders, it has to be taken as the first case. OH and insulin to continue as mentioned just now. NPO for 8 hours. On morning of surgery, omit OHA, normal subcutaneous insulin. Investigations I have mentioned already. Apart from this, we are giving gastric prokinetic drugs and H2 blockers. Sedation and analgesis is to be given, and other medication if the patient is on, like antihypertensive, is to be continued. After taking the morning blood sugar levels, a glucose insulin infusion has to be started. Regional anesthesia and diabetes, the advantages is that the patient is awake, which helps in early recognition of intraoperative hypoglycemia. There is decreased risk of difficult intubation, aspiration, postoperative nausea, vomiting. There is rapid return to diet, insulin and OHAs. There's decreased risk of thromboembolism, and it provides excellent analgesia. Metabolic effect of anesthetic agents is avoided. Disadvantages: profound hypotension can occur if diabetic autonomic neuropathy is present. Infections and vascular complications can be increased. Medico-legal concerns of risk of nerve injury and higher risk of ischemic injury with the use of adrenaline when local anesthetic. General anesthesia, there is better control of blood pressure in diabetic autonomic neuropathy patients. The disadvantages is that there may be difficult airway, full stomach due to gastroparesis, aggravated hemodynamic response to intubation, masks the symptoms of hypoglycemia, and delay return to oral feeds and insulin. Intraoperative care and monitoring. The intraoperative blood glucose targets, as discussed in the case, are different by different societies. We are following 100 and 180 intraoperatively in our institute. The aim of intraoperative care is to maintain good glycemic control at between 100 to 180 milligram per DL. The blood glucose level should be checked before induction of anesthesia and monitored regularly during the procedures, at least hourly. And if there is a sudden fall in the blood glucose level, then the duration can be shortened furthermore. Positioning is important to avoid pressure source and should be done gradually to avoid sudden drop in the blood pressure. IV fluid, Hartmann solution, which is ringalactate, is safe, but as mentioned earlier, we can alternatively use NS and RL. Multimodal analgesia should be given, and ultrasound guided nerve blocks are preferred. Various regimen for insulin. We have the sliding scale, we have Albertese, we have a tight control regimen, we have Velour, and we have variable rate intravenous insulin infusion. The variable rate insulin infusion has been explained by Amla in her presentation. I have put the table to increase or decrease according to the patient's response to the insulin infusion. Tight control regimen, this has also been explained, but I will quickly cover it, is to maintain the blood sugar levels at 79 to 120 milligram per DL. Indications is pregnancy, cardiopulmonary bypass, neurosurgery. Advantages is they improve blood healing, prevents infection, and there is an improvement surgical outcome. Disadvantages that there is more chance of hypoglycemia and it requires frequent monitoring. Complications of diabetes mellitus. These are broadly classified into two types: acute complications and late systemic complications. Acute complication mainly includes diabetic ketoacidosis, hyperglycemic, hyperosmolar, non-ketotic coma, and hypoglycemia. The late systemic complications are classified into vascular and non-vascular. Vascular are further classified into microvascular and macrovascular. Microvascular includes diabetic nephropathy, diabetic retinopathy. The macrovascular complications include hypertension, coronary artery disease, congestive heart failure, cardiomyopathy, peripheral vascular diseases. Non-vascular includes infection, skin changes, dementia, and diabetic autonomic neuropathy. Hypoglycemia. The blood sugar level less than 70 milligram per DL is referred to as hypoglycemia, and neuroglycopenia is when the blood sugar falls less than 40 milligram per DL. Symptoms are due to adrenergic excess and neuroglycopenia, and the symptoms include sweating, tachycardia or bradycardia, tremors, hypertension, dizziness, irritability, seizures, or coma. We will stop our insulin and give dextrose 50 ml, 50% dextrose infusion, and 50 ml of 50% dextrose infusion is given. Glucagon of 0.5 to 1 mg IM is given, and octreotide can also be given, which is a long-acting stomatostatin analog. It is a drug of choice for treatment of sulfonylurea-induced hypoglycemia. Diabetic ketoacidosis versus hyperglycemic non-ketotic coma. When the blood glucose levels is more than 250 milligram per dl, it is and the pH is less than 7.3. Bicarb is less than 15 milliequivalents per liter. An iron gap is more than 12. There is moderate to severe ketonemia or moderate to severe ketonuria, and the serum osmolarity is less than 310 milliosmoles per liter. This helps us to make the diagnosis of diabetic ketoacidosis. For a non-ketotic coma, the blood gas is usually more than 600 milligram per dl. The pH is of more than 7.3. Bicarb is of more than 15 milliequivalents per liter. There's a normal anion gap. There is absent to minimal ketonemia. Urine ketone is absent or minimal. And the serum osmolarity is more than 350 milliosmoles per liter. Management of diabetic ketoacidosis. The first is volume resuscitation. We start an IV infusion of 0.9% NS as 1 liter over 30 minutes, then 1 liter over 1 hour, then 1 liter over the next 2 hours. Insulin of 0.1 units per kg IV bolus is given, followed by 0.1 unit per kg per hour infusion. If the blood glucose level does not fall by 10%, we have to repeat the loading dose. If still no response, we can double the infusion dose in every 2 hours. Insulin is continued till normal acid-base status is achieved. When the blood sugar drops below 250 milligram per dl, dextrose is added to the insulin infusion for clearing ketones. Electrolytes, we have to put 10 milliequivalents of potassium in the first liter of NS and 10 to 40 milliequivalents per liter subsequently, depending on the potassium levels, only if they are less than 5.5 milliequivalents per liter. Replace phosphate only when it is less than 1 milligram per dl. We also have to monitor the serum sodium levels, as these patients have the tendency to develop hyponatremia. Other measures are 100% oxygen. Consider bicarb if pH is less than 7. Bicarb when the pH is less than 7 and the bicarb concentration is less than 10 milliequivalents per liter, and hypotension unresponsive to IV, then we can start the patients on inotropes. We considered the decay to be resolved when the pH is less than 7.3. Bicarb is 18 milliequivalents per liter. There is better mental status. Anion gap is corrected, and blood sugar levels have fallen below 250 milligrams per dl. Management on non-ketotic hyperosmolar coma, more than 10 liters of fluid deficit is present. So 6 to 8 liters is corrected over the first 12 hours with 0.9% NS, 2 to 3 liters in the second and third hour, 0.45% NS at 2 to 5 ml per kg per hour. 5% glucose with 0.45% saline is given when blood glucose level fall below 300 milligram per dl. Insulin, 15 units IV bolus is given, followed by 0.1 unit per kg per hour. If the blood glucose does not fall by 50 milligram per dl in the first hour, double insulin dose. Potassium replacement is same as that in DK. If level is less than 3.5 milliequivalent, withhold insulin and give 40 milliequivalent per hour. Euglycemic diabetic ketoacidosis is very commonly seen these days because of the rise in use of SGLT2 inhibitors like dapagliflozin. For diagnosis of euglycemic ketoacidosis, there is a triad which includes blood sugar levels of less than 200 milligram per dl, ketonemia for serum beta hydroxybutyrate of more than 3 millimoles per liter, and at least one of the following criteria: arterial pH of less than 7.3, serum bicarbonate of less than 18 milliequivalents per liter, and an iron gap of more than 10. The pathophysiology, this happens because there is insulin deficiency and also because of the release of counter-regulatory hormones as we see in the surgery, and the patient is on SGLT2 inhibitors. So SGLT2 inhibitors will prevent the absorption of glucose, as a result of which the patient will not have hyperglycemia. the patient will be euglycemic. But because of the lack of substrate, there will be proteolysis, gluconeogenesis, glycogenolysis, and lipolysis, which is going to which is going to result in development of ketoacidosis, resulting in euglycemic diabetic ketoacidosis. The management is similar on the terms of DKA. We start IV insulin infusion at 1 to 2 units per hour, IV dextrose D5 or D10 to maintain the blood glucose level of 120 to 180 milligram per DL. And then we look for ketones in the urine. We treat the patient till the time urine ketones do not become negative. Post-operatively, we recommend oral OHAs half dose with first meal. The reason being that the patient may not be able to take the first meal properly or may vomit out the first meal. Second, full dose is given with the second proper meal. Recommends normal subcutaneous insulin with the second proper meal. For if the patient has had major surgery, continue insulin infusion till regular diet. Once the patient starts taking regular diet, the patient can be shifted to regular insulin. And we have to provide adequate pain relief to the patients because inadequate pain relief can result in catabolic hormone secretions, which can further result in ketosis and complications. Thank you so much.
Well done, Tisha. Very well presented.
Thank you. Thank you, Dr. Tisha. Thank you, ma'am. We have one question from a delegate, and it says that which is the best regime to follow in an intraoperative course of an emergency case, and does it also depend on the type of surgery?
So, as I have been telling in my talk, is that it doesn't really matter which regime you follow. They are all modifications of the same thing, that you have to give insulin, you have to give glucose. And you have to replace the potassium because the potassium will go in intracellular the moment you're using insulin and glucose. Most institutions have their own protocols. But if given the choice, the ideal regime, the best regime, which has now been able to take the fallacies, the drawbacks of all the previous regimes, is what we follow now, which is the variable rate intravenous insulin infusion. So even in an emergency surgery, you can follow that irrespective of the type of surgery. In an emergency surgery, you might have a poorly controlled patient. In that patient, you can keep the same regime, but you should, I feel, reduce your interval for monitoring the blood sugar, because you may have either a rapid fall or not so rapid fall. You may need to change your values, your insulin doses more frequently. So that is what you need to do more than anything else. The regime per se doesn't really matter as much. So
Okay,
that's a
ma'am.
very
I
good
think
question, and I'm very happy I've been able to, at least inspire you to think a little. Diabetes it's very complicated to read because you see none of the textbooks give it very clearly. There's no detailing, and it is something that, right now we are actually sitting on an epidemic of diabetes. And you're expected to increase the number of diabetic patients by 50% in the next 3 years. It's very scary. So every second patient who's going to be coming to you is going to be diabetic. So the endeavor today when Amla, Tisha and I sat down was to make it very simple for you, make it very goal directed for you to understand if you get this case, not just for the exam purpose. The goal is to make you better anesthesiologist, to be able to tackle this case, to be able to manage this case. And I'll be very happy if anybody has even the slightest of doubt, even if they feel it's a stupid doubt, please do ask it. It may be something that's actually very important and intelligent.
Thank you, ma'am. I think that answers the question very well, and thanks for your insights on the topic, ma'am. I'm sure it will be very helpful for the postgraduates, and we are so happy to have you today. Thank you for moderating.
I'd like to express my thanks to the team at Appec. I got a glimpse of Dr. Kaur, madam. Good afternoon, madam. I hope you're doing well. And the Appec has always been able to maintain a level of excellence, and I'm very sure, ma'am, that you are very much behind it as the Bhisham Pitama of Appec 25. And once again, thank you very much for giving me this opportunity, and very well done, Dr. Amla and Dr. Tisha. Thank you, Anupma. Thank you. Good afternoon, madam. Thank you so much.
Thank you.
Good. Thank you. Thank you, ma'am. I think ma'am has some connection issue. So, before going on to the next session, can we, MD ma'am, yes, ma'am, are you there? Yes, we can have your comments now.
Sorry, Dr. Bharti, I think I had some problem with my audio. Thank
Yes,
you so
ma'am.
much for all good words. Thank you so much.
It's always a pleasure, ma'am. Thank you, ma'am.
Thank you for being with us
Thank
once again in this Appec program. So,
It's an honor, ma'am. Good afternoon.
thank you, Dr.
Wishing you,
Anupam, for
wishing you a
calling.
very good day, ma'am.
Yeah, thank you so much. So, Dr. Anupma,
Yes,
thank you
ma'am.
for calling me, and
I'll introduce ma'am. Ma'am will be chairing. Yes, ma'am. Ma'am will be chairing the next session. Ma'am is our professor and ex-head of the Department of Anesthesia at ABBIMS and Dr. RMA Hospital. She has pioneered and she was when the Appec program had started in Appec 2021. And we are fortunate to have ma'am moderate the sessions for us. She's always the force behind the program. She has various achievements to her. She has been given Pratibha Saman Award at ex-ISC Delhi President in 2022 and 24. She has various publications and national and international journals. She has a variety of interests in critical care, quality improvement in event, and laparoscopic anesthesia. We are so delighted to have you, ma'am, and we welcome you. And we can introduce the next speaker for us.
thank you. Our next speaker is Dr. Upasana Goswami. I have a pleasure in saying that she has been our ex-SR and she is now a senior specialist attached to the India Alopathy Hospital, New Delhi. And I would like to tell you her achievements. She is associated with NBE for teaching and examinations. She's been awarded Young Teachers Award from Delhi. Yes. And presentations in various anesthesia forum. And her areas of interest are difficult airway and obstetric anesthesia. She will be speaking on a very pertinent topic, extubation guidelines. And I always tell my students, if you have learned intubation, you have learned just 20-30% of anesthesia. But if you have learned when to extubate, how to extubate, that means you have mastered anesthesia. So I am very glad to have a very good speaker, Dr. Upasana. She will be speaking on the topic.
Greetings to all my seniors and colleagues, and a very warm welcome to all the postgraduate students who've joined Appec 2025. So my topic today is extubation guidelines. And the plan of today's talk is to cover extubation guidelines for both normal and difficult airway, assessment before extubation, extubation failure, and also some special considerations. Now, we should all realize that tracheal extubation is not simply the reverse of intubation. It is basically a transition from a controlled to an uncontrolled state. There are time pressures to extubate on time, and anatomical changes may complicate the process after surgery and anesthesia. And so it becomes much more difficult than intubation at times. Now, what are the complications that may occur? They may be minor ones like laryngospasm or airway obstruction, which are handled easily. But hypoxic brain injury and death have also been reported, and these may be higher in cases like obese patients and patients with OSA. So I'll be talking in details about the Difficult Airway Society extubation guidelines, which gives us 4 steps. That is planning, preparing, performing, and post-extubation care, along with risk stratification, as in low risk and at-risk patients. So what is step 1? It is basically planning after assessing the airway risk factors. and the general risk factors. And assessment involves looking for pre-existing airway difficulty or maybe difficulties which arise perioperatively, either edema, hemorrhage, or maybe we are sharing the airway with the surgeon. So it is important to assess these things. At the same time, general factors have to be assessed regarding, say, neuromuscular status or the cardiovascular status. So preparing involves optimizing the patient factors and other factors such as monitoring, equipment, location of the extubation, and so on. One very important part of preparation is a rescue plan. If extubation fails, what then? We might have to go for reintubation, and in difficult airway cases, we have to also, consider front of neck access. So it is important to prepare for that as well. Sequence of airway assessment will involve looking for achievability of bag and mask ventilation, looking for edema, trauma, or maybe airway, laryngeal edema, for which we might have to look for a cuff leak test. And gastric decompression is important, so we might have to go for suctioning for extubation. General factors that need to be dealt with are reversal of sedation. So this becomes a very handy monitoring, and train of 4 ratio of 0.9 or above is required to look for neuromuscular blockade reversal. And we might have to see for adequate analgesia and cardiovascular stability, also logistical factors. The third step is performing the extubation after risk stratification of a low-risk patient or an at-risk patient. So what are the low-risk patients? They are basically the fasted ones with uncomplicated airways and no general risk factors. The at-risk patients will have uncertain oxygenation and possible reintubation difficulty. To perform extubation, the one very important step that cannot be missed for any patient is pre-oxygenation with FiO2 of 1. Positioning, yes, there are no universal positions, but we usually prefer the reverse Trendelenburg position because of the respiratory mechanics involved. For OSA patients, we might have to go for the sitting position, and for the tonsillectomy patients, a lateral position with head low position. Now, suctioning under vision is ideal, and alveolar recruiting maneuvers may have to be undertaken. And we all practice one particular move, very, very important, that is simultaneous deflation of the tracheal tube cuff and removal of the tube at the peak of a sustained inflation, so as to expel the secretions and reduce the incidence of laryngospasm and breath holding. Now, the low-risk algorithm of difficult airway society, it suggests either an awake extubation or extubation at the deep plane. Awake extubation, the steps are same as I've already discussed. For deep extubation, the patient needs to be in a deeper plane, so we have to maintain that depth with volatile agents or TIVA agents. Cough, gag, or change in the breathing pattern means that we have to deepen the anesthesia. This again means that the airway patency might be lost, so we might have to use oropharyngeal or nasopharyngeal airways. What is the at-risk algorithm? Here, we need to assess the patients at risk. Now, who are the patients at risk? They are either patients with some, at-risk condition as far as the general condition is considered. So, a patient coming for emergency surgery for a leaking aortic aneurysm with history of full stomach, that is an at-risk patient for us. Similarly, a well-prepared patient coming for head and neck surgery with awake fiber optic intubation also becomes at risk because of the airway involvement. So what are the questions to ask? The questions to ask are, is it safe to extubate? If safe, then do I go for awake extubation or extubation at the deeper plane? And if it is unsafe, then what do I do? Do I simply postpone extubation or do I go for a tracheostomy? Also, for at-risk patients, we might go for some special maneuvers, such as the supraglottic airway device exchange technique, where we can, exchange the tracheal tube with a SAD. It may be done either by removal of the endotracheal tube and then insertion of the SAD blindly, or we may insert the SAD with the help of an airway exchange catheter. And then there is the Bailey's maneuver. What is the Bailey's maneuver? Here we insert the LMA or the SAD behind the tracheal tube and inflate the cuff, then deflate the cuff of the tracheal tube, and finally take out the tracheal tube, keeping the SAD in situ. So we get a patient who has an undisturbed emergence from anesthesia. The remifentanil extubation technique is another one for reducing the pressor response. We can also use dexmedetomidine. We have basically a tube-tolerant patient who is awake and obeying commands. Then we have the AEC technique. The airway exchange catheter is a hollow catheter with gradations. So we can simply take out the tracheal tube after inserting the AEC through the tube, and that can be kept in situ for airway patency. Important thing is to keep the distal tip positioned in the mid-trachea at all times. The fourth step is post-extubation care. We all know we have to hand over the patient in PACU, proper oxygenation, analgesia. Monitoring is important there. ASA gives us the extubation guidelines for the difficult airway. They talk about the difficult or fail intubation, which is defined as reintubation within 48 hours of extubation. And these are the risk factors involved. And All India Difficult Airway Association also gives us guidelines on similar lines. They give us a normal limb first, where they talk about the normal airway extubation, and they give us various pharmacological agents for reducing the pressor response, like esmolol, lidocaine, fentanyl, dexmedetomidine. They talk about the special maneuvers like Bailey's maneuvers, but like all other guidelines, they stress on the continuous administration of 100% oxygen during the process of extubation. Now, they give us the 4 Ds and 4 Ss. What are the 4 Ds? Difficult mask ventilation, difficult intubation or reintubation, delayed recovery, and difficult airway due to pre-existing diseases. The 3 S's are surgical cause of airway compromise, suspected airway edema, and suspected airway collapse. These are the conditions where we have to be very careful in deciding whether to extubate or not, and if at all we are extubating, then how. They also give us the steps for extubation with the help of AEC, and IDA says that the approximate depth of the AEC should be 20 to 22 centimeters when used with an orotracheal tube, and 26 to 30 centimeters when used with a nasotracheal tube. Special considerations are critically ill patients, pediatric population, and maybe the COVID-19 patients, where we all know we have to go for minimal airway handling and continuous use of face masks so as to reduce contamination of the atmosphere. Now, in the critically ill patient, we have to go for the spontaneous breathing trials always. And here the criteria are respiratory rate less than 35, good tolerance to spontaneous breathing trial, heart rate less than 140, stable hemodynamics, SaO2 more than 90, PaO2 more than 60 millimeter of mercury, and most importantly, no signs of increased workup breathing. In the pediatric population, upper airway obstruction is a very important factor to consider, and failed extubation in 37% of patients in the pediatric population is due to this condition. Leak test is important in pediatric population, therefore. And in case of failed extubation, we have to consider HFNC, CPAP, and NIV before going for reintubation, because we know that the edema is still there. It has not gone anywhere. So these maneuvers might help us. The extubation readiness test is also important in pediatric patients. Here, the ERT bundle consists of SBT, the assessment of sedation level, hemodynamics assessment, and magnitude of airway secretions. Very, very important to prevent laryngospasm. To conclude, extubation strategy is a logical extension of the intubation strategy, meaning extubation planning should start even before anesthesia has begun. Proactive planning reduces complications, and team preparation and monitoring are very, very essential for a successful extubation. Thank you.
so much. Chat box.
Somebody made a summary में and में सीकर लिखने
कुछ भी नहीं लिखना
मतलब डिक्लेयर डायरेक्ट
हाँ डिक्लेयर
अरेस्ट एंड डिक्लेयर
हाँ हाँ
कुछ लिखना नहीं ना डीएनआर
I think, ma'am, there's an audio problem.
Yes, ma'am is not audible.
Ma'am is just logging in again. We do not have any questions on extubation guidelines. I'll just wait for ma'am to just log in again.
Sure.
Sorry for some disturbance in the net. And this actually is trying on Dr. Is logic? Is the logic? But we are seeing a logic detail.
सेशन आए हैं टाइमिंग सेशन आए हैं तो सबको इंक्लूड करते हुए हम लोगों की इस बायलॉज को एक तरह से इसको फॉर्मल करके
I think there is a problem with the audio with the ma'am side. She will be logging in again. So meanwhile, we can conclude this session and we can go on to the next session. Thank you, Dr. Upasana,
Thank
for
you
a
so much
wonderful
for
lecture.
having me here.
And we do not have any questions.
Thank you so much for having me here.
It's a very important topic.
It's an excellent show.
Thank you so much.
Thank you.
I think ma'am is here. 1 second. I'll just give it to ma'am.
Yeah. Thank you, Dr. Upasana, for the very nice presentation. And for the PGs, I would just give my remark that, this is a very important topic. And, not only for the exams, but when you are clinically doing it, your assessment for the patient, whether the patient is prepared for the extubation, which comes with a vast experience, So, my one piece of advice to the PGs is that while you are extubating and you are in the learning phase, always have a senior by your side, because most of the complications post extubation can be avoided with the senior's presence, because the preparedness for seeing the extubation, that's very important, and it's a clinical judgment as well. In addition to what all guidelines are to be learned, but clinical assessment is again very important. The two things have to match, and then we come to understand that this is the patient is ready to be extubated, or else we have to keep some preparations besides just whether we have to extubate this patient right here, or we have to keep this patient on ventilator. So many things are there which would determine a safe extubation. And thank you, Dr. Upasana, once again.
Thank you so much, ma'am.
Thank you. So we will continue with the next session. Before that, Sudhir, can we have the answers to the MCQs that we had flashed, and we can display the questions of free lunch also?
Okay, ma'am.
So the correct answer to the first question is the B option. That is, the pressure applied during inspiration is constant, but the tidal volume varies based on the lung compliance and air resistance. Second question. The answer to the second question is the risk of oxygen-induced hypercapnia. That is again the second option. Thank you, Sudhir. So we go on to the next lecture. So for moderating the next session, we have with us Dr. Rajesh Pandey, sir, and we have Sir's CV, although we are all very familiar with Sir's accomplishments. Sir is a principal director and head at the BLK Max Center for Critical Care. He has various affiliations to various societies. He is a member of Super Specialty Board, Critical Care Medicine, National Board of Examination. He has a degree in IDCCM, IHCCM. He is an NBA senior teacher, assessor, and examiner. He is a former vice chancellor of ISCCM and former general secretary of ISCCM. He was organizing secretary of critical care in 2023. He is a former chairman of ISCCM Delhi, Noida. He has been the inspiring intensivist Economic Times in India 2022, and he was an inspiring intensivist in Times Network 2024 also. He was given the outstanding contribution in emergency medicine by SME and American Academy of Emergency Medicine in 2006. He has various publications and book chapters to him. He has a presidential citation of ISCCM in 2013 and later also. His areas of interest are sepsis, ARDS, end-of-life care, and mechanical ventilation. We are so delighted to have you, sir, on this important lecture on sepsis and nutrition. We welcome you, sir.
Thank you very much. I'm thankful to Appec organizers and especially Dr. Nirja and all our team for inviting me. And without much ado, I would like to start the session because we have both the speakers, I can see them. So the first speaker is Dr. Kamalpreet Sodhi, and she is the Director of Critical Care at the Deep Hospital, Ludhiana. And she's a well-known figure in the field of critical care, is on editorial board member of IGCCM, and has also contributed to the manual on RRT and ECMO. She is a research coordinator for the ISCCM Research Committee, and she is currently the Vice President-elect ISCCM. She has more than 40 papers, 30 chapters, and her areas of interest are nephrocritical care, sepsis, ARDS, resuscitation, airway, and infection control. And she'll be talking about a very important subject, which is surviving sepsis guidelines, which will be very useful for the students. So, Dr. Kamal, over to you.
Good afternoon, everyone. So I'll be talking about surviving sepsis guidelines. Well, sepsis is a major health problem with increasing prevalence and high costs, leading on to poor outcomes. The CDC data clearly showed that patients hospitalized for septicemia or sepsis were almost 8 times more likely to die during hospitalization rather than other diagnoses per se. And not only the mortality, it has been found that sepsis is amongst the top 5 most expensive conditions in US hospitals. And I do not wonder that the Indian scenario may be much worse. So sepsis, how we define sepsis, it's a life-threatening organ dysfunction caused by dysregulated host response to infection. And as of now, the various definitions over the last more than 3 decades have come up, wherein we talk about sepsis, severe sepsis, or sepsis, septic shock. But what we accept as of today is the sepsis 3 definition, that is the life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock, as per sepsis 3, which was published in 2016, has been defined as a subset of sepsis with circulatory and cellular or metabolic dysfunction associated with higher mortality. So this is the definition per se. But clinically, what is the clinical criteria for sepsis is any acute increase in more than 2 SOFA points. More than equal to 2 SOFA points increase is there, then we term it as the organ dysfunction has worsened and there is sepsis. And for septic shock, this underlying sepsis along with circulatory dysfunction, which is defined by vasopressor therapy to elevate mean arterial blood pressure of more than 65 millimeters mercury, and metabolic dysfunction defined by lactates of more than 2 despite adequate fluid resuscitation. So this is how we define sepsis per se. If you look at the Indian case mix from the ICU population, this was the first INDICAP study which showed that around 1/3 of ICU population had severe sepsis or septic shock, and the mortality per se with sepsis was around 18%, whereas when the patients had septic shock, the mortality increased almost double, that is around 34%. Subsequently, INDICAPS 2, which was published in 2021, it again showed that almost the incidence of sepsis is the same, that is around 29% in the ICU population. So when we have such a gross mortality and the poor outcomes associated with sepsis, so we ought to have something to guide us how to manage the sepsis. So surviving sepsis guidelines, which we follow as of today, and what I'll be talking in next 15-20 minutes, is the surviving sepsis guidelines for management of sepsis and septic shock, which came up in 2021. So Surviving Sepsis campaign is actually joint collaboration of Society of Critical Care Medicine, which is an American body, and a European Society of Indian Intensive Care Medicine. And now Indian Society of Critical Care Medicine is also a part of the Surviving Sepsis campaign. And the purpose is to reduce the mortality and morbidity from sepsis and septic shock globally. So we, from year 2002, this is the Surviving Sepsis campaign timeline has evolved, and we have come up with the various guidelines almost every 4 years from 2004 to 2021, which are the latest ones. And what we'll be talking about today is the guidelines which came up in 2021. This is the latest one we have. So various types of recommendations or the statements have been given by this in these guidelines, which can be a strong ungraded, which is the best practice statement as followed by the experts and recommended by the experts. Then there are evidence-based strong recommendations, which are given as double exclamatory signs, and weak graded, where there is only a suggestion because the certainty of evidence is low for these statements. And for few of the things they have given no recommendations. So I'll be touching briefly. These are the topics which have been covered in the guideline statement. I will request all of you to go back and do read these guidelines, but I'll be just touching the basic important aspects wherein which, if at all we have some discussion on sepsis guidelines, or we have a theory-based question on surviving sepsis guidelines, we can answer it fairly well. So for all patients who have sepsis or septic shock, we recommend, the guidelines say that they recommend using a performance improvement program for sepsis. And the recommendation is only using SOFA guidelines, not quick SOFA, as compared to the NEWS, wherein as a screening tool for sepsis or septic guidelines. Then for patients having or suspected of having sepsis, the suggestion is for measuring blood lactates, as I have already told that this is a clinical criteria for sepsis. So what is quick SOFA? Quickly, it is 3 parameters: hypertension, wherein systolic blood pressure is less than 100, altered mental status, and tachypnea with a respiratory rate of more than 22. And it was suggested by the sepsis 3 definition that a score of more than equal to 2 quick SOFA suggested that there is likely sepsis and a greater risk of poor outcome. But the sepsis guidelines say that we cannot use QSOFA as a screening guideline. Then how do we go in for initial resuscitation during sepsis? The treatment and resuscitation should begin immediately. This is a strong recommendation. And there's a suggestion, only a suggestion, unlike in 2016 guidelines, which recommended that 30 mL of IV crystalloid fluid should be given during first 3 hours of resuscitation. So this is important. 30 mL per kg crystalloid fluid within 3 hours. And the suggestion is to use dynamic measures to guide fluid resuscitation, unlike the previous guidelines, which said that static or parameters or physical examination is good enough. Then these resuscitation should be guided to decrease the serum lactate levels. So we have to serially measure the serum lactate levels. And there is a suggestion for the capillary refill time, which we used to talk around more than 2 decades back, that CRT to guide resuscitation is a useful adjunct. So these guidelines do suggest that we can use capillary refill time to guide resuscitation. For adults with septic or septic shock, the recommendations are initial mean arterial pressure target of 65 millimeters mercury rather than going for higher MAP targets. And if at all patients who are in sepsis or in septic shock requiring ICU admission, the suggestion is for admitting into the ICU within 6 hours. So about infection, how we deal with the infection, the recommendation is for administering antimicrobials immediately, ideally within 1 hour of recognition of sepsis or septic shock. And the recommendation is also for rapid assessment of likelihood of infection versus non-infectious causes of acute illness. So we must differentiate that whether it is an infection, and if it is an infection, the antibiotics should be administered within 1 hour, or otherwise we have to rule out the non-infectious causes. Then for patients who have a low likelihood of infection, that we have ruled out that there is likely infection and there is no shock, there is a suggestion, unlike the previous guidelines, suggestion for deferring antimicrobials while we continue to closely monitor the patient. Another important suggestion is for using procalcitonin only for de-escalation of antibiotics, but procalcitonin should not be used for initiation of antimicrobial therapy. Then if there's a high suspicion that this patient is at high risk of MRSA, we recommend that the empiric antibiotics covering MSA coverage should be used. Also, if there's a high risk for multi-drug resistant organisms, the suggestion is for using 2 antibiotics having appropriate gram-negative coverage. But vice versa, if there's a low risk for MDR organisms, we should not use, the suggestion is against use of 2 antimicrobial agents. We should go in for a monotherapy. Then patients who are at high risk of fungal infection, again, the suggestion is using empiric antifungal therapy over no antifungals, but there's no recommendation as of date for the use of antiviral agents. Also, these guidelines suggest using prolonged infusion of beta-lactams rather than conventional bolus doses as we were previously using. So beta-lactams should be given preferably through a continuous or a prolonged infusions. Also, there is a recommendation optimizing the dosing strategies of various antimicrobials based upon the PKPD principles, the organ functions, and the specific drug properties. Then if at all we have a specific anatomical diagnosis of infection, so emergent source control as soon as possible should be undertaken. And if at all any intravascular device is responsible for infection, there should be prompt removal of that device. Also, daily assessment for de-escalation of antimicrobials is a suggestion by these guidelines. We should daily assess that whether de-escalation can be undertaken, and because using shorter over long-term antimicrobial therapy is a suggestion. And as previously discussed, procalcitonin is suggested to be used for discontinuation of antimicrobials. Coming on to hemodynamic management, the recommendation is using crystalloids. I talked about 30 mL per kg over 3 hours. That was a suggestion, but the recommendation is for crystalloids. No, strict no for starches or gelatins. And of the crystalloids, the suggestion is for using a balanced crystalloid rather than normal saline, which can be associated with certain problems like renal dysfunction and increased need for the renal replacement therapy. Suggestion is there for using albumin, only 5% albumin, no 20% albumin for patients who have received large volumes of crystalloids. So if patient needs more than 2 liters or 2.5 liters of crystalloid, then we can use 5% albumin during resuscitation. But starches and gelatins are a strict no. Then for use of vasopressors, the recommendation is very clear. Norepinephrine is the first line agent, and adding vasopressin instead of escalating the norepinephrine dose to super high levels. So vasopressin can be added as a line, but if the patient has associated cardiac dysfunction and persistent hyperperfusion despite adequate volume status, the suggestion is for adding dobutamine or epinephrine as a vasopressor. But the suggestion is also no against levosimendan. No, levosimendan is not recommended for patients with cardiac dysfunction or persistent hypoperfusion. Then the guidelines do suggest that we should go in for early invasive arterial blood pressure monitoring rather than going for non-invasive monitoring as soon as practical or the resources are available. And But if we have there's a delay in attaining of central venous access, the suggestion is there for starting vasopressors peripherally rather than waiting for the central line to be put in. So you can start vasopressors through a peripheral IV access. So vasoactive management is one of the very important aspects of these guidelines. Use norepinephrine as the first-line vasopressor for patients with septic shock, targeting a blood pressure, mean arterial pressure of 65 millimeters mercury, and considering invasive arterial blood pressure monitoring. If central venous access is not yet available, consider initiating vasopressors peripherally. And if MAP is inadequate despite low to moderate dose of norepinephrine, rather than going for super high doses of norepinephrine, consider adding vasopressin. And if the patient has cardiac dysfunction and persistent hypoperfusion, you can consider adding dobutamine or switching to epinephrine. Coming on to ventilation, almost the ventilation parameters remain same as of other non-septic ARDS. So there is a consideration we can use. The guidelines suggest use of high flow nasal oxygen over non-invasive ventilation. But the recommendations as for other parameters of ventilation, including a low total volume ventilation with 6 mils per kg as compared to 10 mils, this is a recommendation, and a recommendation to maintain the upper limit goal of less than 30 centimeter water of blood pressures. Also, the suggestion is for using higher PEEP over lower PEEP. Then traditional recruitment maneuvers can be used. This is again a suggestion for sepsis-induced moderate to severe ARDS. But there's a strong recommendation for using prone ventilation for greater than 12 hours daily. That should be the minimum duration of prone ventilation for patients who have moderate to severe ARDS. Then there's a suggestion of using intermittent neuromuscular blocking agents rather than continuous infusions. And venovenous ECMO is another thing which is suggested when the conventional mechanical ventilation fails. Additional therapies for patients who have an ongoing requirement for vasopressors, there's a suggestion for IV corticosteroids. So we can use hydrocortisone as to treat septic shock patients if adequate fluid resuscitation and vasopressor therapy are not able to restore hemodynamic stability. This is vice versa to the 2016 statement, which was against using steroids. Then the suggestion is against using polymyxin B or intravenous hemoglobin, immunoglobulins, which are not recommended. But other therapies like stress ulcer prophylaxis, VT prophylaxis, or maintaining the euglycemic levels with glucose level of 1 less than 180 and early enteral nutrition are all the suggestions for sepsis patients as for other ICU population. But there is a suggestion against use of IV vitamin C. Then long-term outcomes and goals of care. This is one aspect which has been touched by these guidelines, and the recommendation is there for discussing goals of care and prognosis with patients and families over no such discussion. And this discussion's suggestion is for addressing these goals within first 72 hours of ICU admission. Also, for adult survivors of sepsis or septic shock, there has been recommendation for assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge. So this is one thing which has been touched by the Surviving Sepsis Guidelines 2021, the long-term follow-up of the sepsis patients. So there has been numerous new things in 2021 guidelines: capillary refill time, empirical MRSA coverage, fungal coverage, peripheral vasopressor use, levosimendan is a strict no, HFNC preferred over NIV, use of ECMO, and post-ICU follow-up. They are all the new recommendations. So just summarizing the major guidelines, they say initiate broad spectrum antibiotic promptly, ideally within 1 hour of recognition after obtaining necessary cultures. Source control has to be there, identify, address the source of infection as quickly as possible. And if there's a low likelihood of infection without shock, you can defer antimicrobials while continuously monitoring the patients closely. And MRSA and fungal pathogens, if suspected, empirical appropriate antibiotic or antifungal coverage should be given. Administer at least 30 mils per kg of IV crystalloid fluids, preferably balanced. Suggestion is there for balance of crystalloids within first 3 hours. And for vasopressors, the target map of at least 65 millimeters mercury, norepinephrine as the first choice of vasopressors, and we can start vasopressors peripherally rather than waiting for the central line to be placed. And for sepsis-induced severe ARDS, using VV ECMO when conventional mechanical ventilation therapy fails, and prone positioning for at least 12 hours. And for septic shock and ongoing requirement for vasotherapy, there is a suggestion for IV corticosteroids. And the importance of post-ICU care, including follow-up for physical, cognitive, and emotional functions, should be undertaken. So the major considerations for these, the latest guidelines are blood lactate has been suggested as a marker of tissue hyperperfusion and for guiding resuscitation. This has a weak recommendation, again a weak recommendation for capillary refill time for assessment of perfusion. And Q so far is not recommended as a single screening tool for sepsis. This we have to keep in mind. And using procalcitonin, not to when to start antibiotics, but for de-escalation, there is a suggestion to use procalcitonin. Balanced crystalloids rather than normal saline. This is again recommended for resuscitation. And suggestion for HFNO over non-invasive ventilation in hypoxemic respiratory failure. And the guidelines are against use of vitamin C for sepsis and septic shock. So sepsis is all about time. So it should be considered as a medical emergency, symptoms quickly, properly diagnosed and treated, because every 1 hour delay of antibiotic treatment per se can decrease the chances of survival around 7 to 8%. So what has been recommended in very recent time, last month, this has been published as the AHA suggests a chain of survival for post-cardiac arrest patients. Sepsis chain of survival has also been recommended, which underscores the importance of sepsis awareness amongst masses and prevention, early recognition and prompt emergency medical services activation, effective source control and effective infection management with timely antimicrobial administration within 1 hour, appropriate fluid resuscitation and optimized critical care management, along with comprehensive post-sepsis care. So this chain of survival has been very recently recommended. So we must understand what do we mean by sepsis chain of survival. So to conclude, the surviving sepsis guidelines emphasize the importance and rapidity of appropriateness in the recognition and care of patients suspected to have sepsis. So these are just a guidepost for busy bedside clinicians at providing optimal care, incorporating the evidence-based best practices. But we should understand that the surviving sepsis guidelines strongly emphasize the important caveat that no set of rigid guidelines can replace the rational clinical judgment by the physician on the bedside. So clinical situations are unique. A flexible approach is required at the bedside, which we should all apply when we are taking care of the septic patients, just having a consideration of all these guidelines in mind. So that is all. I hope I made you try to clear out all the things which are important as per the Surviving Sepsis Guidelines 2021. Thank you.
Thank you, Dr. Kamal, for a very elaborate explanation of the Surviving Sepsis Guidelines. And the listeners should understand that these guidelines are being revised every 5-6 years whenever there is new evidence. And they started with the Barcelona Declaration in, I think, 2002, when we had new information. The attempts were being made to standardize the definition so that there is a uniformity in research. Before that, everybody was using their own set of definitions regarding sepsis. So there was a lot of heterogeneity in the publications. And there was excitement also because of the new monitoring modalities, newer drugs that were available. They are withdrawn now. And the first one was funded by the industry. Subsequently, they have been funded by the societies. There's no industry involvement directly. And if you look at these guidelines, we still are not very sure. We dumped SIRS long back.
And we adopted with sepsis 3 definitions QSOFA. Now we have dumped QSOFA. We have adopted back SIRS, and we say news and MUSE, which our emergency physicians use, can be used as a screening tool. And lot of the guidelines, the suggestions are low level or very low level of evidence, and they're weak recommendations. So that means we should not be fighting with our colleagues that the guideline says this and we must do this, because the guidelines are also on very thin ice, and who knows, they may change. So for example, one guideline on blood purification, extracorporeal therapies, it's categorical about toremixin, the polymyxin B hemoperfusion, because the Euphrates study was negative. However, they say we can't comment on cytosol because there is no available data. So until the data is available, we can't comment, and the data will never be available because nobody's doing a randomized controlled trial there. So I think it was an excellent attempt by Dr. Sodhi to give you an overview of the surviving sepsis guidelines. This is where we are. And we are still not very sure. The mortality with septic shock continues to be high. There's no magic bullet as of now. If there are any questions to Dr. Sodhi, they can be asked now. She's there with us online.
We do not have any questions, sir. Till now, we don't have any questions.
Okay. Kamal, would you like to say something as concluding remark, because you are now online?
Thank you, sir. Thank you for having me here. But as you concluded, sir, actually you have made the concluding remarks already, that we do not have a magic bullet, and almost most of the recommendations are only like weak recommendations or not supported by quality evidence. So we ought to stand by the patient, look at the patient and assess, and then go by this. Having these guidelines means just that we have in consideration what the global leaders and across the nation people are using for a specific set of patients. But applying this based on these recommendations, we can just assess the patient and individually treat the patient. So just for targeting MAPS and norepinephrine as a first line, and IV again crystalloids versus balanced crystalloids, they are all gray areas where we cannot comment upon much, but the suggestions are still there, and we are looking, I think in a year or so, we'll have the surviving sepsis guidelines 2026, 20. I don't know, you are the leader, sir, so you can suggest in better way. But I think from the anesthesia question point of view, again, this is an important for the postgraduate students, that routinely they do get a question on the sepsis guidelines or how we are managing the sepsis. So they should be just aware of this aspect from a theoretical point of view as per the suggestions.
Absolutely, I agree. So students must correlate the guideline to the level of evidence and also to the level of recommendation. Thank you very much, Dr. Sodhi. Thank you for your time.
Thank you, sir.
Appreciate it. So I can see Nishant is there online. So
Good evening, sir.
Good evening. We move on further, and can we have Professor Nishant's CV? So Dr. Nishant is Director Professor at the prestigious LHMC, Department of Anesthesiology and Critical Care. He was Editor ISA Delhi 2021-22 and got the Best Reviewer Awards in 2018. And he has been a peer reviewer for many national and international journals. His areas of interest are critical care, POCUS, ultrasound guided. RA is what? Regional
anesthesia, sir.
Anesthesia. Oh, that's great. Sustainability. So he will be talking about nutrition in the critically ill patients. Over to you, Dr. Nishant.
Thank you so much, sir. And I would like to first express my thanks to Dr. Nirja and team RML and Appec for the kind invite. Now, there is, you might find this topic a bit insipid when we talk of nutrition, but this is very important when in the ICU. And I hope my slides are visible.
Yes, they are.
Yes,
Okay,
yes,
thank you.
yes.
So I have no disclosures to make, and my talk would mainly focus on the latest SPEN guidelines 2023. So the objectives of this talk would be why nutrition is necessary in the ICU, how to assess any deficiency or over nutrition, then when to administer nutrition, how to administer it, how much and what to administer, what are the problems, how do we troubleshoot nutrition in specific populations, and then we have different guidelines across the Atlantic, the American guidelines and the European guidelines, and how do they differ. So, malnutrition, basically, let us say it's a misnomer. It should be actually undernutrition or overnutrition or altered nutrition. So, malnutrition is a term commonly used, but it has been associated with increased morbidity, mortality, and length of stay in the ICU, mainly because of increased infection rates, muscle wasting, pressure ulcers, functional loss of the GIT, causes readmission and leads to higher costs. Now, it has been seen that the iatrogenic malnutrition, remember the patient is on the ventilator, the patient is critically ill, so it is the duty of the doctor or the physician to feed the patient. And the iatrogenic malnutrition, the incidence is as high as 38 to 78%. Now, the critical illness can be divided into three phases. That is the acute phase, which is again divided into the early and the late phase. So the acute early phase is around 1 to 2 days of ICU admission. Then we have the late acute phase, which is 3 to 7 days of admission. And then we have the chronic phase or the rehabilitation phase. So basically, the maximum catabolism occurs during the first 7 days. Now, the idea is that the first 2 days we devote towards stabilizing the patient, and if we are not able to feed, it's perfectly fine. But from day 3 onwards, it is mandatory that we institute some form of nutrition, because as you can see that the catabolism is still occurring, and unless until we reverse it by feeding the patient, the consequences are going to be disastrous. Now, in the late phase, the patient can either rehabilitate, in that case, anabolism occurs, so that's a good thing, but the nutrition should continue if the patient enters the chronic phase and the patient is still, the nutrition status of the patient is still altered. So if we see the clinical trajectory of nutrition, so we should always know what is the health status with terms to nutrition before the ICU stay. The patient might be malnourished before the patient is admitted to the ICU, or overnourished in case of obesity, or there might be some pre-existing disease which may preclude nutrition requirements. So as I said, the acute phase of critical illness, which is 1 to 7 days. So the patient might be in organ failure, requiring life support, sedation, vasopressive drugs. Patient might be agitated, unconscious. There might be some procedures which need to be performed. So as you can see, the catabolism is high, and it is only towards the recovery in the ward and at home that the anabolism actually occurs. So during this period, unless until the feeding has been started, the catabolism would continue, and the patient status is going to decline further. Now, what are the causes of malnutrition? So the causes of malnutrition would be the patient factors, which will be poor appetite, early satiety, nausea and vomiting, change of taste and smell, slow eating. This is before the patient might be admitted to the ICU. Then oropharyngeal dysphagia. Once a patient is admitted to the ICU acquired weakness, gastrointestinal disturbances, all these are there. And definitely there would be some psychological disabilities which do happen with critical illness, sleep disturbances, PTSD, pain, fatigue, depression, and anxiety. Then there would be some administrative issues such as organizational process factors, inappropriate delivery times, inadequate prescriptions, missed meals, or the early removal of feeding tubes. So that is very important. Or the healthcare system factors. These should and actually factor the most, where there is a lack of nutritional knowledge in wards, poor handover to ICU to ward, lack of specialized dietetic knowledge, staffing shortage, and financial restraints, which are the most common in the public healthcare hospitals. So a few definitions you should know. So the nutrition that we provide in the ICU or in the hospital is called as medical nutrition therapy. It includes oral nutritional supplements, enteral nutrition, and parenteral nutrition. We'll come to these terms as we go along. Then how to know the body weight of the patient? We have the actual body weight, which is the actual weight as shown on the weighing machine. We have the ideal body weight, which is for sex and height. Then The adjusted body weight is a term which is used for obese. That is the body weight, actual body weight minus the ideal body weight into 0.33 plus the ideal body weight. So these are the weight categories which should be used for the calculation of the energy requirements and the calories in the patient. So the ideal body weight in normal BI patients and the adjusted or the corrected body weight for the obese. Then we have isocaloric diet. That is the energy administration of the defined energy target for that particular patient. Hypocaloric or underfeeding is less than 70%. Overfeeding is more than 110% of the defined target. Then we have got something called as trophic feeding, in which we do continue giving some amount of feeds so as to preserve the intestinal epithelium, stimulate secretion of brush border enzymes, enhance the immune function, and prevent bacterial translocation in the gut. When we talk of low protein diet, that classically refers to a less than 0.5 gram per kg per day of protein intake. So whom to feed? So basically, if we see, the patients in ICU can be categorized into three categories: multi-organ insufficiency, which can't be prevented by nutrition therapy, but it doesn't mean that you don't feed them. Even these category of patients, you should feed. Patients who recover quickly and do not require nutrition therapy. A post-op patient, you might have kept him intubated in the ward for, say, in the ICU, say, for 24 hours or 48 hours and then de-extubate. So in that case, you need not feed immediately, but then yes, once you discharge the patient from the ICU, the patient is to be fed. And obviously, the most impactful or the most effect that we see is in the patient in which the disease course will be positively influenced by the nutritional therapy that we administer. Now, it is mandatory to assess the nutritional status of the patient. So we have, unfortunately, there's only one score which has been developed for the critically ill. That is the Nutrix score that you see here, but that is not validated. But we have the subjective global assessment and the nutritional risk score. All these take into account the medical history of the patient, the nutritional history, physical examination, and severity of disease. By definition, any patient who's admitted to the ICU is severely ill. So that is the score. So we have these screening tools, and subjective global assessment and nutritional risk scores have been found to be better than the other scores. The Nutrix score is still under evaluation. So we have this Nutrix score, the NRS score, then we have the SGA score. If you can see, this is the most extensive one, and the MUST score for the status of the nutrition of the patient. And these are not to be done by one, these are not done once, but these are carried on to see the effect and assess the nutritional status. It should be done at least weekly till the patient is admitted. So basically, this talk would be mainly on the ESPEN guidelines. Now, the ESPEN guidelines define the energy requirement, the protein requirement, micronutrients, the feeding route, and monitoring what is required for feeding. So coming to the guidelines, so every critically ill patient staying for more than 48 hours in the ICU should be considered at risk for malnutrition. That is what we have talked about. So we have to initiate nutritional therapy in all patients after 48 hours of stay. This is the same thing. So we have to do that. And then once we have decided that after 48 hours that the nutrition has to be started, the first thing we have to see is whether the patient is able to feed himself or not. The patient is able to eat or not. So if any kind of oral nutrition is possible, even if partial, so whenever possible, make the patient eat on his own. So oral diet should be preferred over enteral nutrition or parenteral nutrition. Now, what do we mean by enteral nutrition? Enteral nutrition is when we feed via the GIT with the feeding tube in the stomach or the postpyloric region, whereas oral nutrition means when the patient is taking the food himself or herself. So, if oral nutrition is not possible, the patient is ventilated on an IV. There is problems that the patient cannot take, is too weak to accept food. Then we have to see whether the patient can be fed through the feeding tube or not, or enteral nutrition is possible or not. So in case there is no contraindication to enteral nutrition, we have to start with enteral nutrition at the earliest. So if the oral nutrition is not possible, then we go in for enteral nutrition. Now, as I said, if the enteral nutrition is possible, go in for enteral nutrition. We'll see the details later. But if the enteral nutrition or GI feeding is contraindicated for that particular patient, we assess the need for further nutrition. So as I said, we can use any of the 4 scores. The SG and the NRS are much better. So if the malnutrition is confirmed, in the case that we cannot initiate enteral nutrition, we have to initiate early parenteral nutrition. Parenteral nutrition means IV nutritional therapy. So in this, again, we have to calculate the energy requirements, and we do not load the patient with the entire energy requirement at the very beginning, be it enteral nutrition or be it parenteral nutrition. So the nutrition or the energy requirement has to be provided gradually to the patient, as we'll see. So now when we say that the patient has to be given early medical nutrition, either enteral or parenteral, on starting from the 3rd day onwards of admission. So what we have here is early medical nutrition. Let's go to the patient can be fed enterally. Oral intake is not possible. We put in a gastric tube. So within 48 hours, we should consider rather than delaying, or if oral intake is not possible, we should go in for an enteral nutrition rather than for a parenteral nutrition. So oral intake comes first, then enteral nutrition comes the next. So in all these patients, now if you see this list, these are all patients who are critically ill, even with GI surgery, even with severe acute pancreatitis, even when there is abdominal trauma, when the continuity of the GI tract is confirmed or restored, even in patients receiving muscle relaxants, prone position, patients with open abdomen, and regardless of the presence of bowel sounds, unless bowel ischemia or obstruction is suspected, and even in patients with diarrhea, enteral nutrition should be considered in these patients. Now, there are certain contraindications, obviously. So if the shock is uncontrolled and hemodynamic and tissue perfusion goals are not reached, we can start the low dose enteral nutrition as soon as the shock is controlled. In case of life-threatening hypoxemia, hypercapnia, or acidosis, we should wait, but enteral nutrition can be started in patients with stable hypoxemia and pervasive hypercapnia and compensated acidosis. In active GI bleeding, enteral nutrition can be started when the bleeding has been stopped and there is no re-bleeding. But it should be delayed in patients with overt bowel ischemia, high output intestinal fistula, or abdominal compartment syndrome, or if the gastric aspirate volume is more than 500 ml over 6 hours. So this is very important. If the gastric output volume is more than 500 ml over 6 hours, only then the enteral nutrition should be delayed. The dose can be reduced in patients receiving therapeutic hypothermia, in patients with abdominal hypertension but without abdominal compartment syndrome, and in patients with acute liver failure, which is acute or life-threatening. So these are the things where you might have to give a low dose of enteral nutrition. So when to start parenteral nutrition? Now, if there are any contraindications to the enteral nutrition, you can start with parenteral nutrition. So some nutrition is better than no nutrition. So early and progressive PN can be provided instead of no nutrition in case of contraindications for enteral nutrition in severely malnourished patients, or in patients who do not tolerate enteral nutrition during the first week. In these cases, parenteral nutrition, you should see the benefits, and the risk and benefit ratio should be seen. Also, in cases of contraindications to oral and enteral nutrition, parenteral nutrition should be administered, and it should not be administered unless until oral or enteral nutrition has been tried and deemed to have failed, or the patient is not tolerating the enteral feeds. So, delayed medical nutrition, whether enteral or parenteral. So if there is any contraindication for enteral nutrition, we go in for parenteral nutrition, partial if possible, whatever, right? So we have to give some form of enteral nutrition. So in patients deemed to be at high risk of aspiration, post-pyloric, mainly gingival feeding can be performed. The feed that we give should be continuous rather than the bolus. Gastric excess should be used as standard approach, so it should not be post-pyloric or jejunal in the first tolerance. In the first instance, you should first try with the gastric feeding. And in patients with gastric feeding intolerance not solved with prokinetic agents, post-pyloric feeding should be used. So the first thing is oral, then gastric, and then if not jejunal. If even that is not all right, we go in for your for your parenteral nutrition. So how do we calculate the energy requirements? We have these four methods: the indirect calorimetry, which is the standard and the preferred method for detecting the energy requirements, VO2 from pulmonary artery catheter or VCO2 from the ventilator. The least accurate are the predictive equations, Benedict-Harris, but most of the times we do not have these three parameters, so we have to rely on these, but these are the least reliable. So these are the formula. We have to we calculate the BMR, and we calculate the BMR into as per the sedentary, lightly active, moderately active, very active, active. So we calculate the BMR, and the basis of BMR we calculate the energy requirement. So whenever we are providing nutrition, we have to give energy and proteins. So how do we determine? As we said, if we have calorimetry available, that is the most preferred method. If indirect calorimetry is used, now if you have used indirect calorimetry, isocaloric nutrition should be used. That means that the energy requirement should be implemented after the early phase of acute illness. So from the third day onwards, you should try and reach the 100% requirement in these patients. Okay, so if the calorimetry is not available, if the VO2 or VCO2 is available, then these should be used. But then most of the places even don't have that. So we have to use, most of the times you have to rely on the predictive equations. So in these patients, when we calculate the energy requirements based on these equations, we should start with 70% rather than the isocaloric nutrition. And in all cases, in the first 2 days, we should give only 70% of the requirement, not 100%. And from the third day onwards, it should be increased from 70% onwards to 100% from day 3 onwards. Regarding the protein intake, now they say that the protein intake has to be individualized, can be from 1.2 to 2 gram per kg per day, can be delivered progressively, but they say that 1.3 gram per kg is good enough. Now, as the patient starts to exercise or mobilize, then that would improve the beneficial effects of nutrition therapy, and the protein intake can be increased. So what to administer? So we have the glucose as the carbohydrates, glutamine, fish oil, micronutrients. Now let us see the amount of glucose or carbohydrate administered to ICU patient should not exceed 5 milligram per kg per minute. So that is very important. We should not overload them with sugars, lipids. Intravenous lipid emulsion should be generally a part of parenteral nutrition, and intravenous lipid should not exceed more than 1.5 gram lipids per kg per day and should be adapted to the individual tolerance. For glutamine, specifically in burns, then in critical ill trauma, additional doses of glutamine 0.2 to 0.3 grams per kg per day can be administered for the first 5 days with enteral nutrition, and it can be extended to 10 to 15 days in case of complicated wound healing. In ICU patients, except burn and trauma patients, additional enteral glutamine should not be administered. In unstable and complex ICU patients, specifically from liver and renal failure, glutamine dipeptide should not be administered. Regarding omega oils, Fish omega-3 should not be given as a bolus. Enteral nutrition enriched can be given. High doses should not be given on a routine basis. And parenteral lipid emulsions enriched with fish oil dose 0.1 to 0.2 gram per kg per day can be provided in patients receiving parenteral nutrition. For the micronutrients, a trace element should be provided daily with parenteral nutrition. Antioxidants as high-dose monotherapy or combination therapy should not be administered without proven deficiency. And vitamin D, if depleted, then can be administered. So all patients do not require vitamin D. In special cases, so we see in the non-intubated patient, with oral, we should supplement with enteral. If not enteral, then parenteral. In patients with dysphagia, texture-adapted food can be considered. And if the swallowing is contraindicated, then enteral nutrition should be administered. In patients with dysphagia and a very high aspiration risk, post-pyloric enteral nutrition or parenteral nutrition should be considered. In the surgical patients, these are the patients that we encounter the most. Early enteral nutrition can be preferred over delayed enteral nutrition. That is, after the third day, we can, within the 48 hours or after the third day, we can prefer. In surgical complications, enteral should be preferred unless there is a contraindication to the enteral nutrition. Parenteral should come later. In the case of unrepaired anastomotic leak, internal or external fistula, feeding excess distal or a feeding jejunostomy would be better, and then we can aim for an enteral nutrition in these patients. In the case of unrepaired leak or fistula, parenteral nutrition remains the choice. In case of high output stoma or fistula, the appropriateness of chyme reinfusion or enteroclysis should be reevaluated and performed if adequate. In the trauma patients, early in enteral nutrition as instead of parenteral nutrition. In the septic patient, again, early and progressive enteral nutrition should be used once the hemodynamics have been stabilized. If contraindicated, enteral nutrition should be replaced by progressive parenteral nutrition. In the obese patient, isocaloric high protein diet can be administered, preferentially guided by indirect calorimetry. So we say that protein delivery should be guided by urinary nitrogen losses or lean body mass determination rather than anything else. And adjusted body weight should be used as I showed in the formula. So monitoring is for glucose and insulin and enteral feeding tolerance, so glucose monitoring. Then we have the gastric feeding intolerance. Intravenous erythromycin should be used as a prokinetic therapy. Intravenous metoclopramide and erythromycin can also be used. For refeeding syndrome, we monitor the electrolytes actually daily, and hypophosphatemia should also be considered in this patient. And a drop of more than 0.16 millimole per liters electrolyte should be measured 2 to 3 times a day and supplemented if needed. So normally we should have a protocol, and first line is gastric rather than post-pyloric. Prokinetic agents in case of vomiting. Use a small bore tube, 14 French is good enough. Routine radiography can be done to know that the tube has not dislodged. Enteral nutrition should be continued in the prone position if they can it can be used. Fiber should be used, and continue enteral nutrition until extubation. So there is on the other side of the Atlantic, the American Society, the energy intake, they found that instead of 12 to 25, whether you give 12 kilocalories or 25 kilocalories, the outcome is the same. Protein intake, again, they have said 1.2 to 2 gram per kg per day. 1.2 is the same as 2 gram per kg. And they do not say whether enteral is better or parenteral is better. They say that either is acceptable if the energy goals is met. Aspen says enteral is better, but Aspen says, America says that both are equal, whatever you want to give them. But if the enteral nutrition is not adequate, supplemental parenteral nutrition should not be started before 7 days. Whether to give mixed oil or 100% soybean oil, anything can be given, and either fish oil or non-fish oil intralipid emulsion within the first week should be given. to summarize, this is the summary of the ESPN guidelines. So clinical nutrition, if oral nutrition is possible, go ahead with it. If no, then you see whether there's any contraindication for enteral nutrition. If the enteral nutrition is contraindicated, you screen, assess, malnutrition is there, you go in for parenteral nutrition. If not, then again you assess after some time whether enteral nutrition can be started. Whenever enteral nutrition can be started, you start with enteral nutrition, you meet the energy and protein targets, other substrates, you consider the special cases, you monitor for tolerance and refeeding as suggested, and then you progress to the targets and shift to oral as the patient recovers. So thank you, and I hope this will help in the postgraduates in planning and describing the education, the nutrition in the ICU. Now, the questions that are generally asked in the anesthesia exam, you do get a theory question, how to calculate the energy requirement in a patient. So those are the 4 methods that have been described. What are the various scores that can be used, and what are the energy requirements, how to go about the plan of nutrition, how to feed a patient in the ICU. Then you might be given a clinical case, say a COPD case, or a case with liver failure, or a case with renal failure, and then you have to plan the nutritional requirement, whether to cut down on carbohydrates, give high carbohydrates, or the proteins and the fats, and accordingly they might ask you. So thank you very much, sir. Over to you, sir.
Thank you, Dr. Nishant, for an excellent overview of the subject. And thank you for telling the students what are the questions that are expected. So your last slide also touched upon refeeding syndrome. That is also a question that is often asked. So if you can just elaborate a bit for the students' benefit about refeeding syndrome.
So the refeeding syndrome is that basically when we feed the patients, now the body is not actually tolerant to the feeds, and then the electrolyte imbalance, hypophosphatemia occurs, the sugars might shoot up. So all these things, and the tolerance with the enteral nutrition, specifically the bloating sensation and everything, the patient tends to vomit, nausea is there. So that things are there. Actually, sir, this is more of a critical care situation for refeeding rather than for anesthesia. So I think you'll be in
I will add something
sir,
for the
add
students'
to this thing,
benefit.
sir.
Because you see, it is in context of those who are significantly malnourished.
Right, sir.
And those who have been fasting for a prolonged period of time, cachexic, alcoholics, oncology patients who are run-down patients, and also uncontrolled diabetes, and very thin patients where BMI may be very low, 15, 16, like that. So when you start, see what happens in these patients, the metabolism changes. Normally it is carbohydrate based, so it changes to fat and protein based metabolism, where these are being utilized for energy, and fatty acids becomes the main source of energy. There is production of ketone bodies, and brain is more or less accustomed to shifts from glucose based information to ketone based information. And there is almost significant reduction in the BMR also, to almost 1/4 of the normal. It can go down. And when you restore, and again, the minerals are all depleted, and whatever minerals are there, they will come to the serum to maintain the functionality. But overall, the phosphorus, magnesium, etc., their levels go down. When we start feeding them, now we are changing this from a fat-based system to carbohydrate-based system. Again, glucose load will lead to insulin secretion and so on and so forth. So finally, there it will lead to your fat and protein synthesis also, because the normal metabolism is being restored. Now, these synthesis processes requires a lot of phosphate, magnesium as the cofactor, and so these minerals are utilized there, and also the minerals can move intracellular now. So there is relative and significant deficiency of these minerals, causing dangerous cardiac arrhythmias, heart failure, and patient can go into multi-organ dysfunction syndrome. Even death can occur. So that is why we start feeding them slowly. Don't feed them, full calories. Start very, very slowly. You can build over a week or so. So that is only applicable to patients who are severely malnourished. And I think you have covered most of the things very, very nicely. So students should know the must score is a new score where you can also monitor how much you are feeding, the impact of feeding. Nutric score, some people say, is more of a critical care score because it has two components. One, if you have the IL-6 value, one when you don't have. And so some people believe that NRS 2000 is a better score. But the idea is we must assess for malnutrition. If the patient is malnutrition, nutrition becomes a priority from day one. If the patient is not malnourished, then you can very well wait. It is not such a big priority. You can wait easily. So thank you very much. If there are any questions, I don't see any question in the chat box. Are there any questions?
Yes, sir. There are two questions for Dr.
Yeah.
Nishant.
Yeah.
One is when we are talking about permissive underfeeding or trophic feeding, and that you have mentioned that in first 48 hours, which component of the feed is it? The carb, protein, the fat, which should decrease, and why? And is it just the total calorie?
See, it is the total calorie. Now, whenever we calculate the total calorie, when we talk of trophic feed is totally different. Trophic feed is something that is given for the gut to be active. That is the main idea, that the blood to the gut should be maintained. So we can very well just give a D5 solution just to keep the gut active for the absorption, to occur, and there is some blood flow. See, why do we feel asleep after having meals? Because the blood is diverted towards the gut and the RAS is deactivated because of that. So there's a relative low blood flow to the RAS. So whenever we are giving something to the gut, the blood preferentially flows towards the gut. So this is to prevent gut ischemia, to maintain gut motility, and to prevent the translocation of bacteria. So even RL.
Very important point. Please understand, gut is the largest immune organ in our body, and the stimulus for gut is some food. So you want to load it with some food, but the gut is, you can't give everything. So that is why the concept of trophic feeding has come. And then as the patient improves, you can build it to a full nutrition.
Oh, okay, sir. So one more question. I think this is very common question. How much of RT aspirate is important to stop the feed, or should we just ignore it?
So that is what the guidelines say, 500 ml over 6 hours. Anything more than that, only then you stop feeding. And then even then you give rest. You can give feeds in an upright position. You can decrease the volume of feeds. You give it as a continuous infusion rather than as a bolus. You start with prokinetic agents and then you start refeeding.
See, these two things, presence of bowel sounds and the aspiration, are quite controversial, and one should not limit the enteral feed just because of that. As Dr. Nishant has said, that prokinetics can be utilized. The strategy these days is to maximize somehow enteral feeding, the toleration of enteral feeding. And bowel sounds are subjective, so we don't base our judgment based on bowel sounds.
Thank you, sir. Thank you, Dr. Nishant, for a wonderful lecture. Thank you, Rajesh, sir, for your expert insight on the topic.
Thank you, Team Appec. Thank you. It's a great
Thank you so much.
effort and a great meeting. Thank you very much.
Thank you. Thank you so much.
Sir.
Thank you, Dr.
We would like to flash the questions pre-lunch which was skipped. The two questions, MCQ questions. Sudhir, if we can have that on the screen. So the first question is, a 55-year-old male with the diagnosis of ARDS is scheduled for urgent surgery under general anesthesia. Which of the following ventilatory strategies is most appropriate to minimize the ventilator-associated lung injury during anesthesia management? Option A, use of high tidal volumes to ensure adequate ventilation and oxygenation. Option B, use a low tidal volume strategy and consider permissive hypercapnia to reduce the ventilator-induced lung injury. Increase the inspiratory pressure to improve the tidal volume delivery while keeping the respiratory rate high to maintain the minute ventilation. Maintain an FiO2 of 100% throughout the procedure to maximize the oxygenation and hypoxemia. Second question. A 68-year-old male is recovering from surgery under general anesthesia. He is now being considered for extubation. Which of the following condition is most critical to ensure before extubation according to current extubation guidelines? Option A, spontaneous tidal volume greater than 5 ml per kg body weight. Option B, stable hemodynamics with a systolic blood pressure of over 100. Presence of functioning cough reflex and adequate ability to clear the secretions. Option 4, complete resolution of muscle relaxation with the negative inspiratory force of at least 25 centimeters of water. With this, there is a slight change in the program. So the case discussion, which was scheduled for now, will be taken after the lecture by Dr. Shivpriya. And to take the session forward, we would like to invite our chairperson, Dr. Rupesh Jain. And we have Sir CV. Dr. Rupesh Jain, sir, did his MBBS from GMC Bhopal, 1999. And he did his MD again from GMC Bhopal in 2004. He is trained in pain management from AIIMS, New Delhi, from 2005 to 2008. He has started the first comprehensive pain management clinic in 2009 by the name of Panacea Pain Relief Clinic. He has 21 years of experience in the field of pain medicine. He is the founder and director of Global Pain School. He is the course director of Fellowship in Pain Medicine by Global Pain School. He is a member of Specialist Board of DMD Palliative Medicine. He is a faculty at Asia Pacific Hospice and Palliative Care Network, Singapore. He has various research articles published in national and international journals. We welcome you, sir. We would like you to introduce our first speaker for the session.
Thank you for the kind introduction. So I would like to invite Dr. P.N. Shivpriya. She is professor at AVVIMS and Dr. RML Hospital, New Delhi. And she's a part of team who has started palliative care wing in Dr. RML Hospital. And I proudly say that she is associated with our organization, that is CTC and Asia Pacific Hospice and Palliative Care Network. And her area of interest is ultrasound in anesthesia, palliative care, and difficult airway. So without wasting time, I would like to invite Dr. Shivpriya.
Today, we will be talking about cancer pain. It is one of the very important topics for exam also. You get one or more questions out of it. So let's quickly overview the presentation. So we'll be talking about introduction, classification, assessment method, approach to pain management, and very important analgesic step ladder. So update on prevalence of pain in patients with cancer 2022. They found out 44.5% of cancer patients still experiences pain. Cancer pain is very complex and multifactorial. So whatever the patient tells the clinician about his physical pain, it is the visible pain, it's only the tip of the iceberg. Majority, 90% of pain that he is suffering, going through psychological, spiritual, social, is always hidden from clinician, from their caregivers. Usually cancer pain is more intense because of the cancer cells, macrophages, inflammatory cells. They collectively generated elevated level of COX-2 enzyme, which leads to increase in prostaglandin production. As tumor grows in size, it invades the nearby structures. It can give rise to new pain, and it stretches the sensory fibers. It can lead to nociceptive, visceral pain, and neuropathic pain.
So these invading inflammatory cells, they also release hydrogen ions, causes extensive apoptosis and intensify the acidic condition inside the neoplastic tissues. Further peripheral sensitization and central sensitization that leads to chronic pain. It can be classified according to the etiology. It can be primarily caused by cancer, caused by treatment of cancer, that is radiotherapy, chemotherapy. Itself, it causes neuropathy. Other debilitating conditions. It can be classified according to pathophysiological classification like nociceptive, neuropathic, mixed pathophysiology, psychogenic. Severity based like mild, moderate, severe. Temporal classification says it can be acute, breakthrough, or chronic, that we will be discussing further. So acute cancer pain is usually because of invasion of pain sensitive structures that typically induced by tissue injury, which causes inflammation, edema, acidosis, necrosis, and it can disrupt normal physiological process. But cancer pain usually does not only have acute cancer pain. The most debilitating is the chronic cancer pain that develops after central sensitization, also because of the neuropathy and various other factors. It presents significant challenges and impacts many aspects of life. It can alter personality, daily functioning, overall quality of life. It can cause psychological depression in patient, other kind of distress. It includes both persistent pain and breakthrough pain. So what is breakthrough pain? It is a sudden flare-up of moderate to severe pain in a patient otherwise stable persistent pain. It usually starts quickly and lasts from few minutes up to an hour. It can happen multiple times in a day. It can be spontaneous. It can be incident pain triggered by some incident, non-volitional, volitional. Volitional means it can be caused by voluntary action. It can be procedural due to any procedure. So how to screen this pain and how to do various assessment techniques? What are the various assessment techniques of pain? So while screening, while diagnosing assessment of pain, we have to keep in mind that we have to follow holistic approach for this pain. The total pain needs to be considered. It includes all the aspects of pain: physical, psychological distress, socioeconomic, and spiritual distress. So holistically, we have to screen it and try to manage all aspects of pain, the total pain. History is very important screening. It can be done by this mnemonic OPQRST, O for onset. What is the onset of the pain? What are the precipitating elevating factors? What is the quality of pain? Is it nociceptive? It is mixed? It is, or is it neuropathic? Is it radiating to some part of the body? How severe it is? What is the site of it? And what are the timing, etc. What are the other comorbidities that patient is suffering from that can lead to other types of pain not related to cancer? How much is the functional status of the patient? What is the family history? So there are some tools that may be unidimensional or multidimensional. Amongst unidimensional, we have this non-verbal Wong-Baker faces. So this scale has many faces which show a smiling face or neutral face or a crying face. So it is used for more than 3 years of age, and patient can show that according to expression, what the patient is feeling. And it can be this on the right side, it is a verbal assessment tool. It shows a scale and patient is instructed to indicate the intensity of current, best and worst pain levels over the past 24 hours on a scale of 0 that indicates no pain to 10. That indicates worst pain imaginable. Scale of 1 to 3 comes under mild pain, 4 to 6 comes under moderate pain, and 7 to 10 comes under severe pain. Other verbal categorical scale in which patient can describe their pain as none, mild, moderate, severe. One is visual analog scale, which shows a scale on towards the left side. There is no pain, and right side worst pain. Patient can indicate where their pain lies. Then there are some multidimensional tools like questionnaires like McGill Pain Questionnaire, Brief Pain Inventory, Memorial Pain Assessment Card, Memorial Symptom Assessment Scale, Edmonton Symptom Assessment Scale. This is obviously more time consuming because it has a questionnaire, but it gives a detailed validated pain and symptom assessment scale. So this one of this scale is Edmonton classification system for cancer pain. It has 7 domains, which includes mechanism of pain, characteristics, cognitive function, previous opioid use, psychological distress, tolerance, and history of such related pain. How to approach for the management of this pain. So there are some general principles we have to follow. So we have to aim to treat the pain promptly and prevent its recurrence. We have to set realistic goal. Patient and their attendant should be instructed about the pain and encourage them to take part in active role in managing it. Pain review is very important. It has to be evaluated in relation to each pain. New pain can develop, and old pain may get worse. So each pain has to be assessed individually. And patient's expectation regarding optimal pain management has to be discussed, as it may not be achievable for them to be pain-free at all the times. So how can we target this pain? So we can target the source of the pain as if removal of the source to removal of the tumor growth, if surgery is possible, surgery, but itself it can cause acute and post-surgical pain syndrome. Then radiotherapy, chemotherapy, which decreases the size of the tumor, but it itself can cause post-radiation pain. Chemotherapy can cause chemotherapy-induced neuropathy. Then central perception can be altered, like by pharmacological analgesics, that is most common. Then psychological support and relaxation techniques, which has to be incorporated with these pharmacological analgesics. All these analgesic method, pain management method, we have to use in sync with each other. It has to be multimodal. It cannot be only one therapy cannot be done. We have to mix and match all the therapies. Then pain transmission can be blocked using local anesthetic, regional drug infusion at epidural, intrathecal, intraventricular, or perineural site. Neurosurgical techniques can be done. So we come to analgesics, which is first line of treatment. And it has to be given according to WHO analgesic ladder and NCCN guidelines. So WHO says that analgesics has to be given by the mouth, by the clock, by the ladder, and the treatment has to be customized according to the patient, and adjuvant drugs has to be used with all the steps. So the right drugs by the right route in the right doses at the right time interval. So by the mouth means oral, it has to be given maximum. We have to try to give the drugs by oral route. It is the standard route, including strong opioids. Because injection needs professional help, it needs hospital admission. Itself is a source of pain. By the clock means round the clock we have to give the medication. It has to be preventive therapy. Otherwise, the PRN medication alone is irrational and inhuman. And all the side effects has to be explained to the patient, and danger signs also need to be explained to the patient. So this is the analgesic step ladder. Initially, it used to be only 3 steps. In step 1, non-opioids and adjuvants. In step 2, along with non-opioids and adjuvants, weak opioids were added. In step 3, along with non-opioids and adjuvants, strong opioids were added. And it was only one way, step 1, then step 2, then step 3. Then it was modified and step 4 was also added, in which they added invasive and minimally invasive treatment when there is no pain relief or opioids are contraindicated. And it was 2-way. For acute pain, it was from step 4 to step 1. And for chronic, it was from step 1 to step 4. We should observe that in each step, non-opioids and adjuvants are added. So it is a multimodal analgesia. So these are the various non-opioid analgesics, weak opioids, strong opioids, and adjuvants. So when we come to paracetamol, So we come to paracetamol. The dosage is for more than 50 kg adults. Dosage is usually 1 gram 6 hourly and maximum 4 gram in 24 hours. And if there are some risk factors like old age, chronic alcohol use, low weight, malnutrition, anorexia, maximum dose is 3 gram. Dose has to be reduced, and it can be given as 500 mg QID. Then in children between 10 and 50 kg, the dose will be 15 mg per kg, maximum of 60 mg per kg in day. So for renal impairment, in patient with renal impairment in which creatinine clearance is less than 30 per minute, the dose interval can be reduced and dose can also be reduced. In severe hepatic impairment, IV use is contraindicated, and even chronic paracetamol use can increase the risk of renal impairment 2.5 times. And the most dispersible and effervescent PCM would exceed the recommended daily sodium intake, so that has to be kept in mind. So NSAIDs, mechanism of action, they inhibit COX-1, COX-2 enzymes, reduce prostaglandin, and decrease pain by lowering pain receptor sensitivity, also reduce inflammation and edema. These are the various NSAIDs and their peak plasma concentration, duration, and dosage. So what are the risk and precaution that has to be taken with NSAIDs? There are various risks. So risk for GI toxicity increases in elderly patients more than 60 years. If concomitant use of glucocorticoids, aspirin, anticoagulants, or high dose of NSAIDs. Then if history of peptic ulcer disease, other major organ dysfunction, and significant alcohol use. Renal toxicity risk is increased in elderly patient, and if patient is of compromised fluid status, patient has diabetes or interstitial nephritis, papillary necrosis, if urea creatinine is raised, NSAIDs has to be discontinued. The vascular event risk is increased if already there is history of cardiovascular disease, hypertension, stroke, TIA, and CCF. And it has to be discontinued or it is contraindicated rather if history of NSAID-induced asthma or any allergic reaction is there. Then when we see opioids in step 2, we add weak opioids. Step 3, we add strong opioids. We'll be seeing now opioids. So severity is not the only criteria to start opioids. There are various opioid resistant pain. So muscle spasm, abdominal cramp is resistant to opioids. Then semi-resistant pains are bone pain. It is very difficult to treat even with morphine, raised intracranial pressure, neuropathic pain, activity-related pain. All this needs adjuvants along with opioids. Then psychosocial pain, spiritual pain, all these pains are opioid-resistant pain. So we see now we move forward to tramadol. Tramadol is a synthetic centrally acting analgesic. It has both non-opioid and opioid property. And it significantly improves neuropathic pain and also cough that is comparable to morphine. It causes less constipation and respiratory depression than equianalgesic doses of morphine, and it is not a controlled drug. Its maximum dose is 400 milligram per day. Its analgesic effect is reduced by ondansetron. So this is its pharmacokinetics, and major adverse effects that you should know: dizziness, nausea, vomiting, headache, drowsiness. Patient should be made aware of all these adverse effects. Special caution to be observed in patients with epilepsy, head trauma, raised intracranial pressure, and in severe hepatic impairment and renal impairment, dose has to be reduced. Then tapentadol, it is a centrally acting analgesic with dual mode. It has action on mu opioid receptor and also act as a norepinephrine reuptake inhibitor. Its dose is 50 to 100 milligram orally, and it can be given at the interval of 6 hourly or 4 hourly. Maximum is 600 milligram per day. And in moderate hepatic failure, the dose has to be reduced but avoided in severe hepatic impairment. And special precaution should be excised in patient with epilepsy, head trauma, as we saw with tramadol, in severe hepatic impairment, renal impairment, and compromised respiratory function. Now we come to morphine. Oral morphine is gold standard treatment in palliative care practice. It is usually given because of its duration of action. It is given in 4 hourly dose. And this dose can be increased till adequate analgesia is achieved. So no proper maximum dosage is there. The dose can be increased till adequate analgesia is achieved. Along with this 4-hourly dosage, a breakthrough dose should always be prescribed. That is usually 1/6 to 1/10 of the total 24-hour dose. And along with the morphine, a regular laxative and antiemetic should be prescribed, because constipation and vomiting is the major side effect seen with morphine. So this morphine oral tablet comes as immediate release tablet of the strength of 10 mg, 20 mg, 30, 60 mg, and also sustained release preparation also comes in strength of 10, 20, 30, and 60. For parenteral morphine, injection morphine comes as dilution of 10 mg in 15 mg per ml. So it is usually diluted in 0.9% saline or 5% dextrose. If we want to convert the oral to parenteral dose, it is 1/3 of the oral dose, parenteral. Breakthrough dose should be given with parenteral also. After the proper titration, then parenteral IV morphine can be given as continuous subcutaneous infusion or continuous IV infusion. And it can mix with drugs such as midazolam and metoclopramide. So this is the basic pharmacokinetics. So how to start the patient on oral morphine? So when pain does not respond to optimized combined use of non-opioid and weak opioid and pain scale of more than 7, we have to start on oral morphine. So initially, when you start on oral morphine, we start with the immediate release preparation. So which is given 4-hourly along with the SOS dose for breakthrough pain of equal amount. That is 1/6 of the 24-hour dose. So after 1 to 2 days, this dose has to be recalculated according to the total usage of the total dosage usage along with breakthrough dose that was used in previous 24 hours, regular plus SOS use. So after calculating total, the dose can be increased and then continued for 4-hourly and SOS doses. So this regular dose can be increased until the adequate relief is obtained throughout each 4-hour period. The bedtime dose can be given as double dose because patient needs not to wake up every 4 hours to take his oral morphine. So the bedtime dose can be a double. After attaining stability with this dosage, then patient can be switched over to sustained release tablet. That is 12-hourly dosage. So it comes out to be 3 times the previous 4-hourly dosage. Now we come to intravenous titration. When pain is more than 7/10, with severe pain, patient comes along with metoclopramide has to be given before it, and morphine dilution is made as 1 mg per ml. 1.5 mg is given. Start with 1.5 mg every 5 minutes. Patient's vitals, respiratory rate, response has to be noted, and then this dosage is repeated. After 2 dosage, if the NRS scale is more than 6/10, double the dose. And what is the end point? When patient becomes pain-free, or that is less than 3 on pain scale, or patient becomes sedated, or any side effects come like nausea and vomiting. Now, post-titration, patient can be put on continuous infusion, IV or subcutaneous, that can be given by patient-controlled analgesia pumps, or intermittent bolus can be given, or patient can be switched over to regular oral medication. And the conversion ratio of oral to intravenous is 1:3, and oral to subcutaneous is 1:2. Other alternative routes of morphine. So other alternative routes are buccal, rectal, spinal, topical, and through nebulization. So opioid naive patient is naive implies that patient is not on opioids for more than 6 weeks. And tolerance is less than expected response to an opioid. So these are various oral to oral conversion of various opioids. Codeine to morphine is 8:1, tramadol to morphine is 5:1, and so on. So fentanyl patch is very common in usage in cancer pain management. So transdermal patch, it has onset of action of 3 to 23 hours and half-life of 13 to 22 hours, and duration of action is for 3 days, 72 hours mostly. So it is usually prescribed when there are intolerable, undesirable side effects with morphine, or renal failure, or oral morphine is not feasible, or some patient prefer patches. So for them, we can use this. And equianalgesic doses of oral morphine and fentanyl are, if 30 mg in 24 hours oral morphine the patient is taking, then we can put 12 microgram per hour transdermal patch. So this is equivalent dose, 30 and 12. So patient needs to be made aware of the common and very common side effects of this patch, like drowsiness, dizziness, headache. These are very common side effects. And abdominal pain, anorexia, anxiety, diarrhea, dry mouth. This has to be explained to the patient. Next, we come to the buprenorphine. It is a partial mu receptor agonist and antagonist at kappa and delta receptor. It has a bell-shaped dose response curve, that is ceiling effect of analgesia due to partial agonist action at mu receptor. So it causes less hyperalgesia, less tolerance, and less effect on endocrine and immune system. Equianalgesic doses is shown in the table. So there are various adjuvants that needs to be used along with these opioids and non-opioids. Steroids are most very common in use, and dexamethasone, prednisolone is used. Then some drugs that are used for neuropathic pain as adjuvants are anticonvulsants, gabapentinoids, gabapentin, pregabalin, sodium channel drugs, GABA agonist, and NMDA inhibitors. Then some drugs that are used for bone pain are bisphosphonates, pamidronate, flodronate, etc. Then we come to interventional techniques. Interventional techniques are indicated when there is failure of conventional therapy and significant pain from locally advanced disease, severe neuropathic pain, or severe pain on movement. And goal is to alleviate cancer pain and reduce overall analgesic use. These can be achieved by neurolytic technique, example celiac plexus block. For pancreatic pain, neuromodulation technique, in which local anesthetic blockade, epidural, intrathecal, intraventricular, or perineural infusions are done. Then surgical techniques can be done like thalmotomy, cingulotomy. So this is a picture that shows at various levels that ganglias can be blocked. So it can be done by chemical neurolysis, which uses alcohol 50 to 100%, phenol 5 to 15%, or glycerol. Radiofrequency thermocoagulation can be used, and cryotherapy can be done. Then epidural or intrathecal drug delivery methods. Implantable system are used in which patient's life expectancy is several months or more. But if the patient is expected to live only weeks, then tunneled epidural catheters are used. That is less invasive. Opioids, clonidine, ketamine can be given through, etc. can be given through these drugs. Then complementary and alternate medicine. That includes TENS unit, acupuncture, aromatherapy, music therapy, herbal medicine. All these complementary and alternate medicine methods can be used along with our mainstream pain management techniques. So to conclude, cancer pain management is complex but manageable, and effective pain control requires a multimodal comprehensive approach guided by routine pain assessment. And it combines pharmacologic and non-pharmacologic methods along continuous patient reevaluation. So let us treat cancer pain with the dignity and science it deserves. Thank you.
Wonderful presentation, Dr. Shivpriya. A comprehensive review on cancer pain management. As you all know, the oral morphine tablet is the gold standard of management of cancer pain. And yes, early incorporation of interventional modality will be beneficial for refractory cancer pain.
Thank you, Dr. Shipriya. Thank you, Dr. Rupesh. We do not have any questions on this session. If there are any questions, we will be flashing it later. As of now, there are no questions.
Thank you, Dr. Anupma. Thank you, Dr. Rupesh Jain, sir. It's wonderful to meet you again on online platform. Thank you so much because you are my teacher and you have taught me so many things about cancer pain.
So, thank you. So, with this, we go on to our case presentation. After that, the remaining lecture would be happening after the case presentation. For the cases of a 54-year-old male with progressive jaundice, pruritus and rapid weight loss, planned for Whipple's procedure. To moderate the case, we have with us Dr. Nishkarsh Gupta, sir. Can we have Sir CV? Sir is professor in onco-anesthesiology and palliative medicine at AIIMS, and he has received Best Researcher Award by the ISA in 2021. He is a faculty at National ICA and ISA and international conferences for the last 15 years. He is a member of ICA since 2008. He has edited the South Asian edition of Barrage, Stolting and Dosh and Dosh. He got second prize in research in Raspacon in 2018 Jaipur. He has received Best Paper Award in IAPC 25th Conference at AIIMS. He has conducted more than 50 airway and ACLS workshops across India and SAARC countries. He has 261 articles to his credit, plenty of books and book chapters in anesthesiology. We welcome you, sir. His areas of interest are onco-anesthesiology and palliative medicine.
Thank you, Anupma.
And to present, thank you, sir. And to present the case, we have with us final year postgraduate Dr. Deepthi Chandra. And along with her, the case is also being moderated and summarized, will be summarized by Dr. Neeru RSR. Over to Dr. Nishkarsh, sir, to conduct the session.
Thank you. Thank you to the team RML, Nirja ma'am, Akhilesh, Namita, everybody. So I feel part of RML since I joined and left. So it is my second home as always. So without wasting time, we'll discuss about obstructive jaundice. So this is an important case and you will get this in one way or the other in your exam, whether it is theory or a long case or maybe a short case, depending on the scenario. So over to you, Deepthi, to present the case and then we'll take it forward.
Thank you, sir. Good afternoon, everyone. I am presenting case on obstructive jaundice posted for Whipple surgery. Mr. Kamal, 54-year-old male patient, tailor by occupation, resident of Patel Nagar, Delhi, belonged to the lower socio-economic status. Chief complaints: patient presented with yellowish discoloration of skin and eyes since 6 months, decreased appetite and weight loss of 7 kgs over a period of 3 months, generalized itching since 2 months, passage of clay-colored stool for 1 month. History of present illness: the patient was apparently well 6 months back when he developed yellowish discoloration of the eyes, urine over last 3 months, which was insidious in onset, gradually progressive. History of loss of appetite and weight loss of 5 kgs over a period of 3 months. History of passage of clay-colored stool 3 to 4 episodes per week since 1 month. History of itching all over the body for 2 months. History of passage of dark-colored urine for 2 weeks. History of easy fatigability present. History of nausea and occasional vomiting present, which is non-projectile, non-bilious, and contain food particles.
So before we proceed further, why do we have asked so specific negative history? Can you just elaborate upon the reasons for this negative history?
Yes, sir. Sir, no history of prodromal symptoms like fever, joint pain before onset of jaundice, and fever, chills, rigors, and associated abdominal pain to roll out viral hepatitis. No history of coffee-colored vomitus, black tarry stool on bleeding from nose. No history of abdominal pain and distension to rule out ascites. No history of intake of steroid or herbal medication. No history of trauma, hematoma, or blood transfusion to rule out hemolytic pathology. No history of decreased vision at night, bone pain, or frequent bruising or ecchymosis to rule out fat-soluble vitamin malabsorption. No history of IV drug users prone to tattooing, recent travel history, or blood transfusion, multiple sexual partners to rule out hepatitis history. No history of decreased urine output to rule out acute kidney injury. No history of chest pain, cough, breathlessness on exertion to rule out cardiovascular system. No history of altered sensorium, sleep disturbance, or convulsions to rule out Sir, CNS system.
Okay, so basically, patient had yellow discoloration of
Yes, sir.
sclera. So, what is the possible diagnosis, DD of the initial symptom the patient has presented?
Sir, my patient presented with yellowish discoloration of the skin and yellowish discoloration of the urine, clay colored stool. So it might be obstructive pathology.
So
And
might
or malignancy
might
also.
be most likely icterus, might be jaundice, and we need to find out what are the possible ways it may occur. Okay, the next, please proceed. We'll see what is.
Yes, sir. Past history, no history of any comorbidity, no history of similar complaints in the past, no history of previous surgery, family history, no significant family history.
So by history, how do we know the possible cause of yellowish discoloration or jaundice or whatever we may call, depending on the scenario? So
Sir, pardon, sir, question.
how do we decipher from narrow down from history the possible cause of icterus or jaundice in this patient?
So there will be yellowish discoloration in the sclera. There will be
Yellow jaundice is jaundice is clear. How do we know what is the cause? It is pre-hepatic, intrahepatic, or post-hepatic?
okay, sir. Okay,
Can we
sir.
know
There
by
will be
history?
scratching. Sir, patient will present with scratching all over the body due to deposition of bile salts. And there are types of
So you said no, patient has clay-colored stools.
yes, sir, due to obstructive
Most
pathology.
likely, there is a possibility, and we have ruled out hepatic causes like on history at least.
Yes,
What
sir.
like
Excessive
infection,
hemolysis.
infection, and those things, and pre-hepatic. You have specifically asked for hemolytic reaction,
Yes,
blood
sir.
transfusion related. So those are the basically you're trying to find out what is the possible cause of jaundice, and jaundice is something which is quite common and maybe coexisting,
Yes, sir.
not only from the exam point of view, but clinically in the perioperative period. So you must, all of us, know about what is the possible DDs and how do we come to a diagnosis. So before we proceed further, what are the functions of liver?
Liver play multiple function in carbohydrate metabolism, in protein metabolism, in fat metabolisms. It also play important in bilirubin and heme metabolism. It plays important role in drug metabolism. It also plays important role in clotting factor synthesis of clotting factors. And except 3, 4, and 8, it plays important role in synthesis of albumin, globulin also. And
So very well knowing there are so many functions. So do you think it is important to know all the functions as anesthesiologist?
yes, sir, it plays important role while our anesthetic management and patient while.
Okay, so we'll come to it later. So we can go ahead. We can go ahead. We can go
Okay,
to
sir.
the.
So personal history, patient is occasionally alcoholic, on mixed diet, regular bladder and bowel habit, normal sleep pattern. Treatment history, he is on tab Udiliv ursocholic acid, 150 mg BD since 2 months.
So patient was aware of the name of tablet, or did you see?
No, sir. No, sir. I checked on no, patient wasn't aware, sir. I think.
So if patient is not aware, usually okay. So it prefer not to say specific drugs in the exam.
Yes, sir.
Because it history-wise, mostly the patients we see do not know, and sometimes it gives a wrong impression that we know the patient before taking the history. So then
Yes,
it
sir.
is not okay. Please go ahead.
Sir, on general physical examination, patient was examined in the lying down position.
Before examination, we go on history. What do you think is the most likely diagnosis?
Sir, most likely malignancy, due to obstructive pathology.
Why do we say malignancy?
Sir, because there is significant weight loss of 7 kgs in last 3 months, so it can.
So 7 means what was the baseline weight of? So suppose the patient had 100 kgs weight. 7 kg is significant.
So more than loss of more than 10% weight loss in last 6 months or 5% in last 3 months.
So weight loss is more than 10%. What else?
And so loss of appetite, anorexia is there history of in my history.
They are pretty non-specific symptoms. No, if patient has some hepatic lesion, non-malignant as well. So any liver disease will lead to a loss of appetite, which may lead to a weight loss. So they may not be specific to malignancy. Anything which is very glaring and specific to malignancy?
The clay colored.
Both obstruct. So that suggests extrahepatic obstruction or something which is leading to. So that may suggest that there is some obstruction down below the liver, whatever the cause, and malignancy can be one of the DDs, but it is
Yes,
not
sir.
the only DD. So what are the other possible differential diagnoses?
So there is, sir, gallstones,
So there can be an obstruction of the biliary tree because of the gallstone.
biliary stricture, sir,
Biliary stricture, yes.
cholangitis, and sir, cholelithiasis, choledocholithiasis.
So does the picture look like cholangitis?
No, sir, there is no history of prodromal functions. There is no fever and
There
like
fever in and
all
there's no
that.
specific symptoms, so that is probably out. So mostly it may be a malignancy or maybe a stricture or some benign pathology of the biliary tree because of the or any reason which is leading to we can say obstructive jaundice or post-hepatic jaundice or whatever. So that is for sure patient has some jaundice which is
Yes, sir.
post-hepatic.
Yes, sir.
Because there is you said clear stools, there's jaundice and there's no pre-hepatic and intrahepatic as per history. So that will be the DDs. So we can go to examination.
But on general physical examination, patient was examined in the lying down position. Patient was conscious, cooperative, and oriented to time, place, and person. Weight of the patient was 50 kgs, height 160 centimeter, BMI was 19.3 kilogram per meter square. Vitals heart rate was 84 beats per minute in taken in right radial artery, regular rhythm, normal character, all peripheral pulses palpable, no radial or no radiofemoral delay. PP was 110 by 66 mm of Hg measured in left arm in the sitting position. Respiratory rate 16 per minute, regular abdominal thoracic type. Patient was afebrile, icterus present in sclera.
So
No.
what is the significance of abdominal thoracic respiration in this patient?
Sir, it's a normal respiratory pattern. And in female, there is thoracoabdomen.
देखो exam में ना what problem usually occurs is, so whatever we say, examiner will have a next question which is something clearly not very significant or odd. You will have a next question on that. So if you say something, I'm not saying it is right or wrong. What I'm trying to say is whatever we suggest, whatever we tell in exam, so we should be really sure what is the significance. But as any copy paste, we just have standard format and we just write it, and we do not know the meaning, then it may lead to a big trouble. So it is good to have that checklist, but you must know what is the meaning of the check, whatever you say. Okay, so so icterus was present. So what? Suppose I say it was not jaundice. What are the other possibilities? So yellowish discoloration of sclera. What are the other possibilities? हो सकता है कुछ नहीं, चलो छोड़ देते हैं. Okay, so where do we see, how do we examine jaundice?
So we examine for jaundice, we look in sclera, and then mucous membrane, under surface of the tongue, palm, sole, we'll check for.
So we see on the lower part of the sclera or the upper part, what do we ask the patient and how do
The
we
palpable.
see it actually?
So lower part of the sclera.
Okay. And have you seen patients with, what are the other parts where do we can see icterus in addition to sclera?
The mucous membrane, under surface of the tongue, palms, and sole, we can check there, sir.
So when does it occur? So sclera occurring, icterus in sclera, what is the cutoff and what is the cutoff when it starts appearing on the palms and then the surface of the tongue?
Sir, in sclera, when serum bilirubin is more than 3 milligram per deciliter.
Then?
And so due to increased elastin sensitivity in sclera, we'll see.
Okay, chalo. So we can go to the okay. So you say no stigmata to suggestive chronic liver disease. So
Yes,
you
sir.
must know what are the signs of liver failure or chronic liver disease, and you
Sir,
must.
Yes, sir. We'll look for spider nevi, caput medusae, xanthelasma, icterus, ascites, gynecomastia, esophageal varices, and palmar erythema. We'll look for
So
all.
we may argue that so they are basically signs of liver failure, not obstructive jaundice.
Yes, sir.
In late stages of obstructive jaundice, you may actually have liver failure as well. So they do not occur early, So bilirubin can be really high before these symptoms and the signs starts appearing.
Yes, sir.
But you must be aware and that these are the possibility. Okay. What next? आगे चलते हैं.
So on airway examination, there is no obvious facial deformity, no loose teeth, absent or artificial denture. Mouth opening was 4 centimeter. Restriction neck movements was normal. Thyromental distance 7 centimeter. Modified Malampati class 2 and upper lip bite test class 1.
What is upper lip bite test?
Sir, upper lip bite test is sir. There are it's of three classes: class 1, class 2, class 3. In class 1, we have the lower lip is like up lower middle. Up, patient is able to touch the upper vermilion border. Then in class 2, patient is able to touch lower vermilion border, and in class 3, patient is not able to touch the vermilion border.
So see, examiner, this is a common fault we do. So we know everything about obstructive jaundice, but patient as a whole sometimes. So I specifically asked for one, so examiner can't ask anything. So since you are practicing an exam case, so we should be aware, and something like airway examination, cardiovascular and respiratory system examination are important. So you should actually do it in patients, especially in the exam, so that because examiner knows the important findings definitely.
Yes, sir.
So if you falter on that, that doesn't give a good impression. Okay. Okay. Next.
Yes, sir. So on systemic examination, on abdomen examination, patient lying supine with arm to the side. On inspection, contour of the abdomen scaphoid, flat abdomen with umbilicus inverted and centrally placed, all quadrants moving equally and freely with respiration. Yellowish discoloration of the skin and scratch mark noted. No visible swelling, pulsation or peristaltic wave. No scar or venous engorgement. No previous surgical scar. Hernial sites, hernial orifice and external genitalia are normal.
Okay. So do you expect the hernial sites to be affected in a jaundice patient?
No, sir.
If I say yes, what is the possibility? When it will occur, if at all? Suppose patient has massive ascites.
Yes, sir.
The intra-abdominal pressure is increased, and patient has a borderline genitalia, hernial orifice is already, he has some history. So any increase in intra-abdominal pressure may actually lead to precipitation of. So importance is there, no? So whatever history we ask, there is an importance, but you will have to connect to your present case. Okay, next.
On superficial palpation, abdomen feels soft, no local rise in temperature, tenderness, guarding or rigidity. On deep palpation, lower border of liver is palpable. 2 finger breadths below the right costal margin, soft, non-tender with smooth surface and sharp margin. A 7.5 centimeter firm, non-tender, smooth surface lump in the right upper abdomen, moving with respiration and side to side. Its medial and lateral anterior margin are well defined. No other palpable mass, organomegaly, or no palpable lymph node.
So this is normal or abnormal, this palpation, on palpation findings?
So this is an abnormal finding in my case. Sir, in obstructive jaundice with palpable gallbladder is mainly due to malignancy, not due to gallstone.
इसमें कहाँ लिखा है गॉल ब्लैडर palpable है या हमने उसकी रिपोर्ट देखी हुई है?
Yes, sir. It's
How do we know gallbladder is palpable? It will be difficult, especially in malignancy, no? Be a mass. It will be really difficult to specifically say it is a gallbladder. It may or may not be possible.
Yes,
so
sir.
On history and examination, it is better you refrain from specifically. You focus on broad picture rather than very specifics.
Yes, sir.
So you say lower border of liver is just palpable, 2 finger breadth below the costal margin.
Yes, sir.
What is the normal span of the liver in a patient? Lower margin?
So 10 to 15.
So
10 to 15
read about it. So why I'm trying to ask you these questions is these become important. So findings definitely we are able to.
Sir, it was 10 to 15 centimeter, which I remember.
That is the total span, no? But what about, are we able to palpate lower border of liver usually?
No, sir.
Okay. So, okay. What other organomegaly becomes important in this patient, which and may be present?
Sir, hepatomegaly, splenomegaly.
Splenomegaly, do you think splenomegaly is common with hepatomegaly in
No,
patients?
sir, it is not common. It is to rule out, sir, hemolytic anemia. It is mostly
So anemic anemia, so spleen enlargement will occur in anemia, and what else? In which condition where liver is involved and spleen may also be involved? Though liver may not be enlarged, so liver may mostly shrunken in those cases. Chalo, okay, next. So there is a big list of hepatosplenomegaly. So when we used to read in undergraduate days, so these are common questions. So we can't forget what we read in our MBBS days. I'm not saying these are this everybody will be being asked for, but these are the things you may be asked in between, depending on how the Viva is going.
Yes, sir.
Okay. We can go to the next.
Yes, sir.
छोड़ देते हैं. इसको छोड़ देते हैं. Leave it. Next.
Sir, cardiovascular examination.
Next. This is normal, no? So no.
Yes,
no.
sir, within normal range.
This is also normal. Okay. With CNS examination, you can. So you in the exam also, no, you may not be. You have to do everything, but it depends. It may be only relevant to the case, or maybe one or two specific examination which may be relevant or which may be affected in a particular case. So coming to CNS, yes.
So CNS examination, patient is conscious, well oriented to time, place, and person. No signs of confusion, lethargy, tremor, or hysteresis. Cranial nerves and motor examinations are normal. Superficial deep tendon reflexes are intact, and plantar reflex are flexor. Sir,
Normally plantar reflex extensor होते हैं, flexor होते हैं.
The flexor.
So this is normal.
Yes, sir.
So when it will be extensor? So okay. What is the summary?
Summary: a 54-year-old male patient with no comorbidities presented with history of painless progressive jaundice associated with yellowish discoloration, clay-colored stool, dark-colored urine, pruritus, loss of appetite, and with no signs of hepatic failure.
See, the patient's age is 54. So what is the differential diagnosis with this? 1, 2, 3. So give me 3 differentials which are possible in the order of likelihood.
Sir, there will be cholelithiasis, sir. Periampullary carcinoma, cholangiocarcinoma, sir.
So one is malignancy. Secondly, so you're saying cholelithiasis. Cholelithiasis may not be the right term. Maybe a CBD stone. CBD stone will lead to this picture.
Sir, choledocholithiasis.
Because if the stone migrates from the gallbladder to the biliary tract, then it may lead to this. But still, loss of appetite, maybe their weight loss will be little late to occur.
The biliary structures is also one of.
So stricture usually present in what age group?
Sir, early age.
So if for his age, it may not be a common diagnosis, common DD, but you will keep it down the line unless you have specific investigation. Okay, so the DDs will become malignancy, so which may be because of the biliary tract malignancy or pancreatic head, or depending on that area, any malignancy which is obstructing the biliary tract. So we know the organs, so we can put the names to them. Second will be CBD stone.
Yes, sir.
And third will be biliary atresia. Anything else?
Sir, primary sclerosing cholangitis can also be.
Maybe. So actually, any case you have to come to 2 or 3. So never jump to a single case. I know all of us know the case what we are allotted mostly, but it doesn't mean we jump to the case, because this means if you tell, okay, this is the case, then this means you have not taken a proper history. So on history, it is really difficult to come to a single diagnosis.
Yes, sir.
It is always a bunch of diagnoses in the order of likelihood. Okay. So we go to the next slide.
Sir, 54-year-old male patient.
Next, this we have discussed. Diagnosis. Okay. So now, these are the investigations you have written. So you must have seen the file. So why do we need a hemogram in this patient? So what is what is the possible? So we say it is a CA head of pancreas posted for Whipple's procedure. Okay.
Yes.
So what are this patient has come to you with this history? That is a normal scenario. No, in PSC clinic we don't take history. Otherwise we do a specific history depending on the case we get from the pre-anesthesia point of view.
Yes, sir.
What are the investigations you will order or you will suggest this patient and why?
Sir, I would like to do complete complete blood count in this hemoglobin to rule out anemia, then total leukocyte count to rule out any active infection, and platelet count for any baseline because it's a major surgery or for coagulopathy. Then liver function test, then kidney function test will go, serum creatinine, serum urea to rule out acute kidney injury. And then we'll go for pre-PT-INR to know the coagulation profile of the patient. Then chest X-ray to rule out metastasis or pleural effusion. 12-lead ECG to rule out arrhythmias because they are more prone for arrhythmias due to hyperbilirubinemia. And 2D echo will like for clot and any left ventricle.
So what is the most common arrhythmia in these patients, especially obstructive jaundice?
Ventricular arrhythmia.
It is bradyarrhythmia or tachyarrhythmia? What is more
Bradyarrhythmias. Bradyarrhythmias more common.
Why it is more common? Why not tachyarrhythmias?
Because like due to bile stones get deposited at SA node, that will result in bradycardia.
So
and due to decrease response to inotropic and vasopressor response also negative.
Okay. So any other test which is not there in the list which you will definitely
Yes,
do?
sir. Yes, sir. Here we'll go for we'll go for 2D echo also.
I'm talking about biochemical test. Any other biochemical test? Okay, you have written no. What is the importance of RBS?
So these patients are because they are on glycogen stores are decreased in these patients. They are more prone for hypoglycemia. So due to
So what is the duration up to which the glycogen store maybe
48 to 72 hours
maximum? Okay.
maximum.
I think it is 24 to 48. 40, 72 थोड़ा ज़्यादा है. And what about so what is the biochemical test which is earliest to get deranged in a liver failure? I'm not talking about obstructive jaundice. I'm talking about liver failure. So if liver function is deranged,
yes,
liver function is getting affected directly. So what is the first biochemical test to get deranged? So if I ask other way, so what is the half-life of common things and which has the
The
shortest?
half-life of albumin is like 14 to 21 days, and
half-life तो 14 to 21 नहीं होगा. 21 days में तो वो चलो okay. What about PTINR or the coagulation test?
Sir, factor 7 is most commonly earliest affected because it has a short half-life of 6 hours. Factor 7.
So usually, so whatever we may say, so for anything to change, 5 T half should be there for the effect to occur. So if it is 6 to 8 hours, so 5 will be about 40. So usually within 24 to 48 hours, the PT start deranging. And similarly, albumin takes about a week or so, week to 2 weeks to getting affected. So basically, you must be aware, and that is the reason why we are getting this test. From the biochemical liver function test, so AST, ALT, ALP, can you make a diagnosis?
So yes, if AST and if aspartate transferase or alanine transferase are raised, so they are suggestive of mostly hepatocellular injury will be there in patient. Or if ALP is raised, is due to alkaline phosphatase is suggestive of cholestasis.
Okay, so basically,
it is mostly 4 to 5 times is raised suggestive cholestasis.
Any other specific test for obstructive jaundice which we may
Yes, sir. There are like gamma glutathione transferase and 5 nucleotide days. These also are suggestive of cholestasis.
Okay. Okay. So now coming to the coagulation profile, you said PT and INR is 1.4. So, and most likely it is an obstructive jaundice as per history and examination and clinical test. It looks like that because direct bilirubin is more raised and the total bilirubin is also high. So what do you think will be the effect on the coagulation profile because of liver function?
Sir, because in this coagulation profile is deranged because factor vitamin K because in this liver plays an important role in synthesis of the fat soluble vitamin. So in due to defective function of the liver, there is deranged fat soluble vitamin which are A, D, and K and E. So due to defective of the vitamin A, it is the patient present with night blindness. Vitamin D, the patient present with bone pain. And due to vitamin E, patient present cognitive dysfunction, and due to vitamin K, the patient usually presents with coagulopathy, early chymosis, and easy bruisability.
So it is important to know the pathophysiology so you can give simple drugs to improve upon the patient condition.
Yes, sir.
So just a small question. So what is the test name for testing bilirubin? No, we used to do in MBBS days. What does it being called? Bilirubin testing. What is the mechanism and what is the test called?
Sir, urine.
नहीं यूरिन नहीं जो डायरेक्ट हाँ बिलिरुबिन टेस्ट करते हैं ना तो उसका एक स्पेसिफिक साइंटिस्ट का नाम है जिसके नाम पे ये टेस्ट करते हैं वो रिएक्शन है क्या चलो कोई बात नहीं नेक्स्ट स्लाइड आगे चलते हैं विल गो टू द नेक्स्ट ओके सो इन एडिशन टू बायोकेमिकल टेस्ट you may need to do some other investigations. So as an anesthesiologist, what are the other tests you like to do?
Sir, I would like for CT scan also for to know the obstructive, to make the diagnosis of obstructive pathology.
How does it affect your anesthetic management?
Sir, there will be increased risk of post-op nausea, vomiting.
Suppose patient ka CT,
Ascites.
suppose patient doesn't have a CT scan. So will you still order it in the PSC?
No, sir. We can go for ultrasound abdomen to in case of their patient have ascites because there is an increase intra-abdominal pressure that will.
Okay. Okay. Next. Usually we do not. Usually this patient come up with CT scan and other investigations. It is a good idea to see them in the pre-op period to know the extent of the disease and come to a plan for anesthetic management. So see what is the size of the growth, where the growth is actually abutting, and is the gastric, is the stomach dilated? So you know whether it is you take it as a full stomach or not. So those kind of assumptions you can make by visualizing the CT scan. So it is always a good idea to see the extent of disease and the possible implications it may have on anesthesia practice. Okay, come to the next slide.
This slide.
Okay. Okay, khatam.
Yes, sir.
Okay. So now this patient has, as we said, it is in the PSC. So bilirubin was 13, I think. Kitna tha isme?
9.2, sir.
9. Chalo, we take it as 15. So bilirubin was direct, total was 15 with direct as around 13.5 with albumin of 2.7. And this has come to you. And rest of the investigations are what are shown on the figure. So this patient is posted for Whipples in next week. So surgeon has given me 1 week, and he is wanting that since it's a major surgery. So anything you want to do or optimize. So what you will do?
For optimization, first we'll go for nutritional optimization of the patient. So to treat anemia because like HB is also less in my patient 9.6 grams. So we can give iron supplement to these patients.
So which iron you want to give?
Sir, iron sulfate.
Oral, IV, intramuscular, subcutaneous.
Oral supplementation is in.
So what is the rise of hemoglobin with oral iron? What is the rate of rise? So ऐसे एग्जाम में ना बिल्कुल ऐसे फंसते हैं ना.
0.821.
1 gram per week. And what is the problem with iron? What are the side effects?
The nausea, it increases nausea, vomiting, and there is gastritis also.
GI intolerance will be there. And in a patient who is already having poor appetite, it may not be a good idea to start iron in the especially the oral iron. So had this hemoglobin with 7 or 6.
So we'll go for transfusion. So we'll go for transfusion.
I would have given. Rather, it depends what is the cause. So we'll have to work out for anemia also. So hemoglobin 6 with bilirubin increased with jaundice, it might be a pre-hemolytic jaundice. So transfusion may not be a good idea. So then it becomes, or it may be a nutritional anemia. It may be because of some other reason. So we need to further investigate. At 9.6, I'm not so worried because it is a major surgery. I will arrange adequate blood, but I will definitely not give iron oral definitely not to this patient. But if it was say 8.5 and I had some time, maybe a total intravenous dose iron could have been given. And nowadays, especially in malignancy, to avoid intraoperative transfusion, it is a good idea to improve hemoglobin. If it is a iron deficiency, iron will work. So that
Yes.
we have to find out if it is iron deficiency, then only total intravenous iron may be a good idea. But for oral in the short-term therapy pre-op period, probably not. If patient was early stage and planned for chemo and maybe patient has about 4, 8, 12 weeks, then maybe it is a good idea. Okay, so what else?
Sir, we can give this patient with a high protein, high carbohydrate, and low fat diet.
So that is written in the book, but what you will give? So as a patient, what you will advise to the patient?
So increase protein intake, like sir.
So how do the patient increase the protein intake? And does the protein intake directly translate to rise in albumin?
No, sir.
I suppose I give IV albumin to this patient, it is 2.8. I can always transfuse, say, 1 unit for a week. So what 7-8 units I transfuse. Do I expect it to increase to 3.5 or maybe 4?
No, sir.
No. So we have to give protein, nutritional supplement of protein. You have to calculate as per weight. So 1 to 1.5.
1.2 to 1.5 gram per
kg, and
milligram per
try to
kg.
find out what is, either send him to our dietitian or try to pre-calculate with locally available resources which patient is having in his diet, and that. But it takes its own time, so it is not a shortcut. So typically it will take about 2 weeks, 3 weeks, 4 weeks, depending on how patient is able to have it, because whatever we may say, protein is not easy to. If low appetite patient, if you give protein, they will not have it. So it has a distinct taste, especially the pre-mixed formulas. So they are usually, compliance is really poor. Okay, what else? So we'll try to build up nutrition if possible. Okay, we talked about anemia. If it is less, we can give total intravenous. Infusion, I'll avoid blood transfusion unless it is very low. And if it is low in a jaundice patient, I will have to be worried about other causes. So further investigation needs to be done. This is very clear?
Yes, sir.
Okay, so what else?
Sir, we'll correct if there is any.
What about?
Yes.
So we are talking about this patient. So coagulopathy is not there, no? It is
Yes, sir.
1.4. PT is 14. So do you still want vitamin K obstruction and some vitamin K malabsorption as well? So should we give? INR is okay.
Sir, 10 vitamin K, 10 mg OD for 3 days prior to the surgery.
Okay, what else? So this is done. So so patient's bilirubin is also high. No, we said it is 15. Do we need to do something for the patient? Do we need to tell him something so that he's better prepared for surgery?
Sir, we'll send for gastro.
Bilirubin, I'm talking about.
Yes, sir. We can send gastro reference also to the patient, sir. And if bilirubin is raised to more than 15 for ERCP.
So what is the cutoff for getting a ERCP? So I say pre-operative stenting, pre-surgery stenting. What is the cutoff for jaundice? Do we have any cutoff?
The 250 micromole per liter, I remember, sir. It's like. I think.
Okay, you must be aware of the cutoff. So in addition to stenting, what else we need to do? What we need to tell the patient?
Sir, please repeat question, sir.
Stenting चलो हमने करा लिया.
Yes,
So
sir.
in addition to stenting, what else we need to tell the patient? In the pre-op period, any advice you will give as anesthesiologist to improve the overall patient condition in the pre-op and the post-op period? And one specific instruction we write, especially if a high jaundice, high bilirubin content is there. So we have seen urea creatinine levels. Mannitol, there's a debate now. Earlier, so when I was a postgraduate, then it was a standard practice. So why are we giving mannitol? By the way, what is the reason for giving mannitol?
The reason of giving mannitol to flush the bilirubin out of the kidney to prevent from kidney injury.
Okay, so basically they don't want dehydration. So that is the key. So if patient is dehydrated, the bilirubin crystals might precipitate and may lead to a kidney damage.
Kidney damage.
So at that time, people used to suggest dopamine and mannitol. But what is the current practice now? What is the recent evidence? Maybe last 5-7 years. So what is the current practice? Is mannitol a standard practice or something
So no,
else?
it's absolute now, sir. So it's not
So
routine
what is
practice.
preferred nowadays? So in any case, you need to do something, no, to prevent crystallization of bile salts. So what is preferred now? So what do they suggest is maintain a good intake output, give fluid in the preoperative.
Adequate hydration in pre-op period.
So you know it. So but you have to tell in the exam also, no?
So adequate hydration in pre-op
What do you
period.
mean by adequate hydration?
Sir, maintain urine output of more than 1 ml per kg.
So some say 0.5, some say 1, so whatever depending on the condition. But so basically you have to monitor the intake and output.
Yes, sir.
And one thing more, say as this patient has liver dysfunction, and though it is obstructive, but late stages I told you, hepatic function may also be deranged. So liver function gets affected. So you have to monitor the blood glucose frequently in these patients, and you may need to supplement. So some fluid may be dextrose as well.
Yes, sir.
So it may usually we give balanced salt.
Balanced salt solution, sir.
That is a standard practice, but you have to monitor glucose, and you may need to give in dextrose if required. So
Yes.
the important thing is to monitor the glucose levels at a regular interval. Okay, come to the next slide. Okay, ये तो हो गया. So we have investigated. Now patient is posted for surgery. So now you are past the exam and you are the senior resident, and we have one consultant and 2 junior residents. So somehow the consultant is busy, so he's managing 2 theaters. So he asks you to manage this case. So you have to plan anesthesia with your residents. So what you will do?
So my plan of anesthesia for this patient is general anesthesia with endotracheal tube with controlled mechanical ventilation with thoracic epidural.
So before that, in the pre-op orders, what you will write? So in the one day before, so the senior consultant tells you that he is busy in another OT with a difficult airway case. So you please manage, and any problem, let us know. So what are the orders you will put in?
Yes, sir. In pre-op order, sir, first I'll introduce myself to the patient, and then I'll explain the procedure to the patient. Then nil per oral for 2 hours for clear liquid, so 6 hours for solid fluids. Then written informed
As
consent.
per ERA's guideline, everybody is now talking about oral dextrose, clear dextrose solution to up. So what is your take on it specifically in this patient?
Sir, for this patient, we give a carbo load. We give that is maltodextran 12.5%. In each sachet, there is 50 gram. So we'll give 2 sachet in 800 ml of water in the morning of the surgery so that there is this help in maintaining the blood sugar level by decreasing the insulin resistance and by decreasing thrust of the patient, hunger of the patient, and by decreasing it also help in decreasing the gastric volume and pH of the patient, sir.
What is so special about maltodextrin? Why not do glucose? No, standard glucose is available. We can always give it. What is so special about it that everybody is talking about?
It does not lead to rapid rise and fall of the sugar level, sir.
I can still take it. No, I'm not worried about that. No, in any case, sugar rise will occur with both. What is more important? It is one of the reasons, but what is more important? In the pre-induction, I'll say period, say within 2 hours, what is the most concerning thing to me as an anesthesiologist? If anything patient is taking, what is most concerning to me?
The risk of so during induction, risk of aspiration if patient is not adequately, sir.
Yes, you are right. Tell me. Anything which has is not appreciated. So maltodextrin it is a faster cleanse from the stomach as compared to glucose. So that is one of the reasons that we prefer maltodextrin based fluid. One thing more. So I have a counter to it. I'll say it is an obstructive jaundice, CA, CBD, say head of pancreas, my duodenum is blocked. So there will be gastric stresses. In any case, I'm doing a rapid sequence induction. So
Yes,
I'll not like to give maltodextrin to this patient. So what do you say? Or I may need to modify the technique after giving maltodextrin. I need to do something else before I take the patient for induction. So there are 2 possibilities. Either we don't give or we give, but we do something else also before we induce the patient.
Sir, will dextrose to the patient we can give, sir, in free.
Yeah, I'm talking about oral maltodextrin. So I'm saying I should not. So there are two consultants. So one of your residents, no, we have a discussion. So you are a consultant now. There are two more residents. One says, "Madam, there is an obstruction. So why we are giving? Because it may lead to increased risk of respiration. Increased risk of respiration as already it is prolonged.
Yes, sir.
We know it is there is an obstruction and the gastric emptying may be prolonged. So other person says no, we can give it. The clearance fast, but then you call for help. The senior consultant comes in. He says we can give, but we need to do one thing more before I start induction of anesthesia. So what do you want to do? Can you visualize gastric content?
Rapid sequence. Sir, we can check for gastric
Rapid.
resistance.
Yes. So nowadays you can always say that I will. So if there's a problem or there's a confusion, I'll still give maltodextrin because of the benefits, but I can do a gastric ultrasound to see the gastric content,
Residual volume.
and then I can proceed. So you are safe. So it is absolutely visualized and you can go through it. Okay. So now, what about preoperative anxiety drugs?
Sir,
Will you give?
for preoperative anxiety, I'll give tab alprazolam 0.25.
You want to give? You don't want to give? First question is this.
Sir, sir, we will not prefer to give in these patients because they have decreased protein binding. Benzodiazepine has decreased protein binding, so I don't prefer to give.
So, yes, no, maybe.
Yes, sir, we can give it depend on the patient.
Can to na bada, so when so I always say this example to everybody. So our gynecology consultant was there, I'll not tell the name. So in the class now we were happy to say can, and she would say you can go to the moon, but do you? So the answer was no. So can is not a word. I will and I would is a better word because we are talking about a patient. So generally patients are different. So okay, so in which condition you will give, in which condition which will not give?
Sir, if patient is more anxious for the surgery, like a hyperactive, we'll prefer to give these patients to come.
Okay, chalo, we'll leave it. So we'll optimize, we'll customize as per the need. Usually we avoid pre-medication in these patients because they're tricky and patients have a liver function which is deranged, and sometimes you are not sure how much effect will be there. Okay. So now this patient, you have made him fit, so-called. Patient has been posted for surgery. Before we proceed, how much time we have left, so we can just customize as per the available time. Organizer में कौन है इधर अभी देखते हैं. Anupama, how much time do we have?
Have 5 minutes for the discussion. It's 5 minutes.
5. चलो ठीक है. So just we'll do it fast. So okay, what about intraoperative drugs? So what is the plan for anesthesia?
Sir, my plan of anesthesia is general anesthesia with endotracheal tube, with controlled mechanical ventilation, with thoracic epidural for post-op analgesia.
What drugs you want to give for anesthesia induction, maintenance, and
Sir, we'll pre-oxygenate the patient with 100% oxygen for 3 minutes. Then followed by we'll give injection midazolam 1 mg per 1 mg. Then fentanyl at 1 to 2 mics per kg. Followed by giving propofol in titrated dose till there is loss of verbal response. Then we'll check for bag and mask on ventilation. After that, we'll give atracurium 0.5 mg per kg. Then we followed by putting cuffed endotracheal tube to secure the airway. After confirming the 5 points of auscultation, we'll put the patient. And we'll see the on capnography. Also, we'll confirm. Then we'll put the patient on ventilator, sir. And we'll open the inhalational agent as well.
okay. So since the time is limited, we'll not go into details of anesthesia management. But just to summarize, we must know about alcoholism if the patient is having alcohol. Though this patient didn't have history, but if somebody has, you must know about what are the problems with alcohol intoxication. When do we stop it? What are the problems with acute withdrawal and those things? Then you must be aware. So either it can be, you may get an obstructive jaundice, you may get a cirrhotic patient depending on the availability. So both are as important. Broadly, the history will remain the same, but management is slightly different from anesthesia point of view. So you must be aware. Then you must know about the postoperative plan and what is the target for when do we extubate, how do we give analgesia. Suppose patient had deranged PT, so do you still give epidural or not? Or what are the other options of analgesia, multimodal in this patient? So nowadays we could give truncal blocks and those things in addition to IV or PCA, so that we are giving something in addition so that analgesia is good. Then do we give an NSAIDs in these patients or not? Those things you have to be aware of. Then you must be aware about general management, the post-operative care. What about ERA? So ERA is a standard question you may get in theory, or you can fit in any possible case. So you must know about the components, what is the importance. So something like in the pre-op, important will be regarding bowel preparation. Intra-op, we have discussed mostly good anesthesia, good analgesia, prevention of hypothermia, anemia, and those things. So all the components are as important. Whatever is feasible in the patient, in the setup, should be thought of and discussed. Then you might have a case on portal hypertension. I'm not sure whether they have kept it separately, but as a liver case, you have to be aware of the shunting procedure if they place it, so that should be done. And post-operative mobilization and post-operative nutrition is important, so that should also be known to all of us. So there is a possibility of say there's a big ripples, the big mass in the CBD, so with involvement of liver. So patient might have liver wedge dissection as well, which is common, and so you need to know about hepatectomy. What is the functional remnant of liver? How do we calculate? How much is allowed? What about CVP? Do we keep it 0, 5, 10, whatever? So those things you must be aware, and you should be well versed with. So I think that's end of the discussion part of it. We have our senior resident to summarize the case for all of us and the important points.
Good afternoon, everyone. I'll be summarizing the topic obstructive jaundice posted for Whipples. Now, liver being the largest organ in the body, it conducts various biochemical as well as metabolic functions. It receives approximately 25% of the total cardiac output, out of which it has dual blood supply, that is 75% is via portal vein and 25% is via hepatic artery, which is exceptional. However, oxygen delivery is 50% via portal vein because of its deoxygenated state and 50% via hepatic artery due to its high oxygen content. The basic functions of liver include secretions of bile, metabolism of liver, hematological functions, metabolism of carbohydrates, fats, proteins, helps in detoxification of toxins, hormones, drugs, storage of vitamins and minerals such as iron, copper, vitamin A, D, E, K, B12, and helps in reservoir of glycogen as well. It has endocrine functions such as activation of vitamin D and conversion of thyroxine into its active form, that is T3. Secretions of angiotensinogen and metabolism of various hormones. It has protective functions, filters portal blood from bacteria, and important in antigenic presentation, phagocytosis via Kupffer cells, and removes hemolytic products. Helps in inactivation of toxins via phase 1 and phase 2 reactions. Phase 1 reactions include oxidation, reduction, hydrolysis. Phase 2 reactions include conjugation, sulfonation, cytochrome P450. Definition of jaundice includes yellowish discoloration of skin's sclera mucous membrane, which is detectable when plasma bilirubin level exceeds more than 2 mg per deciliter. It can be due to excess production of bilirubin or due to decreased uptake of bilirubin into the hepatocytes, or disturbed intracellular protein binding, or disturbed secretions of conjugated bilirubin into the biliary canaliculi, and as well as intrahepatic as well as extrahepatic bile obstruction.
The causes of obstructive jaundice have been divided into prehepatic, hepatic, and posthepatic. From our history, we can elicit the history of icterus, high-colored urine, clay-colored stools, bulky stools, presence of pruritus, presence of significant weight loss, loss of appetite. In examinations, there is presence of multiple scratch marks and palpable lump in abdomen. The common causes of extrahepatic is most common is duct stones, that is choledocholithiasis, in carcinomas of bile ducts, head of pancreas, and ampulla of Vater, biliary strictures, sclerosing cholangitis, pancreatic pseudocyst, ascariasis, or postoperative biliary strictures. Now, changes that are observed is due to the obstruction, urobilinogen pigment is absent in the intestine. Therefore, it presents as clay-colored stools. And the bile backflows to the blood due to the obstruction, which may lead to bacterial translocation, which may present as sepsis. There occur malnutrition due to poor intestinal absorption of fat-soluble vitamins. Fat malabsorption presents as steatorrhea. And due to malabsorption of fat-soluble vitamins, there occur deficiency of vitamin K, A, D, E, K. The deficiency of vitamin K presence is required for synthesis of various clotting factors such as factors 2, 7, 9, 10, which in turn presents as increase in prothrombin time and increase the risk of bleeding. Due to deficiency of vitamin A presents as night blindness, deficiency of vitamin E presents as cognitive function disorders. Also, there is intestinal mucosal barrier dysfunction, which may result in sepsis. Therefore, antibiotic prophylactically has to be started in these patients. There's a suppression of immunity, due to which there is high risk of post-operative infections in these patients. Now, cardiac changes that have been noted are there is altered beta-adrenergic receptor signaling leading to impaired left ventricular function. Due to increase in bile salts, it exerts directly negative inotropic as well as chronotropic effects on the sinoarterial node, due to which there is significant bradycardia noted in these patients. The peripheral vascular resistance is increased and blood vessels become insensitive to endogenous as well as exogenous stress response. And also there is decrease in myocardial contractility observed in this patient. In renal function, there is high chance of acute kidney injury due to decrease in responsiveness to vasoactive agents in this case. For risk stratification, we have 3 scores, that is Child-Pugh score, MELD score, in which we assess the serum bilirubin, creatinine, INR levels. And if the score is more than 40, the chances of mortality in this case is more than 70%. If score is less than 9, mortality is less than 2%. Other factors include the presence of malignancy, hematocrit less than 30%, hypoalbuminemia, that is albumin less than 3 gram per deciliter, bilirubin more than 11 milligram per deciliter, presence of acute hepatitis or azotemia. From anesthetic considerations, it can be further divided into patient-related, anesthesia-related, and surgical-related. In patient-related, we look for nutritional status of the patient, frailty of the patient, and whether the patient has anemia. In anesthesia-related, system-wise in CVS, there is decrease in peripheral vascular resistance, as we already said. Vascular hyporeactivity occur and massive fluid shifts and blood loss is anticipated since it is a major surgery. In renal system, it is essential to maintain adequate perfusion since it is a volume depleted state. In drug metabolism, there is impaired metabolism, increased sensitivity to various hypnotic drugs. Therefore, drug doses have to be titrated in this case. In GIT, there occur bacterial translocation and there occur increase in prothrombin time. And as glycogen stores are compromised, it may present as hypoglycemia. Therefore, regular blood sugar level monitoring is very essential in this case. In surgery related, it is a major surgery, long duration, increased blood loss and fluid shifts are anticipated. There is increased risk of hypothermia. Therefore, ambient OT temperatures as well as bare hugger has to be attached to the patient and adequate post-operative analgesia needs to be maintained in this case. In pre-operative assessment, we will typically rule out the history of jaundice, dark-colored urine, pale-colored stools, presence of pruritus, fever, weight loss, anorexia, right hypochondrial pain, nausea and vomiting. For in examination, we will look for signs of hepatic failure, that is xanthelasma, icterus, Pinder nevi, caput medusae, hepatomegaly, scratch marks, ascites, palmar erythema, and gynecomastia. In investigation, we'll go for complete blood count. As Dikti already said, HB to rule out anemia, TLC to rule out infections cause. In liver function test, to assess the detoxification excretory function, serum bilirubin levels, enzymes for liver injury, hepatocellular aspartate transaminase level, alanine transaminase level, glutathione S transferase level. For cholestasis, increase in alkaline phosphatase or gamma glutarate transpeptidase and 5-nucleotide levels are seen. For synthetic functions, total protein count, serum bilirubin, albumin, as well as coagulation factors has to be seen. In kidney functions to rule out acute kidney injury, ECG to rule out bradyarrhythmias as a result of hyperbilirubinemia, 2D echo since it is a geriatric age group patient, cardiopulmonary exercise test to rule out functional status of the patient, ultrasound abdomen to rule out ascites, and chest X-ray for pleural effusion and metastasis, and CT scan if there is to rule out abdominal duodenal obstruction. Effects of drugs on liver function. There is significant impact on drug metabolism as well as pharmacokinetics. As a result of altered protein binding, there is decrease in level of serum albumin and increase in the free fraction of the content of the drugs available. So dose titration is very essential, and because if not done, it can lead to toxicity and impaired elimination may occur. Clearance of drug is however determined by hepatic blood flow, hepatic enzyme activity, and enterohepatic circulation. Inhalational agents, all volatile anesthetics, decrease the hepatic blood flow to a degree, but halothane causes maximum decrease in hepatic blood flow. Therefore, use of halothane is absolutely contraindicated when in this case. However, sevoflurane and isoflurane have a very little effect on hepatic blood flow. The sensitivity of isoflurane is relatively increased, so there is more likely chances of hypotension bradycardias during anesthetic induction in this case. Trifluoroacetic acid is produced as an end product of metabolism, which is very hepatotoxic, and it is produced maximum when used using inhalational agents such as halothane, which is around 20%. However, it is least when using desflurane, which is around 0.02%. Therefore, desflurane can be safely used as an inhalation agent of choice when patient is posted for Whipples. And halothane can also be associated with halothane hepatitis. However, sevoflurane does not undergo metabolism to trifluoroacetic acid, unlike isoflurane and desflurane. When taking into account IV agents, they don't affect the liver function as long as cardiac output and mean arterial pressure is maintained in the normal range. Propofol may reduce hepatic blood flow, but no change in single dose pharmacokinetics occur, but prolonged infusions of propofol have to be avoided in this case. Thiopental clearance is not altered, no dose adjustment is required. Etomidate, it has large hepatic extraction ratio. Elimination half-life is prolonged due to increase in volume of increased volume of distribution, and ketamine has diminished clearance. In muscle relaxants, the choice of muscle relaxants is cisatracurium followed by atracurium. Because cisatracurium, although cisatracurium and atracurium both are muscle relaxants that are undergo Hoffman degradation and not dependent on liver for its elimination, but cisatracurium causes less of laudanosine production, which is which has epileptogenic potential, and also causes relatively less release of histamine, which can cause anaphylaxis. And succinylcholine also gets metabolized by pseudocholine esterase. So in advanced liver disease, pseudocholine esterase formation may be compromised, and it may in turn lead to prolonged duration of action. And succinylcholine also can lead to bradycardia, ventricular arrhythmias. However, it is not rotated with a single dose, but with intermittent dose, it can lead to the following. However, if rocuronium, vecuronium is used, it is essential to for the patient to undergo neuromuscular monitoring, since it is primarily metabolized by liver, and it may lead to prolonged duration of action if not used. Opioids metabolism is reduced. Morphine reduced metabolism occur, and increased free form of metabolism leads to prolonged duration of elimination of morphine. However, fentanyl is also metabolized in liver. Elimination half-life is prolonged. Single dose can be safely used because it has short duration of action due to rapid redistribution. However, continuous infusions of fentanyl and morphine has to be avoided. Intermittent doses of short-acting opioids such as L-fentanyl can be used if available in institute. Sedative hypnotics, midazolam, diazepam, recovery time and elimination time both are prolonged. And in case of dexmedetomidine, elimination is reduced in patients with hepatic impairment, and therefore dose adjustment is required. For preoperative patients, if anemia is present, it has to be corrected by iron supplementation. Improve the nutritional status of the patient by giving high protein supplementation, high carbohydrate and low fat diet. In severe malnourished patient who is not able to take enteral nutrition, parenteral nutrition has to be started 5 days before the surgery. And pre-rehabilitation by formal exercise testing is important. Maintain adequate hydration via monitoring intake output of the patient, and gastroenterological opinion can also be taken for increased bilirubin level, and patient can be planned for ERCP before planning the patient for Whipples. If preoperative coagulopathy is present, it should be corrected. Since the patient is planned for elective surgery, we can go for IV vitamin K injection 10 mg OD for 3 days and repeat the PT INR of the patient. If INR is more than 1.5 on the day of surgery, we can transfuse fresh frozen plasma to the patient in a dose of 10 to 15 ml per kg For correction, if fibrinogen level is increased, we can go for cryoprecipitate transfusion. Preoperative endotoxemia can be reduced by giving antibiotics. However, it is essential to avoid the use of nephrotoxic agents such as aminoglycosides, NSAIDs, when going for choosing antibiotics. The goals of intraoperative monitoring includes minimal physiological insults to the liver and maintain adequate oxygen demand supply ratio, adequate renal perfusion, maintain normothermia, avoid hypotension, adequate fluid and blood should be replaced. Choice of anesthesia in this case will be general anesthesia combined with thoracic epidural as it provides more stable hemodynamics and requirement of general anesthesia is reduced. Epidural catheter can be used also for postoperative analgesia. Intraoperative monitoring, apart from routine monitoring, we can go for neuromuscular monitoring, RVS monitoring, ABG monitoring, and serum electrolytes can be sent. Invasive blood pressure monitoring, for which we can put a radial arterial catheter. Since it is of long duration of surgery and massive blood shifts are anticipated, we can go for goal-directed fluid therapy as a fluid therapy of choice to monitor, and for which we require stroke volume variation, pulse pressure variation parameters, CP monitoring for venous access and vasopressor administration, and we can also go for thromboelastography if possible. Now, the fluid of choice in this case will be balanced crystalloids along with goal-directed fluid therapy using pulse pressure variation, stroke volume variation as guidelines for fluid responsiveness. Fluid restriction before reconstructive phase of pancreatic or duodenectomy may decrease the risk of pancreatic leak and delayed gastric emptying. Now, it has been observed that goal-directed fluid therapy before reconstructive phase may contribute to lower post-operative rates of pancreatic leak and delayed gastric emptying has been noted. Post-operative management extubation criteria is if patient is not on inotropes, hemodynamically stable, has no adequate neuromuscular recovery is there, and stable hemodynamics is there, we can extubate the patient on table and shift the patient for ICU for further management. However, if the patient is of geriatric age group, significant blood loss is there, patient on multiple inotropes, and there is residual neuromuscular blockage, it is preferable for the patient to undergo mechanical ventilation in the postoperative period and plan for elective extubation thereafter. However, also in the postoperative period, it is essential to monitor intake output. DVT prophylaxis should be given, both pharmacological and mechanical. Antibiotics should be given to the patient. Early enteral feeding should be started. Early ambulation as it is criteria for enhanced recovery after surgery. Adequate analgesia can be maintained either through thoracic epidural or through patient-controlled multimodal analgesia, preferably opioid-sparing analgesia. And if possible, if thoracic epidural is not in situ, we can go for transverse abdominis plain block. Thank you.
Thank you. So I think Dr. Anupama has sent me one question. Let us see if you can answer.
Yes, sir.
So somebody has, I think, put a question: can we use albumin as a resuscitation fluid during hypotension during Whipples? What do you suggest?
Repeat the question, please, sir.
Can we use albumin for fluid in case of hypotension? We can use, we should not. कोई सवाल ये can तो कुछ भी कर तो कुछ भी सकते हैं. Okay, so I'll give the answer. So albumin is basically you take albumin as a colloid, not as a thing which to improve protein. So if the volume of fluid requirement is high, say patient has high volume ascites, which is leading to hypotension. High volume, I mean, say 3-4 liters has, there is a tense abdomen and the abdomen was open and 4 liter ascites is drained. Or the hypotension is refractory, you have already given to 1.5 liters of fluid. Then instead of giving large volume of fluid, you give colloid, and albumin is one of them. So you can use albumin as a fluid resuscitation in replacement to crystalloid in case of large volume of fluid resuscitation is required. But it is not a fluid of choice. So it has its own challenges and not the first fluid to be given in case of hypertension, and definitely not to improve albumin of these patients. I hope I answered the question.
Yes, sir. I think that answers the question sufficiently. We do not have any more questions, sir. And we thank you for your precious time on the weekend and also the postgraduates for such a wonderful session on the Whipple's topic. Thank you, sir.
Thank you.
Thank you, Dr. Deepthi, and thank you, Dr. Neeru, for sparing time and giving us such a good overview of the case. Now we move on to the last session of the day. Before that, Sudhir, can we have the answers to the e-lunch MCQs, if those are ready? The answer to the first question it will be the second option, using a low tidal volume strategy and consider permissive hypercapnia to reduce ventilator-induced lung injury. Second question. Again, the option is second, the stable hemodynamics with systolic blood pressure of above 100. So with this, we move on to the last lecture of the day, which is on very important topic pertaining to ICU and OT, this electrolytemia, including sodium and potassium. For this, we have our ex-professor at RML Hospital, Dr. Nagpal sir. Yes, very happy to introduce sir. And we have Sir CV.
Hello. Good evening.
Hello, sir. Good evening, sir. Sir, Professor Vijay Kumar Nagpal, sir. He is Professor of Anesthesiology at ESIC in PGIMR Hospital at Basai Darapur. Sir was former professor at RML Hospital, and he has a lot of achievements to himself, and he has a vast experience of 20 years in cardiac anesthesiology, and his areas of interest are pediatric and cardiac anesthesia. We're delighted to have you, sir. You can introduce our last speaker for the day.
Thank you, Dr. Anupma. Our today's presenter is very illustrious, Dr. Nitin Chaudhary. He has worked with us as assistant professor at RML Hospital also, and is we are proud to now know him as a faculty in AIMS New Delhi. He has plenty of achievements to his credit, and he's an avid paper writer. So many write-ups and so many awards he has won, and he has more than 60 publications and 5 book chapters. That's incredible. His areas of interests are pediatric anesthesia, obstetric anesthesia, and simulation anesthesia. May we have our Dr. Nitin Chaudhary for his presentation.
Thank you, sir, for your kind introduction. A very good evening to everyone. At the outset, I would like to thank the organizer for giving this wonderful opportunity to be a part of Appec 2025. And it's always a pleasure to be a part of it. And I have been lucky to be associated with Appec right from its time of inception. So here I am, and today I'll be talking on a very important topic, which we routinely see in our ICU as well as in the perioperative period, even in our wards. So it is regarding the electrolyte imbalance, and we'll be strictly adhering to sodium and potassium. So as we all know that sodium is the most abundant positive ion in the extracellular fluid, and it is a major determinant of the plasma osmolarity. You can have a look at the formula of the plasma osmolarity, and when you look at it, sodium forms a very important and a large component of the serum osmolarity, of the plasma osmolarity, right? So that is why any impact on the sodium concentration will have an impact on the plasma osmolarity. So that is why it becomes very important, and that is why any disbalance in the sodium levels will impact all the cellular system of the body. So the total body sodium content is 4000 millimoles, and the concentration gradient between the intracellular and the extracellular compartment is 1:15. So it's primarily a extracellular ion of the body. And the sodium plasma concentration is 135 to 145 milliequivalents. It's important to know the values, because only then that you can make out a decision whether you have hyponatremia or do you have a hypernatremia. The lay requirements are significantly higher in case of the neonates. That is, those with a gestational age of less than 32 weeks require higher, that is 3 milliequivalents per kg per day of sodium. At term, it brings down to 2 to 3 milliequivalents, and an adult requires roughly half the dose, that is 1.5 milliequivalents per kg per day of sodium. So the change in the osmolarity is primarily regulated by 3 mechanisms: That is your thirst regulation, which is by the osmoreceptors which are present in the hypothalamus. Then you have the ADH secretion, and lastly the renal concentrating or the diluting mechanisms. And roughly around 99.5% of the sodium is reabsorbed by the kidneys. So coming to the electrolyte imbalance, that is hyponatremia, and then subsequently we'll be talking about hypernatremia. So by definition, hyponatremia is when the plasma sodium concentration is less than 135 milliequivalents, and depending upon the concentration, they can be classified into three types: mild, moderate, and severe. That is 130 to 134 to 130 is mild, 120 to 130 is moderate, and anything less than 120 milliequivalents per liter will fall into the category of severe hyponatremia. So in case the patient has got moderate to severe hyponatremia of acute onset, it would have a very significant impact on the perioperative morbidity. So you need to understand that not only the value, but also the history, as in whether it's an acute onset or it's a chronic onset, will also have implications with respect to your perioperative outcomes. So hyponatremia can be broadly classified into three categories: isotonic, hypertonic, and hypotonic hyponatremia. So it is the hypotonic hyponatremia which is a true hyponatremia, which we'll be subsequently discussing. Coming to the isotonic hyponatremia, it's basically an artifact of measurement because of the elevated protein or the lipid levels in the patient, and it does not require any treatment. Similarly, hypertonic hyponatremia is also because of the presence of osmotically active molecules, that is in case of the sugar or mannitol in the extracellular fluid. So that is why it becomes important to see for the serum osmolarity. So the serum osmolarity will help us to distinguish between these three types of hyponatremia and find out whether it's a true hyponatremia or not. The hypertonic hyponatremia, or the true hyponatremia if I want to say, based on the extracellular fluid volume, can be classified into three types. So you have hypovolemic, you have euvolemic, and you have hypervolemic. So first you have the serum osmolarity, next will be the ECF volume, and lastly will be the urinary sodium, which will further help you to come to the diagnosis of the cause for hyponatremia. So that is why these three big things become very important when you are dealing with a case of So coming to the hypovolemic hyponatremia, now when we look at the physiology, the sodium and water both are lost from the body. However, the sodium loss is greater in comparison to the water. The causes can be renal as well as non-renal, as already mentioned. And the treatment will be that you want to replace the extracellular fluid volume by using normal saline, so that your sodium and water both are replenished in the body. Coming to the euvolemic hyponatremia. Now, in case of the euvolemic hyponatremia, the total body water increases. So the body sodium content becomes less, relatively less. In the same way as that happens in a pregnant female, you have dilutional thrombocytopenia, and all the plasma volume increases. So similar, it's somewhat similar to that the water has increased, the sodium content has remained the same as it was before, so there will be a dilution of the sodium concentration, resulting in hyponatremia. The causes could be SIDH, or they can be pseudo-hyponatremia syndrome and other causes as already mentioned. And the treatment is basically fluid restriction, because the moment the extra fluid is out of the system or water is out of the system, your sodium will reflect correctly in your lab reports. Then we have the hypervolemic hyponatremia, wherein there is an increase in the sodium and water content of the body, but the water content is greater as compared to the sodium. So it reflects as hypervolemic hyponatremia. This can be seen in case of a fluid overload or the congestive cardiac failure, nephrotic syndrome, TURP syndrome. So all these precipitate as the hypervolemic hyponatremia. The treatment is primarily the management of the underlying pathology that is there, salt and water restriction and diuretic. So this is a small flowchart that will help you to understand better how the hyponatremia happens in the body, how to diagnose it, and how to find the various types of hyponatremia. So the first thing you look into is the serum osmolarity. So the serum osmolarity is low, that means it is a true hyponatremia. Next thing will be your volume status. because that will help you to understand whether it is hypovolemic, whether it is euvolemic, or it is hypovolemic. Once you are done with that, then you look into the urinary sodium. So depending upon whether the urinary sodium is high or low, you would get to know the various diagnoses coming under the subheads. So signs and symptoms of hyponatremia are primarily defined by firstly the magnitude of hyponatremia, that means the absolute value of the serum sodium concentration, and secondly the rate of fall of the serum sodium, that means whether it's an acute event or it is a chronic hyponatremia as you see in the geriatric patients. So usually the symptoms and the signs will precipitate when you have a serum sodium concentration of less than 125 milliequivalents. Primarily the symptoms are neurological to begin with, and later on you might have cardiac symptoms also. So in case of chronic hyponatremia, the symptoms may still be absent in even despite having a serum sodium concentration of less than 120 milliequivalents because of the compensation that has happened in the body. So when you're talking about the symptoms, they could be anorexia, they could be nausea, lethargy, muscle cramps, mild cognitive or gait impairment, seizures, coma, respiratory arrest, brain herniation, mounting to death of the patient. So the treatment has to be tailored as per what is the requirement or what is the etiology of hyponatremia. So you have to see whether it's the intravascular volume status which needs to be replenished, or whether you have excess of fluid in the body, the chronicity of the onset, and the presence of symptoms, whether you need to treat or not, or can we just observe and see where the patient is going. So in case of chronic hyponatremia, that means if either you know the duration, that means it's more than 48 hours, or of an unknown duration. In that case, you should cautiously treat hyponatremia because the cerebral compensation has already happened for this hypoosmolar state. Now, if you try to be overzealous in correcting this hyponatremia, this will result in the cerebral water loss and osmotic demyelination. So what we call as the central pontine myelonesis. So that will happen. So in case of chronic hyponatremia, do not be too aggressive in your management. So hyponatremia can be asymptomatic. Asymptomatic is usually when you have the sodium concentration of more than 120 milliequivalents, and in such cases you should go by a slow correction technique. In case there is a true volume depletion, you replace it with the help of saline. If there is a SIDH or hypovolemia, in that case you will restrict the water. Fluid overload is there, then again salt and water restriction and diuretics. So depending upon whether it is a hypovolemic, euvolemic, or hypovolemic hyponatremia, you will go by your management. In case it has a symptomatic hyponatremia, that is you have a serum sodium concentration of less than 120 milliequivalents, that is when you need to go more aggressive. And there you will institute special therapies like hypertonic saline, that is 3% sodium chloride solution. And the rate of correction, however, need to be closely monitored when you're giving this correction to the patient. So you start with 3% saline initially at a rate of 1 ml per kg per hour. The goal is to increase your serum sodium concentrations by 1 milliequivalents per liter per hour for the initial 3 to 4 hours. You keep checking the electrolytes every 1 to 2 hours. You should be doing that, and you modify the infusion rates so as to ensure that the serum concentration of sodium is not increased by more than 10 milliequivalents in the initial 24 hours. So if you think you're being too overzealous in your correction, you need to slower your infusion rates, because a sudden change in the serum osmolarity can result in cerebral pontine demyelination. In case of an emergency setting where you have the patients presenting with cardiac symptoms, in that case you can give a bolus of 100 ml of hypertonic saline, and then you aim to acutely increase the sodium concentration by not more than 2 to 3 milliequivalents per liter. In case there is no improvement in your neurological status despite giving this bolus, you may repeat this bolus once or twice more. However, take an interval of at least 10 to 20 minutes before instituting these boluses again to the patient. Now, after this, the treatment should be continued as for a moderately symptomatic patients. That is, your goal will be to achieve an increase in the serum concentration of sodium by not more than 10 milliequivalents per liter in the initial 24 hours. The serum the electrolytes and the osmolality should be checked after a few hours, and the fluid input and output should also be carefully monitored, and the patient should be reassessed regularly for any new sign or symptom that might come in the patient. So how do you calculate your sodium deficit? Only then can you replenish it. It's not that you will take any amount of fluid and transfuse. You need to understand what is the deficit. So first you need to calculate that. So to understand the sodium deficit, you need to have the total body water, the desired sodium that you want to achieve in your patient. For example, you want to increase by 10 milliequivalents in the initial 24 hours. So that could be the desired. If you have a patient with 115 milliequivalents, so your desired can be 125 and the present will be your 115. So depending upon these values, you will get to know your sodium deficit calculation. Now, how do you institute? How will you give this? How much fluid has to be given to the patient? So the change in the plasma sodium. So you have the infusate sodium per liter minus the serum sodium divided by the total body water plus 1. So this will help you to understand how much amount of fluid has to be given to the patient. So it becomes important for you to calculate the sodium deficit, and we will just understand it with this example that you have a female, she's weighing 60 kgs. She has come up with altered sensorium. You made a diagnosis of hypoosmolar hyponatremia, and the serum sodium concentration at this point of time is 120 milliequivalents. So firstly, you will try and find out what is the sodium deficit. So the sodium deficit is found to be 300 milliequivalents per liter. Now you have got your hypertonic saline, and a hypertonic saline has got a composition wherein the sodium is 513 milliequivalents per liter. So how much ml of hypertonic saline would you like to give so that you can make a deficit or a correction of 300 milliequivalents? So that comes down to 585 ml. Now this has to be given over 24 hours or 20 hours. So you would divide this fluid by 20 and you will get to know the exact rate of infusion that comes down to 29 ml per hour. So now how as an anesthetist, so this we talked about more of the medicine as to how would you treat it, how would you correct it, how it can precipitate. Now coming down to your anesthetic implications, that what can happen during the perioperative period. So if you have a sodium plasma concentration of 130 milliequivalents, it is safe, you can very well go ahead with the surgery of the patient. So we do say the value is 135 by 145, but any value more 130 or more is considered to be still safe, and you can very well go ahead with your elective surgeries also. Okay. However, in case if it is less than 130, in case the surgery is also elective, you are required to treat it before going ahead with the surgery. What happens to your different measurements with respect to hyponatremia or the physiology is that with hyponatremia, it precipitates as a decrease in the minimum alveolar concentration, and post-operatively the patient can present with agitation, confusion and somnolence. So you can have a more the recovery can be delayed basically, right? So you can have a delayed recovery or you can have a emergence delirium also in these patients. So patients undergoing TURP, they absorb significant amount of water from the irrigating fluid, and therefore they are of high risk of development of water intoxication, right? So that in those patients, you might have to be very vigilant with respect to your hyponatremia, and they may present with signs of hyponatremia, and those signs and symptoms can help you to diagnose early onset of TURP syndrome and treat them accordingly. Now coming to hyponatremia. So hyponatremia was anything less than 135. So hypernatremia will be anything more than 145 milliequivalents per liter of sodium will result in hypernatremia. So the major mechanism is either you have an excessive loss because of the inadequate compensatory intake, or there's a lack of ADH, there's an administration of the exogenous sodium or an impaired thirst mechanism that can also result in hypernatremia. So hypernatremia again can be of three types. It can be with low sodium content. It can be hypernatremia with a normal body sodium content and hypernatremia with increased body sodium content. So the clinical features will be altered mental status, lethargy, irritability, seizures, the patient can throw, there will be hyperreflexia and spasticity. So again, similar to hypernatremia and hypernatremia also you need to again look into the three factors. Firstly, the volume status, then the urine osmolarity and the serum sodium concentrations. These will help you identify which type of hypernatremia is patient suffering from. So just like the previous chart for hyponatremia, we have a similar chart for hypernatremia also, wherein the volume status will help you to define whether it's hypovolemic, hypovolemic or euvolemic, and then the urine sodium concentration will help you to define the etiology or coming to a diagnosis of what is the cause for this hypernatremia. So the treatment has to be tailored depending upon the intravascular volume status. The corrections should be done slowly over the next 2 to 3 days. The plasma sodium concentration should be lowered by 0.5 milliequivalents per liter per hour with not more than 12 milliequivalents in the 24 hours. Rapid correction can result with seizures or even permanent neurological damage to the patient. So you need to be very careful when you're dealing with either hypo or hypernatremia. So increase and decrease both has to be slow and steady. So again, you will first see for the fluid deficit calculation using this formula, so you know exactly how much. So depending upon the hypovolemic, euvolemic or hypovolemic, you can go for the management of the patient. So in case of a hypovolemic, you would give fluid, you would give water deficit. So water deficit can be corrected using 5% dextrose or even 0.45% of sodium chloride solution. In case of euvolemic, you could use again the same fluid and enteral feed just to replace for the deficit and the ongoing losses. And in case you have a hypovolemia, so you want to get rid of the extra water, so in that case you can go for things like furosemide along with stopping any exogenous administration of sodium to the patient. So lastly, you have the anesthetic implication of hypernatremia also. So hypernatremia results in increased MAT for the inhalational agents. Hypovolemia, if there, in that case, you can have exaggerated vasodilatation and cardiac depression, which can precipitate as severe hypertension and hyperperfusion to the organs. Then decrease in the volume of distribution of the drug can be there in case you have a hypovolemic hypernatremia. So this can result in decrease in requirement of the IV induction agents. If there's a decreased cardiac output, in that case, an enhanced uptake of inhalational anesthetic would be there. Elective surgery should be postponed in patients who have the hypernatremia, that is, any value of more than 150 milliequivalents per liter. You should first correct it before taking up these surgeries. And both water and isotonic fluid deficits should be completely corrected before taking these patients for surgery. So now we'll quickly jump on to the next electrolyte or the last electrolyte, that is potassium. So it is a major intracellular cation with a value ranging between 3.5 to 5.5 milliequivalents. So coming to hypokalemia, which is the first disturbance with potassium that we'll be discussing. So if the plasma potassium concentration is less than 3.5 milliequivalents per liter, it is said to be hypokalemia. However, the plasma potassium is a poor reflection of the total body potassium. So if you have hypokalemia, you may still have a normal or a low or a high total body potassium. So they say that in case there is a decrement of 1 milliequivalents per liter of the plasma potassium, the total body potassium deficit can be approximately 200 to 300 milliequivalents. So the causes can be depending upon the mechanism. It can be an inadequate intake. It can be the loss through the gastrointestinal route. There can be an excessive renal loss of potassium, and there can be a shift of the potassium from the extracellular to the intracellular compartment. So all these broad mechanisms can have the hypokalemia as a subsequent consequence. So coming to the clinical features, so if you have the serum potassium more than 3 milligrams per liter, the patient would be asymptomatic. Once it crosses or it falls below 3 milligrams per liter, that is when the cardiovascular symptoms would arise. So in ECG, you can have a T wave flattening, you can have white QRS complex, there can be a prominent U wave, ST depressions can be seen, an increased P wave amplitude followed by prolongation of the PR interval. So increased myocardial cell autonomicity can be there, which can compound to arrhythmias. You may have decreased cardiac contractility and the arterial blood pressure can become more labile. So primarily you can have a cardiac instability because of hyponatremia. Clinically, the patient can have skeletal muscle weakness, there can be tetany, cramps, ileus can be there. In case of your renal system, the patient can present with polyuria, increased ammonium production, increased bicarbonate reabsorption, and hypochloremic metabolic alkalosis can be there. Metabolically, there can be negative nitrogen balance or encephalopathy in patients with liver disease. Hormonally, you can have decreased insulin secretions and decreased aldosterone secretions. So now once we know the diagnosis with respect to it, we can go with the treatment. The treatment is primarily that you want to correct the depletion of the plasma potassium. So the degree of potassium depletion and the underlying cause will define the treatment that you're going to institute. It will consist of giving potassium replacement, correcting alkalosis, and removing any offending drug which can cause hypokalemia to the patient. There is no urgent need for the potassium replacement therapy in case you have mild to moderate hypokalemia. So anything between 3 to 3.5 milliequivalents, you need not be too overzealous in correcting it unless the patient is having some cardiac issues or the symptoms are there which can be detrimental to the patient's health. If hypokalemia is profound or is associated with life-threatening signs, in that case, potassium should be administered intravenously. And potassium is usually replaced as the chloride salt because coexisting chloride deficiency may limit the ability of the kidney to conserve potassium. So your therapeutic goals will be definitely to correct the deficit, plus you avoid any ongoing or minimize any ongoing losses, and lastly you will like to prevent any life-threatening complications because of hypokalemia. So it is advisable that if you can go by the oral route for corrections, go by that. But in case the patient has got severe hyperkalemia, the patient is showing cardiac symptoms or arrhythmias, in that case you will have to go by the intravenous route only. You need to understand that the plasma potassium is not a true reflection of the total body potassium deficit, which can be very high in comparison to the plasma concentrations. And avoid using dextrose containing fluid because it tends to shift the extracellular potassium in the intracellular compartment. So you should need to know when to treat. So if you have 3.5 to 4 milliequivalents, in that case, just a dietary modification can suffice. If it is 3 to 3.5, you need to be careful. If it's a high-risk patient, then yes, you need to be aggressive in your treatment. And in case it is less than 3 milliequivalents, a definite treatment is surely required. So the treatment can be either you correct the precipitating factors that could result in hypokalemia. In case of mild hypokalemia, you can just give a intravenous potassium chloride infusion. In case of severe hypokalemia, potassium chloride infusion has to be started. You also do a continuous potassium ECG monitoring, and if it is high life-threatening, you can give bolus of potassium chloride solution also. But again, you need to be very careful and very vigilant when you're giving boluses. So as we said that potassium given orally is the most safest of all the routes of administration, but that can be only used in case you have mild to moderate hypokalemia. In case it is severe, then you will definitely have to institute with the intravenous route. And for each 15 ml of oral solution, roughly 20 milliequivalents of elemental potassium is given to the body. Coming to intravenous potassium is more for the severe symptomatic hypokalemia, wherein you do require a continuous ECG monitoring with frequent serum potassium estimations. Rapid IV correction may cause dangerous hyperkalemia, so go slow and steady. Be very vigilant when you're doing it. Do not mix with the dextrose containing fluids because it can again result in uptake of potassium from the extracellular to the intracellular compartment and can further aggravate the hyperkalemia that is existing. So if it is 10 ml or 50% sodium chloride, potassium chloride, you have roughly around 20 milliequivalents of potassium. So how long should you continue your intravenous potassium? So it should be given till the cardiac rhythms have returned to normal. Should not exceed anything beyond 8 milliequivalents per hour via the peripheral vein. In case you have a central venous catheter, you can give faster replacements. However, it should also not exceed more than 20 milliequivalents per hour. Again, serial monitoring of serum potassium is very important along with constant monitoring of the ECG. So it's a common perioperative finding, and whether to go for an elective surgery is usually based on the limits that in case if it's anything beyond three and more, in that case you can go for elective surgery. And however, in case it is a severe hypokalemia, then you need to treat the patient before going in for the surgery. It could be anything. It could be hypo, it could be elective as well as emergency surgery. So you need to correct before you're going in for your surgery. Next, we come down to hyperkalemia. Hyperkalemia is when the serum potassium is more than 5.5 milliequivalents. Okay, this is very lethal and this can manifest like dysarrhythmias, conduction abnormalities, and even cardiac arrest can happen in case the patient has got hyperkalemia. Causes can be an increased intake. There is failure from the side of the kidney to excrete excess potassium from the system, or there can be an extracellular shift of the potassium from the intracellular compartment to the extracellular compartment. Symptoms would be that there can be skeletal weakness, there can be cardiac manifestations, which would be because of the delayed depolarizations. Contractility, however, is well preserved, and hypokalemia, hyponatremia, and acidosis accentuate the cardiac effects of hypokalemia. So these are mild, moderate, and severe cardiac manifestations. So you can look at the ECG, and subsequently with increasing severity, new ECG changes will happen. So this will help you in finding a diagnosis or making a diagnosis of hyperkalemia. So the treatment will be primarily that you want the serum sodium, anything more than 6 has to be treated. You want to have membrane stability, you want the potassium to be shifted into the intracellular compartment, and you want to promote the sodium loss from the kidneys also. So you can have various mechanisms, and depending upon that, you can give the drugs to the patient. You want to antagonize the cardiac toxicity, that means you want to have a more membrane stability. In that case, you can go for calcium chloride solution. Intracellular shift of potassium can be achieved with the help of your GI drips. Increased renal secretion can be attained if you give diuretics or Lasix to the patient. And other routes of potassium elimination can also be taken into considerations, such as the fludrocortisone or the intestinal resin exchange, and hemodialysis is the last resort when you are not able to control your serum potassium levels. So anesthetics considerations will be no surgery, be it elective or emergency, should be taken up in case the patient has got hyperkalemia. ECG changes should be, you need to monitor these patients till the serum potassium levels do not come to the normal values. Succinylcholine is absolutely contraindicated because the moment you give succinylcholine, the serum potassium will further aggravate, and this can result in catastrophic events. Avoid using fluids which have got potassium in case you already have a patient who's hyperkalemic. Avoid metabolic or respiratory acidosis. Control ventilation with mild hyperventilation, and increased sensitivity to the NMDA receptors has also been seen in these patients. So with this, we come to the end of the talk on sodium and potassium electrolytes. In case you still have more queries, and you are free to ask me right away, or else you can very well mail me on my email ID, that is drnitinchaudhary@yahoo.in. I'll be very happy to answer to your queries. And before I sign out, I would again like to thank the organizers for giving me this wonderful opportunity to be here on this platform. Thank you so much. Thank you.
Thank you, Dr. Nitin, for this short and crisp presentation, covering both the theory part, the practical part, the anesthetic part, and how to make diagnosis, how to take a decision to treat. This was a nice, good, small presentation. If there are any questions, they may please be had
No,
now.
no questions, sir. No questions are there.
Oh. In that
Thank you
case,
so much, sir.
thank you.
Thank you, Dr. Nitin.
Thank you, ma'am.
Wonderful
Thank
talk.
you.
Thank you, Nagpal, sir.
Thank you, Dr. Anupma. Thank you, Dr. Nirja, for
Thank you,
remembering
sir.
me. Thank you.
And thank you, sir, for spending time on a weekend. Always lovely to have you.
Thank you.
So, so with this, we come to the end of the session for today. And we'll be flashing the 10 MCQs which are there at the end of the day and which you can answer. And the winners will be announced later. Can we have the questions?
Madam, we'll share question in delegate WhatsApp group.
Okay. So questions will be shared in the delegates WhatsApp group. So we wind up the session for today. We hope you learned a lot from today's session. See you tomorrow again for the last day of Appec. That is the day on Sunday. Thank you so much for logging in. Have a great day.